Good morning, everyone. We will be starting very shortly, so please take a seat and make yourself comfortable. Where's Arvind?
Introduce ourselves and I'll just sit down.
Say that again.
We'll just introduce.
Or you can just stay here. It's just... We're good. All right. Good morning, ladies and gentlemen. My name is Tariq Al-Sayed, and I'm a pediatric cardiologist here in Pittsburgh.
Good morning, everyone. I'm Anita Saraf. I'm an adult congenital cardiologist here at University of Pittsburgh as well.
All right. I want to welcome you today to the first Fontan Kreutzer conference held here at the prestigious University of Pittsburgh Club. I'm delighted to see many esteemed colleagues, eminent surgeons, esteemed academicians, dedicated healthcare professionals, and passionate medical students today gathering for this milestone event. Just as the world eagerly watched the climatic France-Argentina football finals or soccer finals, we convene today to celebrate two pioneering surgeons from these very nations who crafted this life-saving procedure. Dr. Guillermo Kreutzer of Argentina. Welcome, Dr. Kreutzer. And Dr. Francis Fontan of France, much like the final contenders of the world's most loved game, brought together a unity of purpose, skill, and dedication in the face of adversity. These two visionaries, driven by their commitment to saving lives, developed the Fontan Kreutzer procedure, which is a game-changer procedure in the world of cardiac medicine. Their groundbreaking work has given countless children born with single ventricle congenital heart disease a chance to lead healthier and fuller lives. Much like in football, where each pass, each strategy, and each goal brings the team closer to victory, in the realm of medicine, each discovery, each invention, and each innovative procedure brings us closer to our goal to improve human lives. Just as France and Argentina displayed unity within their teams on the field, we as members of the global medical community demonstrate unity in our pursuit of progress, innovation, and betterment of humanity. As we move forward into this exciting conference, let us remember the unity and collaboration that the Fontan Kreutzer procedure represents. Today, let us strive to work together, learn from each other, and unite our efforts to better serve humanity. Enjoy conference, make the most of the insights and experiences shared, and remember, we are all players on the same team with a common goal of saving lives and improving the quality of life of patients with single ventricle. Together, we are more powerful than we could ever be alone. Thank you, and let's have a fruitful and successful conference.
Thank you, Tariq. It is my great pleasure to introduce to you Dr. Jacqueline Kreutzer as our keynote speaker at the inaugural Fontan Kreutzer Symposium here in Pittsburgh. Dr. Kreutzer is the professor of pediatrics and the division chief for cardiology at the UPMC Children's Hospital of Pittsburgh. She holds the Peter and Ada Rosen Endowed Chair in Pediatric Cardiology and has over 20 years of clinical experience in congenital catheter interventions and has directed the cardiac catheterization lab for over 15 years. In 2017, she was appointed the division chief and the co-director of the Heart Institute. Under her leadership and in close collaboration with CT surgery, CICU, and cardiac anesthesia, she has helped move this program forward, which is now recognized as one of the top programs in the country, according to the US News and World Report. The main areas of her academic interest include novel interventional therapies, transcatheter management of peripheral pulmonary artery stenosis, including those associated with aortopathies, cardiac catheterization outcomes research and quality improvement, as well as transcatheter valve therapies. She's board certified in pediatric cardiology and adult congenital heart disease. She has extensively lectured nationally and internationally, and has authored over 100 publications, and has a long history of commitment to teaching and mentoring students, residents, fellows, and colleagues, including myself, from the US and abroad. She has also served and continues to serve many academic committees, including the American Board of Pediatrics, Board of Pediatric Cardiology, American Heart Association, NCDR, SCAI, amongst many others, and as well as served as on editorial positions in many journals, including JACC. Please welcome Dr. Kreutzer for her keynote presentation.
Thank you. Thank you so much, Anita. That was very generous. It's such an honor and a pleasure, and welcome you all to this special conference that we're hosting today. So it's been now 50 years since the inception of the Fontan Kreutzer procedure, and there has been a remarkable evolution in the understanding of the circulation, in the changes in the surgical as well as medical management strategies that I will try to go over today. So we'll review the historical evolution of the Fontan Kreutzer procedure, different eras in the understanding, lessons learned over time, and then also look a little bit about evolving strategies to address the challenges. So we're going really, really early. When was the first time we started challenging the need for a pump, for a pulmonary pump? Because in the past, the circulation, you need a pulmonary pump to push blood through the lungs. So the first times this was challenged was in the mid-50s. Dog experiments by Rothbard, anastomosing the right atrial appendage to the pulmonary artery. And then the first true cable pulmonary shunt was done by Carlo Carlon in Italy in 1950. So there's a picture of what he did, essentially anastomose the azygos vein to the right pulmonary artery, ligated the right pulmonary artery on the other side, and ligated the superior vena cava, creating a direct cable pulmonary anastomosis with bypassing the right, partial bypass of the right heart. And then Glenn used those same Carlos technique in dogs first. And then there were other surgeons in Budapest, in Russia, among other sites. And the first patient, that was Shoemaker, end-to-end anastomosis into patients that they died. Actually, it was one of them had truncus with pulmonary hypertension, so not a very good candidate. But then Glenn was the first one who do Dr. Glenn, there's a picture of him there, a successful atrial pulmonary shunt in not atrial pulmonary shunt, a cable pulmonary shunt in a 7-year-old with transposition of the great vessels. And there's the technique he used. You can see there how it's into side anastomosis of the superior vena cava to the right pulmonary artery and ligation of the the SVC to the right connection. And then the bidirectional, Dr. Dogliotti in Italy, in Turin, left open the connection so there would be bidirectional flow into both. So that was the first published in 1961. So these were concepts of partial. You can partially bypass the right heart. Total right heart bypass, then we have to talk about Francis Fontan and Billy Kreutzer in Argentina. So Francis Fontan had done dog experiments, anastomosing the right atrial appendage to the pulmonary artery with a homograph, with a valve in the IVC, but the dogs would not survive. And he thought that the reason was that their right atrium was normal, as opposed to tricuspid atresia, where the idea was in Francis Fontan's original work is that the right atrium is thickened and it could potentially be working as a pump. So in the original study in 71, published in 71, that was the concept, the right atrium working as a pump. And independent of this work in Argentina, the total bypass of the right heart was done by Billy Kreutzer. So if we look at the original Fontan paper, you can see that there's the concept, the idea that they thought it was indispensable to put valves. So he anastomosed the right atrial appendage to the pulmonary artery with a homograph, with a valve homograph, and then put a valve in the IVC, did a direct Glenn on the right side. And the idea was that the right atrium would work as a pump. And two of those procedures were, those were the two successes. It's interesting when you read this paper, you find a few, like the early thoughts of this circulation. You can see they wrote, respiratory assistance should be stopped early because positive pressure prevents central venous return, like really, really early. Another less explicable feature of the postoperative course was that in both cases, a right or bilateral pleural effusion happened. This is not surprising. And then other elements remain unpredictable. Look at this. The hemodynamic consequence of an eventual atrial rhythm disturbance, such as atrial fibrillation or flutter. He put it already in there. Some of the issues that we later on had to deal with, clearly. Billy Kreuzer in Argentina in July of 1971, they had a very sick 3-year-old that came emergently with severe cyanosis with acute decompensation, tricuspid atresia type 1B with normally related great arteries. The Waterstone shunt had occluded and the right pulmonary artery had occluded, very, very cyanotic. And in those times, there were not a lot of options because doing a left BTT shunt would have been, you had to clamp the LPA and you had no flow to the RPA, so it would have been not possible. And the idea of doing that on bypass had not been described. So the mother begged Billy to do something for her dying child. And he said, well, I have an idea, but I have never done it before. This is very experimental. And asked her permission, and she consented for that. And he performed the atriopulmonary anastomosis and the cardiopulmonary bypass connected the right atrial appendage to the with a homograph to the left pulmonary artery, did not do a gland, but left a fenestration. So he left a 6-millimeter opening that allowed for right to left shunting, and did not put any valves in the IVC because in the mind of the team at the time was the idea was you needed a pathway to the pulmonary artery with a fenestration. So that was the first fenestration. In the second patient, they did directly harvested the pulmonary artery, which was normal and connected to the right atrial appendage. So that was presented in the Society of Cardiology in Argentina in 1971 in their conference as an operation for correction of tricuspid atresia. And then it was published in JTCVS in 1973 with a series of patients. So that's, see, I lost my arrow. The idea here was that the right atrium is not a pump. So that was a controversy that continued over the next, probably 10 years or so. There was a discussion, right atrium being a pump per Fontan, and then the Argentina, France versus Argentina. The idea is what the right atrium is, it's a pathway, it's not a pump. And then they perfected the technique because one of the problems with the right atrial pulmonary anastomosis was that it was anterior, get compressed by the sternum. So obviously that would be causing trouble. And so the idea, the next innovation was to do a posterior atrial pulmonary anastomosis. You can see here in this very old slide from the group in Buenos Aires, where from the very early 80s, late 70s, it really had understanding of the Fontan circulation. You can see how you need a wide open pathway. They had the resistance of the vascular bed, and then that the suction to the whole system was the left ventricular diastolic pressure. So that the circulation, the concept of the circulation was based on that gradient between the right atrium and the left atrium. So the next era was when the atriopulmonary anastomosis became essentially widespread, used all over the world. And then soon, because of the distensibility of the right atrium, the venous compliance, the high pressures of the venous system, and the consequences of compression on the pulmonary veins, the scar tissue formation and incidence of arrhythmias, those were all the problems started to be identified in these patients that led to really the need to develop new technologies. Around that time, Dr. Kawashima introduced a total cable pulmonary connection from the SVC to the pulmonary arteries in patients with interrupted IVC. There it was almost total because the hepatic veins were still going to the heart. But in that paper, he says, this is a proof that you don't need a pump, because this functions well and you don't have a pump, obviously it's direct SVC with the IVC flow. But you can also say, but the fact that he wrote that there is that there was still controversy about the right atrium needing to actually do have a kick function. And then the third era is when new pathways were identified that were more energy efficient. And that was very much thanks to Marc Deleval's studies on the energy efficiency of the Fontan circuit and how they proposed the lateral tunnel, the total cable pulmonary connection. It's interesting that Francisco Puga had already proposed in 1987, had already performed an extracardiac conduit as an option for patients where you could not do an atrial pulmonary anastomosis, especially if you have heterotaxy or if you have complex forms of single ventricle with atresia or common AV valves. So and that's then the era of the total cable pulmonary shunt with Marc Deleval that then got perfected by other surgeons. Aldo Castañeda proposed some changes to augment, improve the geometry of the patches of the lateral tunnel, and then the very, very important introduction of the fenestration, which had been already done by Billy in the original paper in '71, but the routine use of a fenestration as a punch within that lateral tunnel baffle with closure of a fenestration in the postoperative period or later on. And that was introduced by the Boston team with Castañeda, Locke, and Nancy Bridges. So soon it was learned that the lateral tunnel, although seemed wonderful in the beginning, you didn't have the right atrial dilation and all that, you still had significant suture lines, very, very similar to the suture lines that you see in a master procedure. So arrhythmia started to happen. And the lateral tunnel can dilate and you can get into atrial baffle leaks. So it became clear that improved options were necessary. And you can see that Dr. Carlo Marcelletti in Ospedale Bambino Gesù in Italy in 1990 introduces the extracardiac conduit. And that ended up being the preferred surgical procedure. It became preferred procedure of choice, which is what we do now. There's many studies that followed, including this one here from Lardo and Del Nido, showing the energy efficiency of the extracardiac conduit being superior to that of the lateral tunnel, and especially if there is some offset where the IVC enters to where the SVC enters, so there's no the crushing of the two flows. So when we look when we think about the evolution of the understanding of the intricacies of the Fontan-Kreutzer circulation, we have to, there are lessons learned in every of these subjects, the physiology, the pathways, we have to think about the lungs, the ventricle, and then finally, last but not least, the lymphatics, which clearly we have discovered play a key role. The understanding of the physiology, if you look back at the early slide from Buenos Aires, this is not that dissimilar to a current slide from Mark Guling in 2017, when you can see this beautiful representation in his work from Belgium, showing the venous return directly connected to the pulmonary capillary bed, the fenestration bypassing the lungs, and then the arterial return to through the systemic capillary bed and then back. And then down there, a graph showing the pressure changes from the systemic venous pressure, the pulmonary arteries, and then as you come down to the ventricle, to the diastolic pressure. And some more concepts that I think help in the understanding of Fontan physiology by Mark Guling is this really nice graph that tells you in the paler tones, that would be like an ideal Fontan. This has the pressure and the y-axis, and you can see the systemic and systole, the high pressure, arterial, and then how it drops through the systemic capillary bed, the systemic venous return, pulmonary vascular resistance, and then down further to the ventricular and diastolic pressure. And how the Fontan starts to fail, what you see is that the PVR tends to squeeze a little bit, the end diastolic pressure goes up, and that also has a secondary effect on cardiac output. So this is a nice hourglass that shows, really a concept that in the Fontan circulation, the true bottleneck is at the level of the lungs, of the pulmonary vascular resistance. And because of that, as the pulmonary vascular resistance increases, you have a secondary effect on decreasing the preload, and that has an impact on the ventricle. So in a normal heart, a stroke volume really depends on the is not dependent on the pulmonary vascular resistance. But we know stroke volume depends on the preload. In a single ventricle, as the pulmonary vascular resistance increases, you will see that the preload will decrease, and that will have an impact in cardiac output. So there is really, it's very, very different physiology that we have to understand, and Mark Gulick had significant contributions in that regard. We have learned a lot of things about the pathways. When the new models came out, now we knew if they didn't work well, we could convert them, and you can convert them by surgery. It wasn't just the plumbing that mattered. We learned that you have to also address the arrhythmia surgery for that to succeed. We also learned that these conduits don't seem to be good forever, that they tend to the cross-sectional area narrows over time, and that needs to be addressed, as opposed to in the lateral tunnel, which is in this graph there in the red, that they tend to dilate, the conduits don't, and indeed the cross-sectional area tends to decrease. We also have learned that the other energetics can be measured and quantified through 3D flow data derived from computational flow dynamics and 4D flow magnetic resonance images. There's been great advancements in that helps us understand the dynamics and hopefully help design optimal surgical pathways. We have learned that pulmonary artery stenosis is not good, that needs to be aggressively treated because any source of unnecessary gradients need to be eliminated, even in small. And that the routine use of fenestration is very helpful in the postoperative period and can have impact long-term. And if the patient needs a fenestration, we can do it in the cath lab, we can create it. There are different techniques, we can improve that, we can perforate through Gore-Tex, we can use the bovie to create holes, and there's lots of ways of doing that. We have learned, we used to think when I was a fellow, collaterals were really bad. We called them all then. The collaterals were, oh, we don't care anymore about collaterals. We left them all open. And now we know that collaterals do matter. So we actually, because we can actually measure them thanks to MRI, we can quantify them, and the collateral burden is an issue. And we have a lot of techniques to close them in the cath lab as well. With regards to the ventricle, obviously we have the systolic function, which we can address by echo and MRI, and we know that over time it tends to progressively decrease in patients with single ventricle. But the key feature in the circulation is really also the diastolic function, which can be a little harder to diagnose. And diastolic dysfunction tends to be very prevalent as years go by. And the table here shows triggers to diastolic dysfunction and the level of evidence that support in literature review. So there's lots of triggers to diastolic dysfunctions in these patients that are very important to address. We have understood the evolution of a patient with single ventricle as they go from the volume loaded state, illustrating the pressure volume loop in green, to go with Fontan circulation, where they become a volume underloaded, underfilled, volume contracted condition. And so we have understanding, and you can see how over time, as the end diastolic pressure increases, the curve, this is the red one, things get worse. With regards to the hemodynamics, we have learned that they do matter in the original Chaussou's criteria. Many of these are not applicable today. You can see, okay, arrhythmias, we have treatments, we have pacemakers and various things. Age, there's a lot of these that are not really so valid, but the hemodynamic parameters continue to be. I mean, pressure of over 15, low pulmonary vascular resistance, those continue to be key points. There's still controversy, however, on whether or not you need to do a cardiac catheterization in every patient prior to a Fontan procedure, although in Pittsburgh, we do. We know that critical clinical data can be found through cardiac cath, and that surveillance cath after Fontan can be very, very helpful to address these problems. And if the physiologic details that can be obtained are multiple and very, very important. We know that resting Fontan pressures do matter, and that the higher pressures are associated with worse outcomes, and that the low cardiac output obviously can have variable income, but the PVR is very important to measure, as we have therapies that can improve them. We have learned, the cath lab is truly an incredible physiologic lab for these patients, where we can change and test conditions. We can test the fenestration if they have one to see, you know, the health of the Fontan circulation, to see whether they have or not veno collaterals. We can do pulmonary hypertension study to see the candidacy for phosphodiesterase inhibitors and therapy specifically for PVR. We can do a fluid challenge, and Brian Goldstein brought that to our institution as a routine use. Every Fontan patient, we now do fluid challenge to look for occult diastolic dysfunction. And this, you know, really has been very useful to understand what's going on, where the bottleneck is in these patients, and sometimes it's more of a ventricular problem, but sometimes it's more of a PVR problem. And we sometimes can do pacing and do strategies in patients who have problems with AV conduction. The PVR we know is key. The lungs over time do change. And there are some pathologic evidence that there are histologic changes in patients with Fontan, that they do lose some of the integrity of the media at pulmonary artery level, and there is a progressive increase in pulmonary vascular resistance. With the lungs, we have also learned that you need hepatic factor. And although in the Fontan procedure, usually you do have hepatic factor, this typically, it can still happen if you have abnormal distribution of the hepatic factor. That can happen in heterotaxy. Pulmonary arterial malformations are obviously more common after Kawashima or a Glenn, but they could happen in a Fontan, especially in patients with heterotaxy that may have abnormal connections or portosystemic shunts. Now, they tend to go away when you do the Fontan and you bring the hepatic factor back, but there are some patients who may have portosystemic shunts, whether they are congenital in heterotaxy or other, and those can be treated in the cath lab. They're a little hard to diagnose. You may have to balloon occlude the IVC and inject below to see the connection from the IVC flow into the portal system, balloon occlude it, and then close it, and then tend to go away. It is possible also to reroute the hepatic flow. We could do it surgically, but we can also do it in the cath lab thanks to really good cover stents that we have. And this is something that we can do. And this is just an example of a patient where we rerouted the hepatic flow using these Gore cover stents. And this is a kid who was desaturating to the 60s. And then a year later on a follow-up cath, the arterial saturation was 92 after we redirected hepatic flow back to the right lung, which was where the AVMs were. Now, over time, we have learned that the lymphatic circulation plays a key role. It is profoundly affected by high venous pressures, and that's essential, the essence of the Fontan-Kreutzer circulation. So every Fontan has some degree of dysfunction. Dr. Marlis Witte, who is a famous lymphatic expert, told my brother, Christian, your father devised the procedures basically creating right heart failure. And you guys never thought before of the lymphatic circulation. You're just finding it now. He's like, how come? And so you can see that the lymphatics, as opposed to in the normal heart, the lymphatics are formed. The lymphatic fluid is created in a circuit that is at higher pressure than even the circuit where it's draining into. So it's because it's created in the lungs, and then you can it's supposed to drain at a higher pressure in the venous system. So it's a real problem with lymphatics. We have to recognize the incredible job of Yoav Dori and the group in CHOP to really help us understand lymphatic circulation and all the sources of dysfunction, which can explain almost every of the non-failures of the circulation, including plastic bronchitis and protein-loosen enteropathy and effusions, and even may have an effect on the lymphatics at the level of the heart function. And as the pressures go up, and you can see the different sources of leaks in the beautiful graphs from the Yoav shared with me. So in terms of outcomes, in the early publications in 1990, when Fontan and Kirkland published the perfect Fontan results, you can see that the hazard function, the instantaneous risk of death at each moment after the operation, had a rapidly declining at the early 6-month period curve, and then stabilized, but then further continued attrition after 6 years. And they concluded that this was a very much a palliative procedure. Now, outcomes have clearly changed over time. And although if you look at the overall and you take in this experience of 40 years after the Fontan operation, over 1,000 patients, you can see that at 30 years, the survival was 43%. However, there's a huge era effect. So it's very different when you look at the era after 2001, where the survival at 10 years is more than 90%. And further studies like a meta-analysis on Fontan outcome here, you can see that it's over 80% at 20 years. So things have changed. We have gone better over time. Large studies such as the Australian and New Zealand registry can show the survival at age 30, 90, and 80% at 40 after Fontan procedure. So there's remarkable improvement over the years in how these patients have done. Despite that, we talk obviously a lot about their problems, but that's how we want to be coming with solutions to help them. So the evolution over time, you can see here from a paper from Boston and a paper from Job. In perioperative survival of Fontan surgery in the paper from Boston, gradual attrition occurs predominantly from thromboembolism, heart failure related, and sudden death. And you can see at 20 years being 82% survival. And in the CHOP experience with a lot of hypoplast there, 74% at 20 years. So it is estimated that patients operated on today may have a 30-year survival in the order of more than 80% in the current era. And that about over 70,000 patients may be alive worldwide today with a Fontan-Kreutzer procedure. And that this population is just expected to expand over the next 20 years. So we need to get ready for taking care of all these patients. So while there are strategies, truly there are lots of areas that we can focus in terms of strategies, medical strategies. Most therapies that we have for heart failure, for addressing the different areas, whether you're talking about the pulmonary vascular resistance, the systemic ventricular function, atrial arrhythmias, a lot of these therapies are extrapolated from other diseases. So studies that are focused on Fontan circulation are going to be essential. Assure that the strategic planning from the whole course of the child's life is thought to preserve PVR and ventricular function. And important active surveillance, protocolized care to make sure that we address potential therapeutic targets early in time. We may try to decrease the population of Fontan patients by improving the surgical techniques on every patient that has, is a candidate for a biventricular repair can have one. Multidisciplinary single ventricle programs and collaborative research such as the Fontan Network, FORCE, and others that truly help us understand at a collaborative manner, increasing the number of patients, how to care of these patients at national and international level. Lymphatic directed therapies will be critical on how to decompress the lymphatics or medications that actually treat lymphatic dysfunction, which we don't have any. And a Fontan pump that has been brought up by many as a potential solution in the future. So in conclusion, the Fontan-Kreutzer procedure was a paradigm shifting advancement in the care of patients born with single ventricle. Challenges remain major. Novel specific therapies and approaches are really needed to tackle the many intricacies of the circulation. Thank you very much. And I end with a Dali painting that shows you how you need to have an open mind when you're analyzing a really complex scenario like the Fontan-Kreutzer circulation. Thank you. Questions?
Yeah, questions. Can you put up the questions? Thank you, Dr. Kreutzer, for an amazing talk. We will now take questions from our online audience as well as the audience present here. If you could either raise your hand and then or post on to the Zoom link that you have, we will get your question and ask them here.
There's another opportunity for questions later on too, and I'm here, so we can always do that later.
Sure. Let's see if there's anything.
There's a question there. Why did Kreutzer refuse to sew in valves at the level of the IVC? Why did you refuse to do that? I think the answer was because he didn't think it was necessary, right? Because he didn't think the right atrium was a pump. Yeah. Yeah. No, you can say so. Así te oyen los de remoto.
Well, a long time ago, Dr. Luis Becu, our pathologist in the Children's Hospital, told me, Billy, when I show him the Fontan paper, the original Fontan paper, he told me, Billy, the right intro will never function as a pump. This is wrong.
All right. I'm gonna move forward. Anyway.
All right. Thank you, Dr. Kreutzer. I would now like to invite Dr. Victor Morel.
Thank you, Anita. It's a great it's a great pleasure having Billy here with us. Obviously, I think this contribution that Billy and Fontan gave us surgeons was incredible, and for all the patients. We just have a little gift for Billy, so that just to congratulate him and sort of commemorate this first international symposium here in Pittsburgh. And we would love if Billy can come up here and just take a little present that we have for you. Okay.
Excellent. Thank you so much, Dr. Kreutzer. Our next session is Living with Fontan-Kreutzer Circulation. It's my real pleasure to introduce Dr. Lauren Lorenzi. Dr. Lorenzi has a PhD in psychology from the prestigious Duquesne University here in Pittsburgh, and is the director of the Cardiac Neurodevelopmental Program here in Pittsburgh. She follows kids and families with single ventricle physiology from before birth till after the Fontan-Kreutzer procedure, and she will be talking about resilience and optimizing mental health post-Fontan-Kreutzer procedure. Thank you.
Thank you so much for the kind introduction and for the opportunity to speak today. Amazing resilience and a high quality of life are certainly described by many individuals with congenital heart disease living with Fontan physiology. However, it is also known that significant psychological challenges do exist across the lifespan, with higher rates of emotional, behavioral, and social difficulties in this patient population. And my hope today in our discussion is to encourage not only an increased awareness of the challenges to maintaining psychological well-being faced by patients and their families, but also to speak to the importance of the implementation of strategies to prevent and alleviate distress and promote resilience through consistent and integrated mental health care. There's an increasing appreciation of how psychological health can contribute to cardiovascular health and reduction of cardiovascular risk. In 2021, the American Heart Association issued a scientific statement of these relationships and encouraged greater screening, evaluation, and treatment of psychological health. I'm sorry, sir. There's substantial literature in the adult world connecting mental health and heart health. And adults with congenital heart disease, those with depression, have higher inflammatory biomarkers, higher rates of heart failure, and ultimately increased risks of mortality. Just in the CVD, mortality risk with diagnoses of anxiety actually increases by close to 40%. The mind-heart-body connection has been further explored as psychological health can adversely and immediately affect the heart, but the broader, longer-term relationship where psychological health can also positively, but also negatively affect various aspects of cardiac health continues to be unveiled, especially within this patient population. With an established understanding of the challenges that these patients and families encounter to maintain their psychological well-being across their continuum of care, we must now engage in the implementation of these strategies to prevent mental health challenges, as I mentioned. There are many contributing domains to these psychological outcomes and well-being, and these are interrelated and cumulative and certainly longitudinal in their impact. We better understand that preoperative risk factors, genetics, socioeconomic status, low birth weight, gestational age, brain dysmaturation, all of these are contributing along with cumulative morbidities and particularly parental mental health. These are more strongly associated with adverse psychological outcomes, more so than the intraoperative support techniques that maybe were previously more attributed. But there are lifelong consequences to the adversity and toxic stress that are often assumed by these patients and their families, and really generating a multidisciplinary and preventative model to support is crucial for positive outcomes. The relationship and prevalence of neurodevelopmental delay and disability in this patient population is certainly well established, and the link between psychological and neurodevelopmental outcomes is clear. This was well established in the Boston circulatory arrest study with RTJ patients, noting that neurodevelopmental difficulties in school age, notably with attention and adolescence in the realms of executive functioning and also social development or social cognition, were associated with later poor psychosocial health outcomes. Specifically, the cognitive functioning at age 8 was predictive of the psychosocial health at age 16, with attention difficulties being one of the strongest predictors. But this just speaks to the fact that neurodevelopmental impairments can be critical targets for our interventions to reduce longer-term psychosocial adversity. The psychosocial challenges that our patients face certainly morph across the lifespan, beginning in infancy and moving throughout the time periods. There are high levels of hypersensitivity to stimuli, neurobehavioral and regulatory difficulties due to so many factors of the extended hospitalizations and stressors to caregivers and patients in this kind of critical developmental period. And as we move into childhood, this can morph into more emotional and behavioral dysregulation, leading to maybe more diagnostic findings. So there are certainly heightened rates of internalizing disorders, namely anxiety, at almost sometimes upwards of 25%, and externalizing difficulties as well. We all know the heightened risks for ADHD, sometimes in various studies of single ventricles ranging between 5 and even 24% prevalence rates. The heightened rates of autism spectrum disorder diagnoses with sometimes 4 to 6 times increased prevalence rates. There are certainly parental reports of some difficult to manage behaviors and heightened aggression, opposition, or even defiance. And it's a critical time for families as they're kind of balancing the need for supports while fostering autonomy of their medically complex child. moving into adolescence in this period of independence and fostering autonomy and identity formation and the goals of socialization and peer relationships, we do tend to see heightened rates of depressive symptoms, and this is certainly linked with quality of life. There are so many contributors to mental health in this time period, but academic difficulties related to neurodevelopmental implications or learning disabilities, health-related school absenteeism, the physical limitations or activity restrictions. I swear that's probably what I speak about the most with my patients. Social anxiety or body image difficulties, parental overprotection that can linger from that infancy period, and also an ambivalence of discussing their CHD diagnosis with peers and how to kind of foster that confidence despite their medical challenges. And that transition period is also a great period for intervention as well from a mental health perspective, with this increased health responsibility and the transition sometimes from pediatric to adult congenital heart care. The psychological distress that can sometimes be linked to poor treatment adherence is certainly an area for intervention, as this is a critical time point to assure solid practices around their independence in medical care. And moving into adulthood, we again see these heightened rates of various psychiatric diagnoses, depressive symptoms really range. The literature for mental health outcomes, as you know, certainly is still broadening in this patient population. So the rates that are found are certainly expansive. However, depressive symptoms may be found in upwards of 36% of patients, anxiety from 34 to 42%. The highest rates of anxiety are more so in the realms of social anxiety and separation anxiety, potentially related to some of those kind of early experiences our patients go through in terms of separation from caregivers. Other psychiatric disorders, including various potentially heightened rates of schizophrenia are all further being investigated. But some of the risk factors certainly include poor neurocognitive functioning, loneliness, limited social support, poor perceived health status, or sedentary behavior, all of which are great areas for intervention from a mental health perspective. And we can't speak to the mental health of the patients without thinking of the mental health of the parents and the caregivers. We recognize that compromised parental mental health can lead to long-term cognitive, health-related, or behavioral problems in our patients, and the challenges that caregivers face from a psychological perspective are broad, notably post-traumatic stress and other acute stress disorders. This must be monitored for a variety of reasons. The prevalence, the critical time period during the time of early surgical intervention, when the development of attachment relationships and that parent-infant-child relationship is really broadening, and the cascading effects that this can have on families and longer-term outcomes is certainly a growing area of interest. In a review of 30 studies of the mental health of parents, and this literature is actually more broad than that of the patients, there is an understanding that the elevated risk is broad. So we're seeing 30% of symptoms consistent with PTSD. That's 3 to 4 times that of the general population in parents of children with critical congenital heart disease. 80% of parents are presenting with clinically significant symptoms of trauma, 25 to 50 with clinically elevated symptoms of depression or anxiety, and 30 to 80% of parents experiencing severe or psychological distress. A 2017 article from Boston with a cohort of 156 adolescents with single ventricle CHD undergoing the Fontan procedure was, I think, a really strong window into the implications in this patient population, as it included clinician-rated psychiatric interviews, not just parental or self-report ratings or review of depression showing in the medical record. With this particular study, there were 5 times higher rates of lifetime anxiety diagnoses, 6-time rates of lifetime ADHD diagnoses, and 65% of youth actually had some realm of a psychiatric diagnosis. So much higher numbers than we had seen before. And beyond these numbers themselves, many more will experience psychosocial stress that may not necessitate a formal diagnosis, but could certainly benefit from additional mental health support. A 2022 meta-analysis of all of this psychological functioning work did find variation in a review of children 0 to 25. There were 23 studies on anxiety, 24 on depression, and 22 on externalizing behaviors, namely ADHD in our single ventricle population. And the cumulative data does show that, or does suggest that these diagnoses are notable risk factors for patients from a mental health perspective. So what can we do? Mental health interventions are certainly warranted, and especially when emotional distress is impeding daily functioning or impacting quality of life, and certainly when it's impactful on medical care. The mental health professional availability definitely differs across institutions and certainly across communities. But we are seeing it in the literature and through some of our collaborative networks and work that there's an increasing understanding that families and patients are seeking mental health care that is specific to that of their cardiac diagnosis. Having that understanding can certainly enhance treatment and hopefully improve outcomes. So it's a continued goal to integrate mental health care into the cardiac home. So with the focus of embedding providers and psychologists into our cardiac centers, we have the opportunity to normalize emotional reactions to health difficulties and challenges. We can reduce stigma of accessing mental health care. We can improve access to targeted and specialized evidence-based interventions, improve equality in access, which is always an incredibly major goal, foster this interdisciplinary approach. There's so much overlap in the presentation of various mental health diagnoses and cardiac symptoms. So traversing that is incredibly important with full collaboration between the medical and mental health providers. And then fostering just psychologically informed care is always an important goal. There are only actually 2 studies thus far on the specific impacts of certain psychotherapeutic interventions, one with parents and one with adolescents in a group domain. There's certainly a lot still to be learned about the specific interventions and what might be most effective in this patient population. However, having kind of targeted and embedded therapists that understand the cardiac population and can use a realm of different interventions dependent on the presenting problem, it is certainly going to meet the most needs at this time. And of course, also psychopharmacology, it can be so assistive to have kind of embedded psychiatric support within an institution to have that full communication between the cardiac and psychology and psychiatric providers to optimize the implementation of psychotropic medications. There's many areas for growth in this domain as we continue to work with these patients as they move across the lifespan. But targeting psychological care and outcomes is just such an essential component of caring for our patients with congenital heart disease, specifically those with single ventricles after undergoing the Fontan-Kreutzer procedure. And increasing screening and early identification of psychological need to offer preventative care and catch these difficulties early is certainly going to improve outcomes. We always aim to increase access to evidence-based, individualized, culturally sensitive, and accessible mental health care, which is a challenge, as we've all seen, especially in the last years in the COVID pandemic, as behavioral health resources have been difficult to come by. But that's a constant goal. And sharing of resources and collaborative initiatives throughout our many networks, including the Fontan network, is going to be really helpful for moving this very targeted service forward. As we kind of unite our psychosocial support teams within heart centers and broaden relationships within our institutions, but also with schools, with communities, with families. We're going to allow for mental health to have a growing seat at the table, which I think is really critical as we continue to improve outcomes in this really amazing patient population. So thank you.
Thanks, Dr. Lorenzi. We'll take the questions at the end of the session.
Thank you. Next, we have Dr. Candace Silversides joining us. She is a professor of medicine at the University of Toronto and the chair of pregnancy and heart disease at the Miles Natal Heart Center in Mount Sinai Hospital, where she leads the obstetric medicine program as the director of cardio obstetrics clinic. She's the inaugural editor-in-chief of ACC's newest journal, JACC Advances. She also works at the Peter Monk Cardiac Center, specializing in adult congenital heart disease and echocardiography. Dr. Silverside's research interests include pregnancy and heart disease and adult congenital heart disease. She has contributed to many international practice guidelines and consensus statements. She'll be joining us virtually today.
From the University of Toronto. I'm sorry I can't be there in person today, but I do feel fortunate that I can be with you today virtually. And so I'll be talking about pregnancy in women with the Fontan operation. I thought I would start with a case. So this is a case of a 23-year-old. She's had a lateral tunnel Fontan. She's well, she's on no cardiac meds. She's had no Fontan complications. She has good ventricular function, normal ventricular function, and no AV valve regurgitation. So if she came to talk to you about pregnancy, what would you tell her? Would you tell her she's at high risk for arrhythmias, for bleeding complications, for miscarriages? Would you tell her she's at risk for all of those above? Or would you tell her that pregnancy is contraindicated in the setting of the Fontan operation? So I'm going to come back to answer these questions in a bit. But just to start off, I want to remind everybody about the unique aspects of the Fontan physiology that could be impacted by pregnancy. So Fontan physiology has a unique cardiovascular physiology to it, with both central and systemic venous hypertension. There's also non-pulsatile blood flow to the lungs. It's a preload deprived ventricle. And as a consequence of many variables, there's decreased cardiac output both at rest and with exercise. In addition to that unique cardiovascular physiology, patients may also have systolic or diastolic dysfunction. They have a propensity to arrhythmias, to thrombosis, and paradoxically to bleeding. And there also may be systemic manifestations of the Fontan operation, such as hepatic congestion or Fontan-associated liver disease, renal dysfunction, or neurodevelopmental issues. And you can envision that all these factors could be important when you add on a superimposed stress of pregnancy. So I'm going to focus on the cardiovascular stress of pregnancy, but there also is additional other physiologic stresses that may impact the Fontan physiology. But again, going back to cardiac physiology during pregnancy, there's an increased preload to the ventricle. You can envision that may be poorly tolerated in patients with significant diastolic or systolic dysfunction. There's also an increase in heart rate. As a consequence, there's an increase in cardiac output, again, that will persist throughout the pregnancy, and that may be poorly tolerated. Pregnancy is also a proarrhythmic state, in part because of the increased preload in both the atrial and ventricular stretch, but also because the hormones of pregnancy impact the action potential that may predispose women with Fontan circulation to develop arrhythmias, even if they have not had them in the past. Pregnancy is a prothrombotic state, and even outside of pregnancy, women and men with Fontan circulations are at risk for thromboembolic complications, and that risk is heightened during pregnancy. And also, there's, for many reasons, there's an increased bleeding risk during pregnancy, specifically at the time of labor and delivery. So you can envision all these physiologic changes related to pregnancy could destabilize an otherwise stable patient with a Fontan circulation, acting as a perfect storm to cause troubles. So let's talk about what actually happens in pregnancy. Before I talk about women who actually have a completed pregnancy, I do want to highlight that for reasons we don't fully understand, some women will actually have difficulty conceiving. And in fact, a significant portion of women will either not conceive altogether or have recurrent miscarriages. This is data from United Kingdom, but what you'll see here is that only 42% of this cohort actually were able to conceive and have a successful pregnancy. So even before pregnancy gets completed, there's a increased risk of recurrent miscarriages and difficulties with fertility. I'm going to present data from this study. This was a summary of all the literature, all the case series of Fontan patients who had pregnancies and their outcomes. It includes more than 250 women who had a pregnancy. And if we look at the different types of complications, I'm going to break it down into maternal cardiac, maternal obstetric, and fetal and neonatal complications. So this first slide depicts the different types of maternal cardiac complications that occur in the Fontan population during pregnancy. The y-axis shows the rates of complications. What you see if you look at the x-axis, that the most common complication is actually supraventricular arrhythmias that occur in 8.4% of pregnancies. Almost 4% of pregnancies are complicated by heart failure, and 2% of pregnancies are complicated by systemic thromboembolism. In addition to cardiac complications, women are also at risk for obstetric complications. Really, this primarily relates to bleeding complications. You can see here the blue bar, which represents postpartum hemorrhage, occurs in 14% of pregnancies. 2.5% of pregnancies are complicated by retroplacental hematomas. These can be particularly problematic in women who require anticoagulation during pregnancy. And then finally, the red bar represents a premature rupture of the membranes. If you also look at neonatal and fetal complications, these occur with increased frequency in the Fontan population. In fact, these are the most common complications you see. The blue bar represents preterm deliveries, and almost 60% of pregnancies in women who have a Fontan operation have a preterm delivery, very common. Women also are at risk to have infants that are small for gestational age. Here it reports it at 20%. And the red bar represents neonatal deaths at 5%, which is very, very high compared to the general population overall. So they're not only at risk for adverse morbidity, but also adverse fetal and neonatal mortality. One way we classify risk is a risk classification called the WHO classification or the World Health Classification. This was a 4-point classification system devised to assess pregnancy risk in women with pre-existing heart disease, with class 1 being the lowest risk or really no significant maternal cardiac risk, and class 4 being the highest risk where pregnancy is contraindicated. Women who are stable, otherwise well Fontans, are considered a WHO class 3 or a high-risk pregnancy lesion. And you can see the company they keep is with other complex congenital heart disease in terms of the risk class. However, women with Fontan operations who've had complications are considered WHO class 4, a risk category where pregnancy is felt to be sufficiently risky that pregnancy is not advised. So what makes a Fontan more high risk? Well, it's Fontans that either have systolic or diastolic dysfunction with heart failure. Those that have severe AV valve regurgitation may poorly tolerate a pregnancy if they have significant hypoxemia or refractory arrhythmias or more complex Fontan complications such as PLE. If we go back to our case, I had originally described this otherwise very well 23-year-old lateral tunnel Fontan. And what I would tell her is that firstly, she may have difficulty getting pregnant because miscarriages are common. I would have mentioned that arrhythmias are the most frequent maternal cardiac complication and something we would have to watch for. Women are also at risk for bleeding, particularly postpartum bleeding. So that tends to be something we look for. And finally, that actually one of the biggest risks is actually the risk of fetal and neonatal complications, which occur with very high frequency in the Fontan population. Now, one thing that I would also address, not related to pregnancy itself, but related to life after pregnancy, is the fact that women who've had women and men with Fontan circulation have a decreased life expectancy. So this is just study from Gerhard Diller looking at mortality in patients with ACHD lesions compared to an age-matched population. What you can see if you look at a 40-year-old with an ASD, they have a mortality that's similar to a 42-year-old in the general population, but patients who have had Fontan operations when they're 40 have a life expectancy that's similar to a 75-year-old in the general population. So certainly women may get through a pregnancy, but this has major implications for them, for their children, and for their family going forward, and needs to be addressed as well. So if we go back to our case, what happened to her? Well, she did become pregnant. At 24 weeks, she presented with her first arrhythmia ever, an IART, required cardioversion. It was started on metoprolol and low molecular weight heparin. She returned again with an arrhythmia. And in fact, she started to get destabilized at around that time. She had spontaneous rupture of her membranes, premature, like I've mentioned. Prematurity is complication of the Fontan operation. She ultimately had a non-reassuring heart rate and required a cesarean delivery. The baby was fine. However, she developed a very large incisional hematoma, required fluids, had volume overloaded, and had a very prolonged hospital stay. So how do we manage complications during pregnancy? This is my last section of the talk. Well, first of all, arrhythmias are the most common, and interatrial reentrant arrhythmias are the most common of the arrhythmias that we see. They're poorly tolerated both inside and outside of pregnancy, and they can be associated with other serious hemodynamic complications. This is an old study I'm showing you here, but just showing you that when they develop arrhythmias, patients are also at risk for thrombus, for heart failure, and for other issues that need to be addressed above and beyond the arrhythmia. This is just a picture showing that really large atrium that you see, especially with old style Fontans, and the complications of the atrial thrombus that can occur. So I think it's just really important to remember that arrhythmias may be associated with important thromboembolic complications that you need to address if you're going to address the arrhythmia with a cardioversion. And so that really highlights this first point I've listed here, that arrhythmias may be an indicator of other hemodynamic problems, so you need to go looking for them. This is, again, not unique to pregnancy. However, probably, well, not even unique to pregnancy is my second bullet, is that you should treat atrial arrhythmias promptly, try and restore sinus rhythm. I would say it's particularly important in pregnancy because you're not only dealing with a mom and a baby and you need hemodynamic stability, but it's also a prothrombotic state, and thrombus and thromboembolic complications can develop very quickly. It usually requires cardioversion in part because we don't have the full armamentarium of antiarrhythmics that we would have outside of pregnancy. So for instance, amiodarone is typically not used unless you really have to use it during pregnancy. All women should be anticoagulated specifically during pregnancy because it's a prothrombotic state, and EP should be involved because these are complex arrhythmias. Pulmonary embolus, I've already mentioned, can occur, although with less frequency than arrhythmias, in part because Fontan's a low flow state, but also because pregnancy is prothrombotic. Again, you have to go looking to make the diagnosis if you have any indication of symptoms that suggest a pulmonary embolus, and pulmonary embolus should be treated very promptly because it's very dangerous in the setting of Fontan physiology. There's variability on the use of prophylactic anticoagulation during pregnancy. I think there's some clear times where you'd anticoagulate if women have arrhythmias, if they've had a history of thromboembolic complications, if they have an atrium like the one I'm showing here that's filled with dense smoke. However, for a stable lateral tunnel or a stable extracardiac, I think there is variability from center to center about the need for routine prophylactic anticoagulation. And that is in part because there is this increased bleeding risk during pregnancy. And so you really do have to individualize and balance the risk of thrombosis versus risk of bleeding. I've already mentioned that women can also develop heart failure. It's in part because they can have both diastolic or systolic dysfunction that can predispose to heart failure. If they do develop heart failure, especially in pregnancy, look for precipitants. The classic one is atrial arrhythmias, but things specific to pregnancy like thyroid dysfunction can cause arrhythmias or heart failure, and you should look to make sure there's no other precipitant that needs treatment. For those women that develop pulmonary congestion or volume overload, please remember that you can give Lasix during pregnancy. And these women should also be followed by an ACHD specialist, ideally one who also has expertise in pregnancy and heart disease. My few last points. In general, a vaginal delivery is preferred. There's less complications than a cesarean delivery. However, there are a few instances where a cesarean delivery is indicated in women with heart disease. It's not just having a Fontan operation. However, some patients with Fontan operation will develop premature labor while on an anticoagulant, and that's an indication for a cesarean delivery because you can't do a vaginal delivery if the fetus is anticoagulated. For patients who have a vaginal delivery, not only do we do an early epidural, really make sure we do good pain management, manage volume closely, but we also assist the second stage to ensure that they don't have prolonged pushing. And finally, the last bit of management really relates to monitoring these women. You have to, because it is a preload dependent circulation, you have to be attentive that if they lose a lot of blood, it could really result in a cardiac collapse. However, you also have to finely balance it because they'll often have IVs running and they can develop heart failure. And so you really have to find that fine balance between ensuring that there's enough preload, but not developing heart failure iatrogenically. And finally, I think I've already stressed you have to monitor for those other complications like arrhythmias and bleeding and thromboembolic complications even after the delivery itself. So I'm going to leave you with these 4 points. First of all, that the Fontan circulation is really a unique physiology, and that can be destabilized by those hemodynamic stresses of pregnancy. For those women that become pregnant, atrial arrhythmias are the most frequent cardiac complication, and they can also occur in conjunction with heart failure or thromboembolic complications or alone. Bleeding complications are also common, and that's what makes anticoagulation in this population more difficult than usual. And finally, fetal and neonatal complications such as preterm births and low birth weight babies are very common. Thank you very much. This is my cardio-obstetric team in Toronto that I feel very fortunate to work with, almost as fortunate as I feel to be able to speak here today at this really fantastic meeting. So thank you very much. Enjoy the rest of the meeting.
Thank you so much, Candice. It's my privilege now to welcome Sasha Opatowski to the stage. Sasha is a professor in the University of Cincinnati College of Medicine, Department of Pediatrics. He directs the adult congenital heart disease program there, and he co-directs the exercise laboratory as well as the research program. On a personal note, Sasha came from Boston to Cincinnati at about the same time I left Cincinnati to come to Pittsburgh. And although we never had a chance to work together, we take care of a lot of the same patients and have interacted a lot around that space. And I'm really thrilled that he was able to make the trip over to Pittsburgh today. Thanks, Sasha.
It's a great pleasure and honor. Thank you very much for inviting me. I'm just going to pass on a message. On Thursday, a patient expressed that she was angry at you and she missed you very much. And that is something I hear quite often about Dr. Goldstein. So thank you very much for inviting me. I will say that I don't know if any of you know who this is. We're all on the same team here, but one team happened to win. This, I think, was before he won and when he was still dreaming about the trophy. So I'm very glad for the talks that came before because they really touch on a number of the topics that will come up and also some of the things that I'm not able to speak about. This quote comes from a patient who saw me. She was from down south. She was about 40, developmentally delayed, and her mother was expressing that when she was 4 years old, she asked her cardiologist, when will my daughter be able to walk? And of course, as I often do, those who know me, I jump to conclusions and assume I know what the person's going to say. And but I didn't say anything. And she said, oh, and the cardiologist said, whenever you put her down. And so it is very complicated, the interactions with exercise and activity. Both physicians and parents and others, all well-meaning, often lead to patients not necessarily getting into the habit of exercise. So in a big, broad scope, I'll talk about exercise and the Fontan-Kreutzer circulation, first pathophysiology, testing, and then treatment. And I'm going to assume some familiarity, but now I know you all are familiar after the first several talks. One caveat is that most of my information is from Tarek's Twitter account. So this better be a good talk. All right. The pathophysiology. So there are a lot of things about a Fontan-Kreutzer circulation that limit the ability of the heart and circulation to supply the muscles with oxygen. And I'll go through these relatively quickly, and then we'll ignore most of them for the talk, but it's really important to remember that there are a lot of things that contribute. There's high central venous pressure, which actually helps to augment preload. It's sort of a compensation. There's Fontan pathway obstruction or long segment narrowing, AV valve regurgitation or stenosis, less frequently, systolic or diastolic dysfunction, chronotropic insufficiency or at least low peak heart rate, abnormal pulmonary vascular findings such as abnormal pulmonary vasodilation or abnormal walls of the pulmonary artery, as was shown by Dr. Kreutzer, restrictive lung physiology, myopenia, and hypoxemia all contribute to decreased exercise capacity and these abnormal exercise test findings. And there are a lot of other contributors as well. And there really are too many to get into. Things such as iron deficiency and anemia, relative anemia, arrhythmia, junctional rhythm is not that uncommon. Deconditioning, of course, musculoskeletal and coordination issues. That's something that I tend not to think as much about, but they're very frequent. Psychological factors like PTSD and anxiety, which don't necessarily manifest in the way we might expect. And pain, something we really don't think about a lot, but there has been more recently evidence showing that adults, at least, and likely children with congenital heart disease have increased chronic pain issues. Corollary is that if there are a lot of contributors, there are a lot of ways that exercise can provide a lot of different benefits in different ways. So our focus just for the next 5 or 6 minutes will be cardiac output and cardiovascular contributors to exercise limitation. So this is an equation I think many of you know, Fick equation. Oxygen uptake is a function of cardiac output and the arteriovenous oxygen difference. Cardiac output is a function for the medical students in the room. This one you'll be comfortable with, right? Soon you're going to be mad at me, but right now, heart rate and stroke volume, I could have asked that question. Excellent. For some reason, I can't seem to, you know how oh, here we go. That's good. And together, impaired stroke volume augmentation and chronotropic impairment really conspire to decrease the peak oxygen consumption, the ability to deliver that oxygen. Now, this is an embarrassing admission. This isn't being recorded, I'm sure. When I was starting to read exercise tests back in Boston, Dr. Rhodes, who you probably know, one of the nicest people that's ever walked this earth, I said to him, Jonathan, I mean, you know, this patient's peak heart rate is 80% predicted in peak, you know, O2 pulse, stroke volume is 80% predicted. Why would the peak oxygen consumption only be 64% predicted? That makes no sense. And he said, what happens if you multiply 0.8 and 0.8? And sure enough, that's what happens, 0.64. And so they really do conspire together to decrease peak VO2. Some of you, a few of you who remember this paper from the PHN 2008 might remember that people really more often point to decreased stroke volume or O2 pulse, and we'll talk about this a little bit more, as the thing that's not able to be augmented in the Fontan circulation. And that is true. And if we were comparing peak O2 pulse to percent predicted peak heart rate, that might work. What we're doing is we're including chronotropic index, which is not part of the equation for percent predicted peak VO2. So really, these both contribute, and in a given patient, each can contribute importantly. So stroke volume is a function of several things, including end diastolic volume, ejection fraction, valve regurgitation. And end diastolic volume is a function of systemic venous return and pressure. pulmonary vascular resistance and the impedance of the pulmonary vascular bed, ventricular compliance and the pulmonary venous pressure, heart rate, and it goes on. Importantly, venous return is something that's not spoken about that much. And it's a really critical part of the Fontan circulation, perhaps even more ignored than lymphatics at this point. But this is a graph in from a textbook on exercise physiology. It's really a wonderful book, that was looking at the blood distribution when supine and then upright. And by the way, this isn't a cool person, it's that the temperature is cool. With a hot temperature, you have skin distribution. And what you can see is that when supine, so in the cath lab, most of the time you're supine, not when you're doing the catheterization, but you can see that most blood gets redistributed to the core. And that's why people develop orthopnea and whatnot. And when you're upright, not doing much, you start to have venous pooling and you have high venous pressures in your lower extremity veins. And then with walking, what you can see here is you redistribute blood based on the valves and deep muscles, deep veins with valves and muscle pump. And you can see here with walking right off the bat. Now that's the first thing in a normal person and patient with Fontan that increases cardiac output with exercise is actually that you're just pushing blood back to the heart. That's the thing that controls the cardiac output largely. And so it's important to remember that as we think about exercise physiology. And then there's this forgotten part of the equation, the AVO2 difference. We tend to ignore that. And if we get to testing, what are the things we're actually measuring when we're doing an exercise test? We're really measuring VO2, heart rate, and arterial saturation non-invasively. We don't measure these other things. One could make an argument, maybe we should measure hemoglobin, because a cardiopulmonary exercise test is a pretty annoying and expensive complete blood count. But we don't tend to do that. So we don't know what the hemoglobin is. We're not measuring venous saturation most of the time, and we're not measuring stroke volume. But we can estimate the stroke volume if we assume this is all normal or similar between people. So just ignore all that. And you have VO2 here, and you divide that by heart rate, what you're going to get is a correlate of stroke volume. Now, there are a lot of pitfalls here. So if someone has severe anemia or has severe hypoxemia, if they have issues with extracting oxygen, like a mitochondrial disease and an arteriovenous systemic AV fistula. All of those things will make that relationship faulty. But otherwise, you can do that oxygen pulse, the amount of oxygen that's being carried per beat. And what I'm showing here is two different patterns, patient 1 and patient 2. And the top patient, I'll give you a moment to think about it. Red is heart rate, and blue here is that O2 pulse, the cardiac output divided by heart rate. So a surrogate of stroke volume. And what this is pacemaker Wenckebach, and there's a sudden drop in heart rate right here. And this patient didn't notice it, probably because their O2 pulse just jumped right up. In that case, you're not going to be changing your hemoglobin or your extraction beat to beat. So this patient doesn't feel it because they're able to augment their VO2 and oxygen delivery. The second patient doesn't have anything wrong with their rhythm. You can see their heart rate goes up pretty normally, although it doesn't get up to where you expect up there. And this is a patient with a Fontan generally doing well, but as the heart rate goes up, their O2 pulse goes down, suggesting that their stroke volume is going down. That can happen in severe aortic stenosis or a mustard procedure, but this really is a correlate of being unable to have enough venous return. And this isn't just seen in individuals. There's an average plot of stroke volume by heart rate. So the x-axis is different, but they're going to be pretty similar. And as heart rate goes up in the Fontan circulation, unlike in black here with the normal biventricular circulation, you're not able to augment your stroke volume in the same way. So what you expect with exercise in the Fontan circulation, this is a proof of principle study that was done when Grushin-Veltman was in Cincinnati. There are 10 Fontan exercise tests and 9 control exercise tests. And what you can see here is that venous pressure goes up a lot more rapidly and severely in the Fontan circulation than in these controls. You can see at rest, there is overlap, right? You couldn't 100% differentiate these two groups. With exercise, you really could almost entirely. The same group looked at in a larger cohort, 46 patients who had this done for clinical purposes. That venous pressure went up in almost everyone. With one patient towards peak, it went down. And they looked at outcomes and showed that that peak venous pressure is the thing that best correlates with outcomes across the board, more so than resting venous pressure. I'm going to go through this case very quickly just to show you this hemodynamics, just to emphasize how there's a lot we don't really understand, and it's important to really think about these patients. You're lucky to have Dr. Goldstein. I feel like I might be flattering him a little bit too much, but someone who would be willing to think about this. This is a 40-year-old woman with lateral tunnel Fontan, developed ascites, and really had a really deteriorating course over 3 years, was on very high doses of diuretics, had a very extensive workup, not much to say, had a normal catheterization with venous, with Fontan pressures and whatnot that were not normal, but they weren't very strikingly abnormal, not that unusual. Started sildenafil, which we are wont to do when we're not sure how to help somebody. Not only did this patient not improve, but she developed a headache and almost passed out a couple of times. So we stopped that and we did an invasive exercise test where we put it in a venous line and had her get up on a bike and do true fit cardiac outputs from a radial line and a Swan-Ganz catheter. This is a patient who had severe PTSD. Lovely person, seemed like she wasn't overly anxious about most things, but the moment that a needle came close to her, it's very stressful when someone has no sedation, since they're going to have to exercise right after. And despite numbing, it was really very difficult for her. But what you can see here on the left is the Fontan pressure doesn't go up. In fact, when she goes from supine to upright, the venous pressure drops precipitously. The wedge pressure drops quite severely, and it just doesn't augment at all with exercise. Cardiac output doesn't really augment much, and PVR, probably because of decreased flow, goes up when she gets upright and just doesn't go down with exercise, okay? In any normal individual, PVR should go down with exercise, cardiac output should go up a lot more. So what you see here is the limitation isn't, the wedge being high, so it's not systolic or diastolic dysfunction, it's not necessarily PVR, because if it was PVR, the venous pressure would go up. The issue here is that she has very high venous compliance. So if I can figure out how to change this. Oh, do you guys know how I do this? Oh, thank you. Venous capacitance going up is a major issue. So we don't see this too often, but it does happen, and it's something to keep an eye out for in terms of exercise physiology. I'm going to skip over this. And we sort of see hints of that, right? You have these patients with very severe varicose veins. That's not just happening in the legs. And it turns out that phosphodiesterase inhibitors like sildenafil and sildenafil are also venodilators. Finally, treatment. So here's some Argentine exercise training. It's amazing. For Lionel Messi, there are a lot of pictures of him exercising. For Maradona, there are almost none. I wonder why. There are a lot of types of exercise. And one thing to highlight is that when this patient asks you, well, exercise can be harmful, okay? And for many decades, that was the standard. We really don't know what types would be most harmful. And I just wanted to highlight, this is last night when I was going over these slides and looked, my Google Scholar gave me a hint about this paper, which looks so incredibly cool, that they basically looked at a lot of different markers of possible liver injury in terms of ultrasound and circulating biomarkers after exercise to look for liver damage. I haven't read it in detail, but right after this, I'm going to. But this is the sort of thing we have to do to try to identify what sort of injury we could be doing with certain sorts of exercise. But there is clear consensus, and I agree that we should strongly encourage exercise. So what data support that shift? I'm going to skip through this pretty quickly. Reasoned arguments and randomized controlled trials. There's other evidence, but we're just going to focus on these. Reasoned arguments are great. So in populations where it's been studied, exercise is good for you. It also increases muscle mass, improves endothelial function, and improves ventricular compliance. And all of those things are fundamentally important. And here's a paper showing the increased adiposity and decreased muscle mass in a Fontan. You might say, we know that a decline in VO2 in this population is associated with worse outcomes. So if exercise and training improves peak VO2, maybe it'll be associated with improved outcomes. Fair. But I love this exercise, but I've heard you say that love's reason without reason. Well, that's okay, right? We don't necessarily have to have reason. I think we all agree, and it's probably good. We should try to figure out why, and it probably doesn't do major damage. And so then we have to go ahead and start to think about exactly how we counsel patients. I'm going to skip ahead here, just highlighting here how little data there are on that this is actually beneficial. Given how strongly we recommend it, it's quite surprising how little we know. But it's important to remember why a patient is interested in exercising, right? There are a lot of reasons, but peak VO2, having better vascular function, better cardiac function, none of those are reasons unless they have correlations with something else, right? And so you can actually, we've all seen a good number of patients who feel a lot better and are doing a lot better when they exercise. And it's important to remember that that is an end in and of itself, even if on average, it may not have a huge benefit. So what we know is being sedentary is bad and exercise is beneficial in most contexts. The benefit is not limited to peak VO2. Exercise training does improve exercise capacity, and it's usually safe. We do know that cardiac rehab is effective in certain situations. Few people, though, sustain regular activity, and there are obstacles to these patients, especially feeling comfortable exercising. There are a lot of open questions about how we're going to do this the best possible way. And the good news is that on the horizon, there are a good number of more rigorous, robust studies that are being done in Australia. These are Australia, Stanford, and Michigan. And I just wanted to highlight, there are also things that are not clinical trials that are ongoing. This is for the Fontan Outcomes Network. Our first clinical care practice project is really getting patients, parents, providers, and others together to understand better what's limiting us and understand the importance and how best to support patients and providers in how we counsel patients to improve physical activity. And this is from a learning session where we all started squatting. You see this really impressive guy back there? I think that's me. And with that, I say thank you. We are all on the same team. If Pete Rose and whoever this other guy is could get along.
Well, we're going to have our panel discussion here. So if Dr. Silversets can join us on Zoom.
Yeah, I'm on. Hi,
Excellent.
everybody.
Hi. Hi, Candice. How are you?
Great, thanks.
Thank you. Welcome. All right. So we're going to take some questions from the audience here, and also we'll take some questions from Zoom here as well. So you can come up to one of these microphones if you want to ask your question. And I can start with a question to Dr. Lorenzi. So really wonderful talk, Lauren. When and how should we refer these patients to see a neurodevelopmental specialist?
We have really tried to take a preventative model at Children's Hospital of Pittsburgh and beginning these services even prior to birth. So we have started to institute, I have a visit with patients, with parents that have a diagnosis of critical congenital heart disease during pregnancy to start a conversation of coping and empowering parenting in an ICU setting during a long hospitalization and accessing, social supports and things that can enhance kind of psychological outcomes. Regular screening during the inpatient hospitalizations through postpartum depression screening for parents or neurodevelopmental evaluations during inpatient stays are very important. And then, regular neurodevelopmental follow-up in early childhood and neuropsychological follow-up through adulthood is incredibly important. The Cardiac Neurodevelopmental Outcomes Collaborative has given us some significant time points, but really those transition periods, moving into kindergarten, moving into to second grade when the kind of educational asks are heightened, moving to middle school, high school, and then onward. Those are really critical time points for more thorough evaluations, but integrating screening beyond just those time points is incredibly important to have kind of more a longitudinal relationship with families, but also catch things as early as possible to mitigate as many challenges as we can. So through early intervention and through, just kind of maintaining that relationship across time with families to kind of be used to that conversation about neurodevelopmental risks or mental health challenges that they might face so that they're, open to discussing that and intervening when we need to.
Wonderful. Thank you so much, Lauren.
Sure.
Any questions? Yep, Anita?
I have a question for Dr. Silversides. Could you comment a little bit on how you counsel perhaps a pregnant Fontan who belongs to modified WHO class 3 versus class 4, and how you change your strategy in terms of incorporating more specialists or different types of specialists when it comes to organizing multidisciplinary care while taking care of them?
Sure. No, I don't know if I have a completely, well, first of all, I would say that if a Fontan really is not doing well, if you have a failing Fontan, if you have a Fontan where you just can't medically stabilize arrhythmias or those scenarios that I've mentioned, or that's had recurrent heart failure, I mean, I would advise those Fontans not to get pregnant in the first place. So I would take at least that approach. Now, remember, just because you advise someone that they shouldn't get pregnant doesn't mean they aren't going to get pregnant. All it means is you're giving them your best advice. I didn't put in a slide, but I usually put in a slide that says all we really are doing is educating women about the risks, and they will decide whether those risks are acceptable or not. So I think even if you tell them they should avoid pregnancy, if they say I'm getting pregnant, you also then have to plan for pregnancy. And to be honest, probably I approach most Fontans similarly. Obviously, I do more surveillance if it was a Fontan in bad shape, but I think all Fontans, I'm looking for the same things, which are the things I've talked about, things where the hemodynamics of pregnancy can destabilize them. Arrhythmias really are the big one. In terms of who I get as part of the team, this is a cardio-obstetric team in general. So if I was at a center where I didn't have ACHD expertise in EP, I would get them involved if there was arrhythmias. If there was some really big liver issue, I guess I'd get the hepatologists involved. I haven't really seen that. That would be more probably along the lines of a failing Fontan. If a Fontan really had refractory heart failure symptoms, I would probably have the heart function team involved as a back-end team. So if they were really failing, I would get the appropriate team. But most of the time, it's me and then the rest of the general cardio-obstetrics team. So that includes a high-risk MFM. It includes an OB anesthetist who has an understanding of the Fontan circulation. That also means OB anesthetists are different than the cardiac anesthetists that we know. So sometimes, we're fortunate we have combined OB and cardiac anesthetists that are dually trained, but that would be atypical. So often the OB anesthetist will have to talk to cardiac anesthetists about what do they need to know to tailor anesthesia for a single ventricle patient. You also need to ensure that you have social support. So you may need social work involved or other type of, clinical psychologists involved if it's appropriate for the case. And then something that I think we often don't say, but a really important of a cardio-obstetrics team is to have your nursing staff have some understanding the cardiac issues for a patient that's delivering, especially some complex patients like Fontan patients where the problems can happen right after delivery while they're in the labor room or while they're being monitored. So that brings me to a last point that, again, I didn't have time to get into, but, we would often monitor a Fontan if they have any signs of trouble or if they're not a pristine Fontan, we would monitor them in a cardiac step down or ICU or something after they deliver, just because you can have better cardiac nursing. You can monitor easily better for arrhythmias. You can monitor volume status better. So most of the time you want to place someone after a delivery in that setting. And again, that means you also have to make sure that the team that you're placing them in has some understanding of Fontan physiology and what to look for. I know that's a long-winded answer, but the core of the team is cardiologists with Fontan, pregnancy, ACHD experience, high-risk obstetricians, cardiac anesthetists, and nursing staff that knows what they're looking for.
Excellent. Thank you.
Hey, thanks, everyone. Great talks. This is Arvind Haskapal, Pittsburgh. I have a question for Sasha regarding exercise trackers and wearable technology. There's obviously a boom. This is nothing new. And, I was watching Shark Tank last night. They even have smart pins you can put in exercise machines and it'll track your exercise. So my question to you is like, are those data useful, and do you routinely recommend this in your Fontan or ACHD patients?
No. I don't normally recommend it just because I my sense is that if they're interested in doing that, they'll be doing that, and they're probably good on their own. And if they're not doing it, it's not going to help. Ones with Apple Watches or things that they're already wearing, but sort of it's incidental and they're not obsessed with it, which is that one subset of psychology, and the other subset is those that are obsessed. But those that are not obsessed, then it can be helpful to look at it and get a sense of what they're actually doing. But I haven't really integrated that. It could be a really good motivational tool if used the right way. I think one of the challenges, so many different types and people wear them differently, that's a little bit difficult to know what you're getting, but it could be a really good tool.
Can I just make one quick comment from abroad here? There's a really nice review on biosensors in congenital heart disease in JACC Advances. It's open access. It's free to download. If you want to look there, it's a lovely review article on the topic.
Sasha, I want to ask you two questions. First, I really appreciated the conversation and some of the really nuanced work that you've done in this space, which I think is moving the field forwards in incredible ways. The first is, I agree, and I think most of us in the room agree that the era has sort of shifted from avoiding exercise as a prescriptive restriction to encouraging exercise. And yet still, when we see patients who are getting into their teens and 20s, many of them have now gone through childhood, maybe golfing instead of sitting at home, but not playing soccer or whatever that is. And so I think there's still a lot of work to be done. And I'm curious in your thoughts on how we as a field better get at that with patients and families, really. It's before they get to you and adult congenital and me in the cath lab oftentimes. And I'm curious sort of how we better do that. The second question I have is, these highly nuanced sort of personalized medicine approaches to taking care of the Fontan are clearly one of the places we need to go. The idea of identifying problems with venous compliance or capacitance being too great and that being a problem, and then focusing on maybe compression stockings and other things like that has real impact for that patient. But it's also hard to bring every patient to a laboratory environment with invasive venous pressures and other things. How do we find the right approach to this? How do we not withhold those nuanced assessments and only use them in very careful, very sort of extreme circumstances? Because I suspect that we are, as you said, we just put them on PD5 because that's what we do. That's probably okay in some patients and not in others. How do we better personalize our approach as we gain more tools and therapies? How do we better sort of understand who needs one?
It's really actually very difficult. I'll do this second question first. I'm now remembering that patient. I had totally forgotten this for the last however many years. So we took her off the sildenafil and off a lot of the diuretics, and she did about the same. She didn't do much better, but she didn't get any worse on much less diuretic. And she came back, I think 6 months later, and we repeated the same test, except did everything the same, except at that point, we got her up on a treadmill in the cath lab, still awake, still upright, totally different hemodynamic response. And so part of the problem is you can convince yourself that that's exactly what's going on. And then we don't really know all the nuances and know how variable it is. Have what's normal. We don't have 150 patients we've done this on and what the various permutations are. So to even get to that, we convince ourselves that we know what we're doing, and probably we're doing a little bit better, but we can also overfit our model to whatever we're seeing. So I don't know the answer to that. It's really hard. The first question, I think we may have a better answer, and that also is going to be exceptionally hard, but I think it's involving patients and parents in trying to work together with us and also with each other to try to figure out how to make that part of the culture, and a collaborative approach across centers and sort of mentorship and making sure that that's an important part. Us sort of communicating, and I'm not a pediatric cardiologist, so I don't have to do this, but like talking to their coaches or the PE teacher to make sure that they understand that to the degree we can tell them it's safe, or that they should be treated the same way or whatnot. But that I imagine those folks are also having a psychological impact, and that's really difficult. So I don't know the answer to it, but I think working with patients and parents and seeing all the different personalized permutations of that as well, what the obstacles to exercising.
I imagine the learning networks like the FON, that's
It's
one of
well
the
suited
goals
for
is
that,
to,
yeah.
is to
It's
get.
very
to-
well
yeah.
suited.
Thanks.
We'll take one last question from the audience.
Hi, I'm Bill Marshall from Ohio State. For Dr. Lorenzi, you mentioned high prevalence of anxiety in patients with congenital heart disease. We've also learned about everybody here knows that long-term outcomes and potential limited life expectancy. So my question for you is, in the young Fontan patient or the 20-year-old, 25-year-old doing well, balancing not exacerbating giving them something else to worry about, but also being honest about the potential future trajectory of their lifespan. If you have any practical tips or other advice on that, that's always a hard conversation.
I thank you for the question. And I think that's an incredibly challenging balance. I think kind of starting conversations as soon as possible regarding kind of that transition period and moving into adulthood to kind of normalize some of these conversation topics is incredibly important. Because when kind of this new outcomes information does come in this transition to adulthood period, it can be really riveting to our patients. And, you know, several of the older Fontan patients that I have that are moving from late teens into early 20s are starting to have some additional stressors in their just general functioning with, you know, ableism in the workforce. I have, you know, one who had hopes to become a police officer or join the military and was unable because of his diagnostic history. So kind of shifting career goals. But I do think they feel the weight of that mortality conversation. And I think, again, kind of evoking, trying to optimize mental health and using kind of preventative medicine ahead of time so that they're in the best kind of place to receive the growing information as they traverse kind of their medical trajectory is important. Kind of pulling together social supports even as they move into adulthood, and, you know, starting the conversations as early as possible. I think also, you know, the kind of way in which we formulate these discussions is really powerful, not like, you know, if you're experiencing this, but how you're experiencing it, because it will come and it will be stressful and these challenges likely will present. So evoke kind of formulating the conversation more of how you're managing it rather than if it's present, I think is important. But, you know, having that kind of presence of mental health within the cardiac home, I think can help with that, so that the novelty of those harder conversations that may come with the medical complications moving into adulthood or mortality discussion aren't new, but when they come, they're well supported.
Fantastic. Thank you very much. With this, we're going to go ahead and close this session. Thank you very much for our fantastic speakers and moderators. And we will start right at 10. So we have a short break till 10 o'clock. Thank you.
We're going to go ahead and get started in a minute or so. Can I call the moderator up on the stage, Dr. Gaurav Arora, Dr. Jackie Kreutzer, and Dr. Libby Lanford. Thank you.
Well, wonderful. We're going to get started with this next session, and it's going to be screening and interventions during the lifespan of a Fontan Kreutzer. The co-moderators in this table is Dr. Gaurav Arora, who is essentially directing electrophysiology at our institution, and Libby Lanford, and Libby is an expert advanced imager here in Pittsburgh. So the first speaker is Dr. Arvind Hoskopal. Arvind is director of the ACHD program at UPMC Children's Hospital and Heart Vascular Institute. Arvind is associate professor of pediatrics, and we are very happy to have recruited him a few years ago from Utah. Arvind will be talking about approaches to Fontan Kreutzer management program. Come on.
Thank you for the kind introduction, Dr. Kreutzer. It's an honor to be here and speaking in the symposium, and thanks to my co-directors for putting this together and inviting me. I'm not just honored, I'm also humbled to be here. We didn't know, but it was such a great surprise to have the OG of Fontan Kreutzer procedure, Dr. Kreutzer himself, grace us with his presence, and to all the attendees all over the world, both in person and virtually, my heartfelt gratitude. And I promise this is going to be the only non-clinical talk of the symposium, and I've been posed with talking about setting up a Fontan Kreutzer management program. So I'll give it a shot. Let's go. So why do we need to have a Fontan specific program? What is the scope of the problem? As we all know, we have heard multiple times, it's been more than 50 years since this procedure was conceived, and now there are more than 70,000 people worldwide living with this circulation, and this number is increasing. And here in the United States, most of the adult Fontans are taken care of or should be taken care of in an ACHD program. And there are only 50 accredited ACHD programs and about 120 self-identified ACHD programs in the country, and 320 board certified ACHD physicians. That may sound like a lot for 70,000 in the world, but in the United States, but we have other ACHD patients to take care of. More often than not, a Fontan patient is probably less than 10% of our practices. But these patients are extremely resource intensive. And I talk about the 80-20 rule, where 20% of your patients take up 80% of your time. And that's not a hard and fast rule, but this probably fits the definition. And hence the need for specific Fontan management programs. And data are evolving. I was talking to Dr. Lanford earlier today, and she's one of our Fontan management people. And she said, I've been doing this for a long time. And in the 1990s, we didn't have treatment for PLE. We didn't have treatment for plastic bronchitis, but this is evolving and we are learning, and we need to have specific programs designed for this patient population. Now, a Fontan circulation is inherently not a perfect situation. It is a palliation. So I think this was Goldstein who described this as the human-made form of heart failure. Like right from the get-go, there are issues. And though this is a small percentage of our population, the comorbidities are higher than any other population. There are data to prove this, perhaps the highest. And it is not just the heart that we need to worry about. The Fontan patient it's a multi-organ system disease. So in addition to the heart, we need to look at the liver, the lymphatics, the lungs, kidney, growth, brain, contraception, pregnancy, etc. Most of these are covered in today's symposium. but that constitutes a real Fontan management program. And if we have a fragmented approach taking care of these patients, this can lead to late detection of comorbidities and poorer outcomes. And the ultimate pathway for these patients would be transplant timing and listing. I believe that session is coming up later today as well. I talk about transition because no good Fontan management program is complete without having a good transition program. I say that term loosely, that it is more, in many institutions, it's more of a concept than an actual program. But I don't think there's a perfect transition program, but these are some of the concepts, because why do we need to have a transition program specifically for Fontan? Because we know there's kind of like a loosely put, a bimodal peak of comorbidities right after in the early post-op period where a pediatric cardiologist is taking care of this patient, and during the transition phase in the adolescent to the early adulthood. So extremely important to have a good transition program, and where we gradually shift the responsibility of healthcare management from the family to the patient. And I mean, if I can get a show of hands of how many Fontan patients show up by themselves to clinic, even when they're in their mid-20s, and even 40-year-olds are showing up with their parents. And I see a lot of nods in the audience, and that is true. And in addition, like, there is this vulnerable period where in the teenage where there could be a lull in their comorbid issues, and they're feeling great, and they don't want to come and see you anymore. And by the time they come, there are data to show that they're sicker and harder to manage. So I'm just going to run you through some thoughts about what you could do. There's no perfect recipe for a perfect Fontan management program, but screening protocols are important. It not only ensures adequate testing, but paradoxically, it avoids over testing. So if you have a protocol in place and not a one size fits all kind of situation, but obviously there are nuances to that, but protocols are important. And those quote unquote multidisciplinary Fontan management clinics, these have several flavors as well, and a single physical clinical space, and there are some institutions which do that, but logistically this has become harder, and especially during the pandemic, I'll show you a list of subspecialists who are needed to take care of these patients. It may be near impossible. So what we do is like a virtual program where we have multidisciplinary meetings where we get the data and review it together with the subspecialists. This is a busy slide. You're not supposed to read all of this, but this is the village which is needed to take care of a Fontan patient. This is from a paper published by the Cincinnati group, and Tarek was still at Cincinnati. He was on this as well. But imagine getting all these people in the same room at the same time to take care of one patient. I don't think it's possible. Maybe they do it in Cincinnati. Sasha is smiling, but he says no either. So, but this is what it takes. But if you look at this list, most of our patients see most of the subspecialists at some point in their lives. So we did come up with the testing frequency in this JACC expert analysis published recently. This is offered as a guide. The one on the left side of the screen, the EKGs, the echo, are pretty standard. Everybody gets that in most clinics. What you want to pay attention to is to the right side of this is the multidisciplinary evaluation, the exercise testing, and also surveillance CATs. I don't know if most institutions practice that. In our institution, it is becoming standard of care that most of the Fontans do get surveillance CAT, the frequency of which is going to be determined by the cardiologist. This is, again, this is also available in the same expert analysis. It's a little bit more detailed card, which you can easily hang up in clinics for quick reference. You can also create smart phrases to prompt you to do these testing in your EMRs, and available. I'm not going to go through each one of this online because it's available easily. The 18 ACHT guidelines also divides the ACHT patients, the Fontans, not just based on their severity, which will be the most severe form of congenital heart disease, but also based on their physiologic stage, the so-called AP classification. And again, this is another reference you can use to determine the frequency of testing applied to individual patients, of course. So what do we do here at UPMC? It's we try to do like a truly patient-centered approach with the Fontan cardiologist kind of conducting the orchestra, working with other cardiac subspecialists and other internal medicine specialists. Of course, we incorporate research and social work, which is extremely important, taking care of these patients. We have a virtual multidisciplinary model in our program, and we do have a standardized testing and follow-up protocols. And we have this called Fontan sheet, which not only serves as a clinical guide, but also as a database when taking care of these patients. This used to be a PDF format, an editable PDF format with I'll show you an example in a little bit, and then where our nurse coordinator enters all of these and updates the sheet and hands it to the cardiologist prior to seeing the patient. And in addition to all of this, this can be easily handed to the patient as part of their medical passport and an easy guide if they're either moving or seeking care elsewhere or in times of emergency. Now we have evolved into a dot phrase in our Epic EMR, and which half of it is automatic and half of it is manually entered. And we can walk you through that if anybody's interested. And this is kind of unique to UPMC, led by the Adult Heart Failure Group, the MOC. It's not maintenance of certificate, and everybody's getting a little nervous. It's MOC's Medication Optimization Clinic, which is an intense 6-week program where we have been referring some of our Fontan to, where they get the counseling, the medication optimization labs, and because there are data in the adult heart failure world to show that escalating therapy, we see a Fontan, we see them back in 6 months, change one medication. But here, this is a 6-week course, quite intensive to escalate the therapy to the full so-called GDMT. And we do have a multidisciplinary meeting where we review all the data, and subspecialists are invited on an as-needed basis. This is a screenshot of how the Fontan sheet looks like. It was initially conceived for the liver data and liver follow-up alone, but now it has evolved into like a comprehensive 4-page PDF document where it's a one-stop shop for all the latest labs, cath data, cath imaging, and it is modifiable, of course. If somebody wants to add additional features, we can do that. As I said, now we have evolved into an electronic format of this, and this is, you can create an encounter in Epic, and it's called an informational encounter, and have a dot phrase, and where some of the macros are auto-imported, but the rest of them are tabbed through sections, and this is highly customizable, and I find it extremely useful, and then you're not looking for the sheet in a database. It's right there in the EMR, and it's a permanent part of the medical record system. So as we head into the future, and this the idea of a physical combined clinic is resource intensive, and the best model, to be quite honest, is yet to be determined. Like whether it is hybrid, it has to be a combined clinic, or everything in between. And with the pandemic, one of the good things that came out is like we got better at using the telehealth platform, and we have been using this increasingly. It's not just to see the patients, but also to also have the multidisciplinary conferences on the Zoom or Teams links. And Again, since this is such a nuanced field, we do highly recommend that there should be regional centers and centers of excellence where these patients should be taken care of, and in collaboration with other regional providers, of course. This is our wonderful team, and Anita is right here, and Natasha, our other cardiologists, and we have social work. We have a dedicated researcher and our own scheduler, which, as I said, takes a village to take care of these patients. With that, I'm going to end, and this is the contact information. I believe we're taking questions at the end. Yeah, thank you.
Good morning. It's my pleasure to be able to introduce Dr. Tariq El Said, one of my co-workers here. He is an assistant professor of pediatrics at the Heart Institute of CHP. He did a large part of his training in Cincinnati. There appears to be a Cincinnati connection here. He also did an advanced cardiovascular imaging fellowship at Boston Children's. He returned to Cincinnati after finishing his training, and then we were lucky enough to recruit him here to the CHP Heart Center in 2021. Anyone who knows Tariq knows he's very energetic and is actively involved in research and publications. And he has a very strong interest in the Fontan population and everything to do with them. He'll be speaking on advanced imaging today.
Thank you, Dr. Lanford, and thank you, everyone. It's really an honor and a pleasure to be here this morning. I will be talking about advances in imaging post the Fontan-Kreutzer procedure. We will start with an introduction and background, and then we will look at different imaging modalities used in Fontan-Kreutzer patients, and then we will finally look at the future directions. So let's start with some introduction and background. As we heard this morning, the procedure was created in the 1969. And then in the 1970s, there were multiple modifications with the removal of the valved conduits and the creation of the atriopulmonary Fontan by Dr. Kreutzer. And then in the 1990s, there was creation of the modern types of Fontan that we see today, which is the creation of the cavopulmonary anastomosis with lateral tunnel and extracardiac conduit Fontan. And with that, there was significant improvement in the operative survival. And today in 2023, we see many adults with Fontan, and it's time to focus on the long-term morbidity and mortality. So looking at the long-term outcomes, this is the same paper actually that Dr. Silversitz used in the morning. So this is a paper from the United Kingdom with 7,000 patients with adult congenital heart disease and a median follow-up of 9 years. And it compared the survival of different types of congenital heart disease to an age and sex matched group of adults in the United Kingdom. And what you can see on this graph here is that patients with Fontan circulation seem to have the higher standardized mortality ratio compared to all types of congenital heart disease, including complex congenital heart disease and patients with Eisenmenger syndrome. So it's definitely a population with high risk for adverse outcomes. And based on that, we think about the journey of these patients on a roadmap, starting from stage 1 through the Glenn anastomosis, and then they go through the Fontan-Kreutzer procedure, and then many of them will end up needing a heart or heart-liver transplantation. And our goal as Fontan doctors is to try to delay or prevent transplantation, but also try to refer them for transplantation at the right time. And imaging plays a central role here because it helps us with risk stratification, and also it helps us with predicting mortality and morbidity. There's a nice balloon here in the room. So that takes us to imaging. So we'll look at different imaging modalities used in Fontan next. In terms of the preferred diagnostic strategy, there's really no one strategy that works for every patient, but we typically use a combination of echo, cardiac MRI, and sometimes CT scan when cardiac MRI is contraindicated. This is a scientific statement from the AHA that kind of guides us through how often to use these testings. So echocardiogram is typically recommended yearly, while cardiac MRI is recommended every 2 to 3 years. And we use cardiac CT in patients where we can do cardiac MRI. And this is, for example, patients who have epicardial leads. So to see how, to highlight how multimodality imaging can be very helpful in these patients, let's discuss a patient presentation. So this is a 24-year-old with hypoplastic left heart syndrome, aortic atresia and mitral atresia. He had a baseline echo that showed low normal right ventricular systolic function. And then unfortunately during COVID, he lost to follow-up and fell into some substance abuse issues. Before this presentation, he had 1 week of, or one week before this presentation, he had sudden chest pain at the gym while running. And since then, he had persistent dyspnea and dizziness with mild exertion. He presented to an outside hospital emergency department. His troponin was very elevated. His BMP was also very elevated. They did a chest CT, which was concerning for a pulmonary embolus in the left pulmonary artery, and thus was transferred to our hospital. This was Friday afternoon. I remember I was on call and I called Dr. Saraf that day because she was on call for ACHD. So looking at his echocardiogram from the emergency room, you can see, from 2019, this is his baseline echo. You can see that his RV has reasonably well functioned. And then as we look at the echocardiogram from the presentation in 2021, you can see that the right ventricle was severely dilated with severely depressed function, and there is a small pericardial effusion. Next, when we sweep anteriorly towards the aortic valve, we see that there is a filling defect in the right ventricle here, and it's pretty echo bright. So that was suspicious for a thrombus. And then looking at his coronaries, you can see that we can fill his right coronary with color. And then we try to look at his left coronary as well, but it does not fill with color. So the echo report is that his RV function was severely depressed. There is an RV thrombus, and that the left coronary origin is not well seen, and there is a small pericardial effusion. So let's just talk very briefly about the pros and cons of echo. So the pros is that it's portable and widely available. There is always an on-call fellow who can go to the emergency room and do an echocardiogram. In this case, Dr. Gonzalez is here. Actually, she did this echo. It's a great tool for valve assessment, and it has high resolution. But the problems with it is that it requires some experience in congenital heart disease. And also we have limited RV functional assessment, especially quantitatively, and the acoustic windows can be limited. Next, we look at his CT scan from the outside hospital. So the bright structure here is the superior vena cava. And you can see this is the filling defect in the left pulmonary artery. But as we go towards the Fontan, we see that the Fontan is not filling with contrast. So our suspicion is that this is just a contrast timing artifact rather than a real thrombus in the left pulmonary artery. And then when we were looking more carefully, so this is his native aortic root. So this small structure here, and you can see the right coronary is coming off it. And then you can see that there's maybe a small filling defect in that native aortic root. So the CT read from the outside hospital is that there is left pulmonary artery large embolus. After we carefully reviewed the images, we thought that the LPA thrombus is less likely and that there is possible native aortic thrombus. The pros of the CT is that it has rapid acquisition, so we can get it very quickly in the emergency room. It has high resolution, and also it visualizes the Fontan pathway pretty well. However, the cons of this modality is that it involves radiation, and it does not give us any flow data. And also the contrast timing can be challenging, especially in these Fontan patients, and that was the case in our patient. So just to review his imaging so far, so we were concerned for native aortic thrombus, as you can see on this CT here. And then when we carefully review his echo as well, we noticed that even in the echo, we couldn't fill that left coronary artery, and there may be a little filling defect here as well. And this is just to see where that filling defect I was talking about. So this is the native aortic root, and that's what we were thinking could be a thrombus. So because of that, he went the next day, so Saturday morning, he went to the cath lab, and in the cath lab, they confirmed that there is a native aortic thrombus. However, there was good flow seen in both coronary arteries, And he was pretty sick at that time, so we felt that the risk of trying to take this out outweighs the benefits. A few days later, he went and underwent a cardiac MRI, and you can see by cardiac MRI, this is his right ventricle here, and the function of that right ventricle was severely depressed. And then this is what we call the late gadolinium enhancement imaging, or the SCAR imaging, where the normal myocardium is usually black, while the SCAR or the abnormal myocardium is usually white. So this entire area is a SCAR here. So this patient infarcted a very big part of his right ventricle. Now we're going to spend a little time talking about cardiac MRI in patients with Fontan, because we believe it plays a really important role. So cardiac MRI is good for cardiac structure, evaluating cardiac function, quantitative evaluation of the flow, and also tissue characterization. So when looking at the cardiac structure, we can look at the cardiac anatomy. We can look at the cardiac anatomy. As we can see in this patient, this is a patient with double outlet right ventricle. The aorta is coming from the right ventricle here. There is a large VSD, and you see the subaortic conus. We can also do some nice arch reconstructions. So this is a 3D reconstruction of the aortic arch here, and we can tell if there's any coarctation. We can also look and see if there is, and I don't know why the videos are not playing on this, but we can also see if there's any pulmonary artery compression. So this is a patient with a severely dilated aorta, and that's causing some compression of the left pulmonary artery, which is common in these patients. And also we can look for Fontan pathway obstruction. So this is a nice 3D reconstruction. This is with IV contrast. You can see that the inferior part of that Fontan conduit is narrowed with dilation of the IVC and the hepatic veins. And this is another patient, and this is without contrast. And you can see that the conduit is probably diffusely small for this patient, with severe dilation of the IVC and the hepatic veins as well. Also, cardiac MRI is very good at looking at the ventricular size, ventricular mass, and ventricular function. And also we can look at the ventricular mechanics and strain with cardiac MRI. And we can use the flow data to evaluate valvular regurgitation and also the burden of the collaterals. So this is that same patient that we looked at the Fontan pathway in before. And as you can see here by this 3D reconstruction, you can see entire Fontan pathway is actually pretty small, and then there is dilation of the IVC and the hepatic veins. And because it's a venous system with really low pressures, when we go to the cath lab, when we measure the gradients, usually there is like very minimal gradient despite this degree of stenosis. But luckily now we have these advanced tools with 4D flow, which is like, pretty straightforward to do right now. And you can see clearly that there is some flow acceleration starting at the level of that conduit. So you can see it's like, blue and green here, and then you can see that there is a lot of red here over that conduit. And that also, when we do the analysis, correlates with kinetic energy loss over that conduit. And that kind of supports the clinical decision we make in these cases of stenting this Fontan conduit to make it bigger. This is another 4D flow, and from a patient we actually did last week, there was a concern for possible AVMs. So with that 4D flow, we could label the IVC flow, and we can see that there is good flow distribution to both lungs, like with this 4D flow. Similarly, the SVC flow also goes to both lungs. This used to be very time intensive, and like we needed to send it to computational flow dynamics and get the results like 3 weeks later. Now with 4D flow, like we report that in the clinical report same day. So it's pretty quick to do these days. And then the thing that the cardiac MRI can do that no other modality can do is tissue characterization. So you can see this is our patient. So as mentioned before, had a really large scar in the right ventricle. And then this is the normal healthy myocardium. But this picture is without contrast, without giving gadolinium. And this is called T1 mapping. And we can actually now look at the normal myocardium, which is this purple here, while these areas here look thin and also look kind of more orange. So the T1 value for these areas is elevated. So that tells us that there is a scar there even without using contrast. So back to our patient, he was admitted to the cardiac ICU and underwent a successful VAD implantation. And finally, the exciting part is the future directions in cardiac MRI. So we're really trying to use the information from cardiac MRI to guide management post-Fontan using cardiac MRI for routine screening. So now we can look for any Fontan pathway stenosis, which can limit the ventricular preload and result in Fontan circulatory failure over time. We can also look at maldistribution of pulmonary blood flow, which previous work have shown that it is associated with poor exercise capacity. And we can also use all the measurements that we use by cardiac MRI for volume and strain, as you can see in this paper. If the ventricle is very dilated or if the ventricular strain is low, it's associated with death or transplant. But all these nice studies come from single center. So if we're thinking about the big patient picture as a puzzle, each one of us holds just one little piece of that puzzle. And it's time to really come together in multi-center studies to try to understand the picture and also improve the outcomes. And one example I'm going to mention today is the FORCE registry, or the Fontan Outcome Registry using cardiac MRI. It started in 2020, and it built a nice research platform in 2022. And now it's striving to become a service for patients and physicians. So let's just look at how the data is structured in FORCE. So the clinical data is housed in REDCap, while the image-based data is actually housed in a cloud-based system called Ambra. The number of patients is increasing rapidly in this registry, and it's now more than 3,000 patients, making it the largest Fontan database in the world. And it's striving to do like automated pre-processing for all the images that we acquire by cardiac MRI. And this is something that takes attending physicians more than an hour to do. And now it's trying to do it through machine learning in about 60 seconds or so. So the workflow will be that the patient will come, get the cardiac MRI, and hopefully the images will go to that FORCE cloud service. They will do that processing really quick and send the information back to the physician very quickly. And because they also have the clinical data about these patients, they will put all of that in a nice risk score, and that will give us like a risk score specific for every patient, let's say for 5-year death or transplant. So that will be an image-based precision medicine for these patients. So to conclude, we covered a lot of ground today. So we looked at the single ventricle roadmap, and we mentioned that imaging plays a central role here in risk stratification and also in detecting complications, in this case, native aortic thrombus, and that our goal is to delay or prevent transplantation and refer at the right time. And also that multi-institutional collaborations are very essential. And we mentioned the example of FORCE, and there's also the Fontan Outcomes Network that Dr. Opatowski leads. And with that, I would like to thank our wonderful Fontan Kreutzer colleagues and also the FORCE registry team. Thank you.
Thank you. The next talk will be given by Dr. Chris Follansby, who's an assistant professor of pediatrics and an excellent clinical electrophysiologist. We're lucky to have him back, and he'll be telling us today about electrophysiology considerations in Fontan Kreutzer management.
Good morning. Thank you for the opportunity to be here to talk with everybody. As we've heard about from a variety of perspectives, arrhythmias have really been a troublesome component for the Fontan population since their inception. The atrial pulmonary Fontan in particular had notoriously high rates of tachycardia concerns, with some data sets showing incidence of atrial arrhythmias exceeding 65% in this population. This is from the Australia-New Zealand registry, which shows a more typical estimation of the mid 40% for the arrhythmia population. With each surgical advancement that we've seen a correlating decrease in the burden of arrhythmias going to the lateral tunnel and ultimately the extracardiac Fontan. However, this still remains a significant source of morbidity and mortality within the Fontan population. And this is not just from a tachycardia standpoint. We also see the same data emerge from a bradycardia standpoint, albeit to a lesser incidence than the tachycardias. As we've seen before, the predominant form of arrhythmia that we deal with is atrial tachycardia, which can result in loss of AV synchrony and increased end diastolic pressures, which is not well appreciated in a passive flow pulmonary system. This is associated with a significant thromboembolic risk with up to 19% incidence of atrial thrombus in the sustained arrhythmia population, as well as the onset of heart failure. It has historically been an ominous finding, with 52% of patients with late stage Fontan mortality being known to have persistent atrial arrhythmias. And in the AP Fontan population, it was particularly ominous, being associated with a 6-fold increase for the risk of death or transplant, which translated to a 6-year mortality rate exceeding 40%. Intraatrial reentrant tachycardia has by far and away been our primary adversary in this realm, accounting for up to 93% of the tachycardia mechanisms in some data sets. It's followed distantly by non-automatic focal atrial reentrant tachycardia, and then a small smattering of more typical forms of SVT. Intraatrial reentrant tachycardia is caused by the formation of scar lines, either surgical or from progressive fibrosis due to remodeling in atrial myocardial tissue. This results in electrical blockade, allowing the formation of slow conducting channels supporting reentrant circuits. The rule of thumb when it comes to IART is multiplicity of circuits, with AP Fontans being found to have an average of greater than 2 circuits per ablation attempt. Unfortunately, as we've heard, medication has had limited success and often complicates underlying sinus node dysfunction or ventricular dysfunction, limiting the use of beta blockers in this population. And unfortunately, we've also seen increased susceptibility to side effects with medications such as amiodarone due to impaired hepatic processing and increased iodine levels, leading to a high incidence of thyroid toxicosis with long-term amiodarone in the Fontan population. The good news is, though, that we've seen excellent advancements in the technology around 3D mapping systems, the advent of multipolar catheters that allow for rapid high-density mapping, and cooling tip catheters that improve tissue penetration, allowing for shorter procedure times with improved acute success rates. Currently, we enjoy acute success rates for IART ablation that reach up to 90%. However, this does need to be taken within the lens of that Fontan patients have the highest recurrence rate of arrhythmias within the congenital heart disease population, with studies showing 40 to 50% of patients will develop new arrhythmias within 1 to 3 years post-ablation. In that setting, we really should potentially think about catheter ablation more as a palliative procedure with the goal of decreasing hospitalization time, heart failure symptoms, and medication needs. Studies have shown that the atrial size as well as the low voltage area size are good predictors of recurrence. Our population is also changing with an ever-growing older population of Fontans, as we've heard about in our prior talks. And now we have significant numbers in the 3rd, 4th, and even 5th decade of life. And as we see this growing population, we're seeing a change in the composition of arrhythmias. This was an interesting study that was presented or that was published in 2017, looking at congenital or ACHD across the board, though also including single ventricle population. And what we saw is that we are seeing a slow transition of the paroxysmal and sustained IART, or the typical atrial tachycardias, being slowly replaced by the emergence of paroxysmal and sustained atrial fibrillation in our older patient populations. When they looked at potential etiologies that may be contributing to this transition, we see a change from our typical risk factors that we've known about, which included the increased complexity of their underlying congenital heart disease, bradyarrhythmias, as well as the presence of pacemakers, as well as the number of cardiac surgeries or atrial scar lines. And we've seen a transition to our adult patients, well, behaving more like adults. They now have older age, they have higher BMIs, they have hypertension, dyslipidemia, they smoke cigarettes, and they've developed coronary artery disease. And so in many ways, they are simply behaving more like typical adults. In response to this, though, the electrophysiologists, we've had to expand our thought process in our ways that we're going to manage our patients and potential therapeutic options, which has really moved us more towards the introduction of pulmonary venous isolation as a potential procedure to help deal with the burden of arrhythmias. In the setting of this, our approach has adapted somewhat. For our patients that have onset of sustained arrhythmia episodes, we have moved towards initially beginning with our comprehensive clinical evaluation to get a full understanding of the physiologic health of the patient, as well as any hemodynamic concerns that may be contributing to the increasing arrhythmia burden. We obtain cross-sectional imaging, as Dr. Al-Sayed just showed, that can help us guide procedural decision-making, as well as vessel Doppler ultrasounds, since access is never a guarantee in this patient population. We perform our procedures with a multidisciplinary team, including interventional cardiology, pediatric, as well as our adult electrophysiology colleagues when we plan for pulmonary vein isolation. We always perform a comprehensive hemodynamic assessment, which Dr. Goldstein will share us some more information about that in the talk to follow, I suspect. And then where appropriate, in addition to addressing the IART circuits, we perform a pulmonary vein isolation with our empiric short-term outcomes being very positive. A note about following ablation in our care. It is very important for aggressive anticoagulation following pulmonary vein isolation and aggressive IRT ablation in this population, given the very high risk of thromboembolic events. We have transitioned over to 2 to 3 month coverage with a DOAC, as well as 2 to 3 months of additional antiarrhythmic coverage, as this patient population has a high incidence of post-ablation irritational automatic tachycardias. Moving along, the next big component in the tachycardia picture is the ventricular tachycardias, which fortunately have had a much lower incidence than the atrial arrhythmias in this population. However, we still have many questions that surround the significance and really optimal management strategies of ventricular tachycardia in this population. But fortunately, as the universe tends to supply, 2 days ago, we had a new publication looking at the burden of ventricular arrhythmias in Fontan population. This is in the most recent issue of Circulation Arrhythmia and EP, and is published by the Stanford group. This is a single center retrospective study involving 431 Fontan patients from 2002 to 2019. In this, they had an overall ventricular arrhythmia incidence of 11%, which was 90% non-sustained VT, and very similar to what we typically see on our Holter monitors, where you catch triplets, quadruplets, and short, relatively slow monomorphic runs. They had 10% sustained runs and a relatively low incidence of malignant arrhythmias, which they defined as hemodynamically unstable at 2%. There were several key findings that were supported by this study and are fairly interesting. As most of us have long suspected, the risk of ventricular arrhythmias increases from the time of the Fontan surgery moving forward. And they confirmed this with a risk of 2.4% at 10 years and increasing to a 19% risk at 20 years post-Fontan. The malignant ventricular arrhythmia cohort, interestingly enough, had a lower age with a median age of 14.3 years compared to the median time to overall ventricular arrhythmia development at 15.9 years post-procedure and a median age of 21.3 years. This was also associated with worse baseline systolic function and AV valve regurgitation, which we've long known have been risk factors in this population. An interesting analysis is that they subdivided their cohort into a Stanford-only group, meaning Fontans that have only been cared for in Stanford, and their entire cohort, which included a large number of referrals for post-Fontan advanced care in an effort to control for selection bias in their referral population. When they ran their analysis or Cox multivariable analysis in both of these groups, only 2 factors bore out as statistically significant in both groups. The first was having a stage 1 repair with an RV to PA conduit, which had previously been demonstrated by Hall et al. To be a risk for the development of ventricular arrhythmias, and makes sense when we compare it to other congenital heart disease cohorts that are associated with ventriculotomy scars, particularly the tetralogy of Fallot community. Additionally, we saw that an increased age at the time of Fontan was associated with the risk of development of ventricular arrhythmias, which is consistent with data that we've seen in the development of atrial arrhythmias and sinus node dysfunction as well. Finally, a curious finding when they looked at the systolic function at the time of the diagnosis of ventricular arrhythmias, 65% of the patients had normal or only mild systolic dysfunction at the time of their arrhythmia diagnosis. But more concerning, in their data set, there was no difference in the long-term outcomes between the preserved systolic function cohort and the moderate to severely depressed cohort. While this could be a simple matter of sample size, not adequately able to discern the difference here, it is certainly concerning for those patients where we frequently see relatively short, non-sustained monomorphic runs on our Holter monitors. And probably the most impressive takeaway point from this study was the very strong association they had with the increased risk of transplant or death, with a hazard ratio of 9.2 and 48% transplant-free or 48% transplant-free survival at 5 years post the diagnosis of ventricular arrhythmias in this population. So it still leaves the question for us as clinicians taking care of this cohort of what we do when we finally diagnose ventricular arrhythmias. And for a large part, I don't think that we still clearly know what the optimal approach is. I think the data clearly supports that we need to be routinely surveilling for the onset of these. And when they are detected, comprehensive evaluation aimed at optimizing hemodynamic factors, as well as early consideration of potentially antiarrhythmic and heart failure therapies, may be even directed at our patients that have more preserved systolic function than we previously had thought. ICD implantation remains a difficult subject given the technical difficulties with placing an epicardial ICD lead. And unfortunately, Fontan patients have a low success rate for screening for subcutaneous ICD implantation as a less invasive option. Further compounding this, actually, in Stanford's experience, they had 7 patients with ICDs implanted, and none had an appropriate or an inappropriate discharge at a mean follow-up of 1.8 years. Which really, I think, in the end supports that ICD therapy may still be best targeted at the patients with a malignant ventricular arrhythmia presentation, particularly in the setting of diminished systolic function. The other question will ultimately be the onset of ventricular arrhythmias versus the optimal timing for consideration and evaluation of transplant therapy. Quickly, I do just want to talk about bradycardia and pacing. As my previous slide showed, there is significant sinus node dysfunction in the post-op period for the Fontan population. It's associated with decreased autonomic control of the heart, manifesting as decreased heart rate variability, depressed baroreflex sensitivity, as well as chronotropic incompetence seen in up to 62% of the Fontan population. The PD Heart Network registry shows an incidence of 13% of pacemaker implantation within the Fontan population, which in that specific registry is predominantly extracardiac. It's associated with lower quality of life, lower ejection fractions, increased risk of death, transplant, and Fontan failure, as well as ventricular pacing itself. It's associated with a 13-fold increase in the risk of death or transplant. This was a study from 2022, also out of the Stanford group, which was aimed specifically at trying to tease out factors with ventricular pacing that may modify the course for our single ventricle patients. Looking at kind of the classic path, they found a lot of the things that we suspected were true, though they were able to more definitively show. And as that we expected, there was a lower survival from moderate or worse ventricular dysfunction in the setting of ventricular pacing. There was a lower freedom from Fontan failure, and there was a lower freedom from transplant in patients that were being ventricularly paced. They were able to identify 2 protective factors for ventricular pacing, and that included a lower burden of ventricular pacing, which is denoted by the blue line on the left side, which would be defined as less than 85% ventricular pacing versus greater than 85% in the red line, as well as apical positioning of the ventricular lead, which is denoted in the black line versus the green line, which is non-apical lead positioning. Finally, they unfortunately did not have sufficient numbers to look at other mitigating factors, particularly multi-site pacing, which is the single ventricular form of CRT. This has really been a challenging enigma for the electrophysiology community, really going back even to the earliest studies, which has been plagued by low numbers and really mixed outcomes as far as clinical improvement. Even more recent studies from this is one from 2018 detailing the Boston experience with multi-site pacing. And even in this case, they were unable to show significant difference in outcomes at 5 years for multi-site pacing, which as far as this has led to shaping our approach, I think as an institution, we really aim to try to achieve an apical lead position where feasible. As our approach, and we particularly try to aim to minimize our ventricular pacing needs, either using adaptive pacing programming modes or by prolonging AB delays, trying to encourage intrinsic ventricular activation as much as possible. Regular surveillance is very important in this group for the early detection of dysfunction. And I think in the future, it will become a risk-benefit talk ultimately for multi-site versus transplant evaluation. But I think unfortunately right now, we haven't quite teased out exactly who the optimal candidate is for multi-site pacing or potentially some technical approaches that may help to ultimately improve our efficacy with multi-site pacing. Thank you.
Wonderful. Well, next speaker is Dr. Brian Goldstein. Brian is professor of pediatrics at the University of Pittsburgh here, and he's director of the cardiac cath lab. Brian was recruited in 2019 and brought incredible energy to our program, not only as an outstanding interventional cardiologist, but as a cardiologist in general, and especially because of his input on single ventricle management and particularly on clinical research overall for cardiology, giving his extensive expertise as a leader of the CCRC and other initiatives nationwide. Brian will be speaking about catheterization strategies for Fontan Kreutzer management.
Thank you so much, Jackie. And before I start, thanks to the organizers, Anita and Tarek and Arvind for putting this together. This is a really special day from my perspective to have everybody here and virtually present for an important conversation and timely conversation. Thanks to Jackie and Victor for supporting this meeting. And then I'm not sure where they are, but Angie and Drew for actually carrying out this meeting. Thank you so very much. We're going to speak a little bit this morning about catheterization strategies. But I want to, let's figure out, okay. I want to preface this by saying for my real disclosures, we're not going to go into a comprehensive approach to using catheterization and Fontans, but instead sort of pick out a couple of critical discussion points within this population and the modality that I think are worth drilling down on. So as an outline, we'll discuss first principles, physiologic principles of the circulation. We'll look at provocative testing maneuvers and why to use them, managing Fontan pathway obstruction. We'll discuss the diagnosis and treatment of cyanosis, and then we'll wrap up. So as I said, not a comprehensive assessment, but a real focused assessment on the things that I think are worth talking about. This is August of 2019 when I met the other Kreutzers. This was in Rio at a Fontan specific summit that was really in some ways in honor of Billy Kreutzer. My first time meeting you both, and it was a wonderful meeting. At that meeting, I was with David Cooper, but also Jim and Susie Tweddle. And Jim, as many of you who know him, was an extraordinary champion of single ventricle heart disease, specifically in hypoplastic left heart syndrome. And unfortunately, his untimely passing left a huge void in the field for all of us. But I speak in some ways in honor of him and his contributions today. So let's review first principles. In any circulation, blood flow per unit time is dependent upon the drop in pressure across the vascular bed and the resistance across that bed. So therefore, pulmonary blood flow is dependent upon both the change in pressure and the resistance. In a biventricular circulation, the subpulmonary ventricle, the right ventricle, does the work to generate this change in pressure. And in a pulsatile circulation, resistance is dynamic. There's endothelial responsiveness. So here, the biventricular circulation is characterized by low right ventricular pressure, low pulmonary arterial pressure, and low pulmonary vascular resistance. With exercise, cardiac output can be augmented substantially, about 5 times or more from baseline, relying upon an increase in right ventricular pressure and a concomitant decrease in pulmonary vascular resistance to augment cardiac output. However, in the Fontan circulation, the change in pressure is the difference between central venous pressure and single ventricle and diastolic pressure. And the resistance is often fixed inappropriately and sometimes even mildly elevated. So a decreased pressure gradient and a resistance that's either fixed or even increased results in less pulmonary blood flow augmentation. Even with a moderate elevation in central venous pressure, pulmonary blood flow is limited, which in turn reduces single ventricle preload and cardiac output. So here in the single ventricle circulation without a subpulmonary pump, cardiac output at baseline is about 70% of a typical biventricular circulation, somewhere near normal, but central venous pressure is chronically elevated. And with exertion, cardiac output can be augmented, but to something like 2.5 times, not 5 or more times, at the cost of a significantly increased central venous pressure and increased pulmonary vascular resistance. And with any pathway obstruction within the Fontan circuit, this precapillary obstruction only augments the degree of central venous pressure increase and reduction in cardiac output. So this is really my argument for provocative testing, which is at baseline, there's not such a difference between a Fontan patient and a normal patient. They look relatively similar. You couldn't pick out individual dots in separation in some ways. But during exertion, there's much more identifiable difference between maximal capacity of the Fontan patient and the biventricular patient. Arguing to utilize something that stresses the circulation or mimics exercise in order to tease out the true failures or faults within a particular patient's circulation. There are many limitations to hemodynamic assessment in the volume unloaded, anesthetized, supine, paralyzed patient. These are all negatives. So we try and avoid as many of them as possible. But stress hemodynamics in an awake patient may unmask underlying pathology that is otherwise concealed in a standard assessment in the cath lab. Exercise hemodynamics, well described. Sasha showed us an example earlier today, but they're really hard to carry out for a whole bunch of reasons. Other stressors, inotropic, chronotropic agents, or volume loading all have roles. I'm going to argue today that volume loading has an important role because it's easy to do, it's highly reproducible, and it's meaningful. But it has a typically limited role in hemodynamic assessment. But the Fontan circulation offers an intriguing case for rapid volume expansion as a technique. This population may be particularly prone to falsely low pressures after a prolonged NPO status. And patients are often symptomatic despite manifesting normal end diastolic pressure, low pulmonary vascular resistance, and preserved ventricular systolic function on their assessments. Only recently, really, has diastolic dysfunction, what I like to term Fontan HFpEF or FEFPEF, has become recognized as commonplace in the Fontan circulation. But here's an example. This is a 15-year-old patient with double inlet left ventricle Fontan, who's referred for fenestration closure due to exertional dyspnea. And you can see the A waves and end diastolic pressure are mildly elevated in this patient who's under sedation, something in the 11 to 12 millimeters of mercury range. But after receiving 15 cc's per kilo of normal saline, waiting for 5 minutes, you can see the A wave end diastolic pressure now reaches to something that looks more like 18, 19, or maybe even 20. So this is a problem that probably isn't going to be solved with fenestration closure or not. This is diastolic heart failure, and is, I think, helping us drive our strategies as a field of moving into medical management and guideline-directed therapy of diastolic heart failure. So when we looked at this was work I had done in Cincinnati, 46 patients who underwent a stress testing with rapid volume expansion. You can see that the ventricular end diastolic pressure changed substantially after exposure to fluid, whereas transpulmonary gradient, pulmonary vascular resistance, and cardiac output were unmoved. If you looked at individual responses, you can see baseline and final end diastolic pressure had a smorgasbord of values, but there were 35% of patients who manifest an end diastolic pressure of 15 or more millimeters of mercury after exposure to fluid challenge. What's more, if you look at the patients who ended up high, most of them tend to have poorer compliance. Their slopes are steeper. Even some of them started lower than others who had a flatter slope, but really increased their pressure. In univariate analysis, higher baseline pressure, end diastolic pressure, longer duration of Fontan circulation, and lower baseline cardiac index were all associated with a higher fluid challenge and diastolic pressure. Lower duration of Fontan circulation, longer duration of Fontan circulation was associated with greater change in EDP. And in multivariable analysis, only higher baseline EDP was significantly associated with the higher fluid challenge EDP. Occult diastolic dysfunction has now been looked at over a greater period of time. Dan Peck, who was a fellow in Cincinnati, looked at this about 7 years later, 84 patients now who underwent fluid challenge, and looked at over time the greater duration from Fontan. In general, the higher the post-volume load EDP. And this is true across a variety of things. That duration of Fontan circulation is the biggest risk factor for all sorts of problems. Here, if you look at the group that had a positive response or had occult diastolic dysfunction, 52% of them went on to meet a composite clinical outcome compared to 26% of patients who did not have the occult diastolic dysfunction. And here's the Kaplan-Meier curve looking at freedom from meeting a composite outcome if you had occult diastolic dysfunction or not. It was clearly a factor associated with worse clinical outcomes. And if you broke it down by duration of Fontan, on the right are those patients who had more than 10 years out from Fontan. And you can see that that separation is statistically significant, that having diastolic disease is a greater factor beyond just duration of Fontan for that outcome. And we've also done work, like Sasha suggested, of in cath lab exercise. There's other ways to do this, but it is really cumbersome and hard for patients to do. Pulmonary vascular resistance, we'd shown previously in patients with exercise, doesn't change. It's supposed to fall substantially. This is normal. It should be low and fall substantially. And in Fontan patients, it's really inappropriately high. And this is work we've seen earlier from Grushin Veldman and his team looking at invasive venous pressure measurements, showing a rise in central venous pressure with exertion compared to controls. Intervention, we're going to sort of move on now. Intervention after Fontan-Kreutzer is really common. This is work we had looked at through the C3PO group many years ago. How do I get out of this? Thank you very much. 77% of post-Fontan cardiac catheterization cases were interventional in nature. So we find things to do. What do we find to do and what really needs to be done? Well, this is a first principle statement. Early relief of anatomic pathway obstruction is important in the Fontan-Kreutzer circulation. It's hard to make this a data-driven statement because the patients are still young, the procedures are still young. We just saw for the first time, I think last week or 2 weeks ago in JACC, that pulmonary valve replacement in tetralogy is associated with improvement in mortality. We just saw that. Yet we've been talking about this for a long time. So it takes a while to generate the evidence. But this is a first principle statement that having obstruction to egress of liver outlet and everything else, to all of the lower extremity venous capacity, to getting back to the pulmonary vasculature during exercise, that's a problem. And so we can treat it. This is the use of a coverage stent to simultaneously relieve stenosis and also eliminate right to left shunt. Here's a patient who was young, early after Fontan procedure, had a sort of surgical misadventure with some IVC injury that was patched at the time of the Fontan. And you can see hiding below the conduit is a pretty substantial obstruction, which if left, if not surveilled, would be a really problematic approach for this patient. This was missed by non-invasive imaging, but was found because a lot of providers are now starting to do early surveillance after Fontan to ensure the anatomic repair is ideal. And so this can be treated with stent therapy, of course. And here's a patient who's late after Fontan who has had pathway obstruction and now has the complication of thrombosis within the pathway obstruction. So we can do more treatment of this, but this is likely to be problematic to join the presence of anatomic disease as well as hematologic problems. So what do we know about the use of treatment or the use of conduits and lateral tunnels in Fontan? Well, if you look at these patients here, lateral tunnels in red and extracardiac conduits in blue, this is the percent change in Fontan minimal cross-sectional area. And you can see that the conduits in blue below, they're dotted everywhere, but there's a 50% loss from baseline in patients even early. And so conduits behave like conduits in other locations, and you should expect that conduits over time will not look at this as the same size as they were put in, and they'll need to be treated. This was work from Emer McGovern, who's in Cincinnati, Kentucky, and she showed that if you had your Fontan earlier, you were more likely to need a stent later. And that's probably a consequence of using a smaller size conduit or having anastomotic issues related to the conduit. This is work from the Boston group. Doc McElhenney led this, showing that if you treat lateral tunnels and you look at the CFD data during baseline or with exercise, you can normalize the fluid dynamics across the tube graft or the lateral tunnel by relieving stenosis. And in fact, the future is probably different than it is at present, as it is with so many things. These are using the X-graft concept. These are dilatable conduits that our team has been putting in Fontans now for a while. This is a picture, of course, of an RV to PA shunt, but the concept holds true. We may be able to put in these tubes a little smaller than what's needed as adults and have better laminar flow characteristics as children, but then anticipate dilating those conduits to match the needs of the adult without having to worry about the Gore-Tex or homograph conduit being resistant to that dilation because it's purpose-built, it's baked into the design of the conduit. I'm going to skip this. So identifying the mechanism of cyanosis is the other sort of important topic I want to talk about. And we're going to race through a little bit so we don't get further behind today. But I think it starts with understanding the potential mechanisms of cyanosis. And there are many and varied, and some are easier and more straightforward than others. So veno-venous collateralization, I think, is straightforward. Persistent left SVC to coronary sinus, I think we all anticipate this, but we're going to throw a monkey wrench in that when we show a case example in a second. Obviously, fenestration or baffle leaks, lung disease, of course. AVMs are complicated, and AVMs can be due to differential delivery of hepatic factor. We saw a nice 4D flow example earlier of demonstrating the distribution of hepatic factor of IVC egress to both lungs or to no delivery of hepatic factor, and then others. So I just want to show a case that sort of illustrates some of the complexity of what we do. This is an 18-year-old female, doubling the AV valve with hypoplastic left ventricle, underwent a PA band and then a right glen, had LSVC coil embolization during the pre-Fontan cath, and then had Fontan completion. And there's severe functional limitations due to resting cyanosis, clubbing, exertional dyspnea, and cyanosis, and had a catheterization a couple years before that revealed no findings. And the cardiologist and the patient were both frustrated with that there was not an answer or a fix, and so came back a couple years later for a new question. And really, there's no interesting findings here apart from the fact that the aortic saturation is a little low at rest in the mid 80s. Maybe the outputs are a little low. And this is not this particular case, but this is an example of the idea of retrograde assessment of pulmonary veins to ensure that there's not pathology focused in a pulmonary vein. You can go backwards through the heart, through the aortic valve and the AV valve to get into the pulmonary veins and find disease. So here, left lower pulmonary vein was desaturated, and we ultimately found veno-venous collaterals going to that segment. In this particular patient, though, when we went to go engage the pulmonary veins, we actually engaged the coronary sinus and got into the left SVC. And lo and behold, what connects to the left SVC there is the hemiazygous vein. And so what had happened is this patient underwent coil occlusion of the left SVC, but at a location that was higher than the azygous or hemiazygous insertion, which allows for persistence of the hemiazygous communication to the left SVC, to the coronary sinus, but prevents our ease of both identifying it and treating it. So we were able to use a large sheath that was thankfully just long enough to get all the way through. This is just looking for an entrance into the azygous or hemiazygous. Oftentimes they're off the renals. We didn't see one easily, and since we had gotten through retrograde, we just just went with it. And we're able to deliver a 16 millimeter anaplastic vascular plug retrograde through the aortic valve and AV valve into the coronary sinus and relieve this patient's obstruction. We went on to find some pathway obstruction in the conduit and treated that as well. And so now you sort of have a tuned up vasculature. And this patient had a great story. Pulse ox immediately high, functional limitations essentially all resolved over the ensuing weeks to months, clubbing resolved, and was able to go on to participate in intramural collegiate swimming, which is pretty cool. So I want to move on to another story real quick because I know we are tight on time. This is a patient who has heterotaxy, interrupted IVC, mixed type veins to a confluence behind the atrium, and underwent a slew of procedures to ultimately get to Fontan. But they went from it includes a bidirectional gland, right bidirectional gland, left Kawashima because of the azygos. And incorporation of the hepatic veins directly into the hemiazygous vein as a manner to deliver hepatic factor into the Fontan circulation with ligation of the right-sided veins to the connection to the atrium. This patient was lost to follow-up for a period of time, but represented with cough, dyspnea, and profound desaturation. They're admitted to the hospital for further evaluation. They're found to have really minimal oxygen responsiveness, identified to have severe developmental delay, behavioral problems, including self-injurious behavior. The workup was negative for infection, routine labs were unrevealing, and they were referred for catheterization. And in the cath lab, we found, I would say, nothing too terribly exciting, a Fontan pressure of about 15, an end-diastolic pressure of about 11, and cardiac output that was pretty reasonable. And we found what appear to be severe AVMs on the right side. You can see the sort of reticular pattern for diffuse AVM disease on the right. And in the central pulmonary artery, there was a relative stenosis. And if you bring the catheter back into the hemiazygos, you can see that the hemiazygos, which is carrying, of course, the hepatic venous effluent, really only commits to the left lung, which doesn't have significant AVM disease. And here you can see from the hemiazygos picture, you can see the little stub of where the hepatic veins come in. That's really only filling the left pulmonary artery. We went and looked for things off the renals, and there's a little bit of venovenous collateralization, but not too much. We demonstrated that the hepatic veins do enter normally into the hemiazygos without obstruction. And so we sort of thought about this and said, seems like the central pulmonary artery stenosis is obstructing the hemiazygos hepatic venous egress to the right pulmonary artery. So if we treat that, we can resolve the problem. So let's put a stent in the central pulmonary artery. And that's exactly what we did. Here's a stent in the pulmonary artery, and now hemiazygos blood reaches the right lung. Hooray. So post-cath, the saturations were the same, of course, despite the use of oxygen. She went home with the expectation that the AVMs would resolve over time. 4 months later, nothing changed. She was readmitted to the hospital, in fact, not long after that, with cough, dyspnea, worsening desaturations, and found to have a large right hemorrhagic pleural effusion, which is really uncommon. So she came back to the cath lab. Before coming back to the cath lab, we performed what I think is the most critical thing. We looked backwards at the data. And it's really important to make sure that you understand what happened to a patient to get them to where they are now, because things will be revealed. So in this patient who had this imaging before they became a Fontan, this is a balloon occlusion picture in the hemiazygos vein. You can see lots of venous collateralization, but what you also see, if you're keen to pick this up, is connection between the systemic circulation and right here, the portal venous circulation. So these are early right to left shunts, but late systemic to portal venous shunts. And that portal vein is highlighted here. So this patient had known systemic portal or portosystemic connections. These were never addressed in any means. So following the surgery, systemic to portal shunt direction reverses, of course, and now mesenteric flow is shunted away from the portal vein to the systemic vein. This shunt will not be identified on a routine hemiazygos angiogram now, it's going the other direction. But the liver, importantly, will not be presented with the mesenteric venous egress to actually cleave this and produce the hepatic factor, which then prevents the development of AVM. Instead, the pulmonary artery stent that we put in would be anticipated to augment portosystemic shunt by reducing resistance to flow to that AVM lung, which resulted in the patient's presentation. So we did some additional investigations. Portal vein ultrasound, can't find it. CT scan, can't find it. Systemic ammonia level, over 130. This is really important because this explains this patient's developmental delay, self-injurious behavior, all these things. So now we propose an intervention to assess hemodynamics, embolize all the portosystemic shunts, and create a band back in the central PA to limit flow to that right pulmonary artery. And it's hard to do these things, but now we found a pressure of 23 in the Fontan circulation and end diastolic pressure of 17. So we've actually made things substantially worse. And of course, because of all this AVM, now the systemic vascular resistance is low and cardiac output's quite high. So I'm going to mostly skip through this, except to show you that you can create temporary change in circulation such that you can create flow from the systemic back to the portal circulation by balloon occluding flow below the hepatic venous egress. So now the flow through the hepatic vein circulation is actually lower resistance than transiently the lower hemiazygous vein. You can get into those shunts where you can embolize them. And in fact, you can get through them and find the portal veins, which now are tiny because they haven't had blood flow for 10 years. And you could go through a series of phase treatments to manage this. And so we did all those things, and I'm not going to go through all of it, but we made the patient ultimately better through a series of procedures. So in conclusion, there's no magic in magic. It's all in the details. Catheterization data are highly dependent upon the circumstances or state at the time of data acquisition. And we have to remember that when we go back and interpret them. Dynamic testing increases the likelihood of identifying things like occult pathologies like diastolic disease. Relief of the Fontan pathway obstruction is critical, in my opinion, to longevity of the circulation. And significant cyanosis requires a rigorous and thoughtful investigation, especially in cases of heterotaxia and interrupted IVC. Thanks so much.
Good morning. It's my pleasure to introduce our next speaker and thank him for leaving beautiful San Diego to visit us in what is a fairly nice weekend here in Pittsburgh. I'm speaking about Dr. Laith Al-Shwabki. He is an associate professor of medicine at University of California at San Diego and is the director of their adult congenital heart disease program.
Thank you so much, everybody in the organizing committee for inviting me here. I was talking earlier with someone that we haven't seen the sun in San Diego in 2 months. So I got my tan this morning walking over. So today I will focus the conversation about transcatheter edge-to-edge repair with a clip system of the atrioventricular valves in patients with the Fontan-Kreutzer circulation. Many of you have talked, and Dr. Goldstein eloquently described the data with rest and exercise, with the differences between the Fontan and the regular circulation. But moving forward to the Fontan hemodynamics, remember that the left atrial pressure is just one step before the LV EDP or the single ventricle EDP. And the combination of these two might determine the cardiac output and oxygen delivery for a lot of these patients. And therefore, systemic atrioventricular valve regurgitation is critical in long-term survival for these patients. This is data from Tariq that he published a few years ago, showing that severe or moderate systemic atrioventricular valve regurgitation was the strongest predictor of mortality in these patients. And I really like this paper because he lumped the ventricular dysfunction and AV valve regurgitation. And that's reflective of our inability sometimes to tease out the true underlying ventricular function in patients with severe AV valve regurgitation in Fontan and other circulations as well. But before embarking on any intervention for our patients, it's important to emphasize that this is a multidisciplinary conversation. And before putting a patient on the cath table, you have to really make sure that all the stakeholders have had a chance to review the primary data and weighed in multidisciplinary open forum. But importantly, the committee has to conclude that this particular intervention is most likely to result in benefit to this patient. So with that in mind, I will go over a few cases. This was early on in our experience. This patient was born with complex cyanotic congenital heart disease. She had crisscross AV valves, hypoplastic tricuspid, and left-sided morphologic right ventricle. And she lived all her life across the border in Mexico and presented in late 30s and underwent a percutaneous Glenn anastomosis due to profound cyanosis. And that gave her a lot of stability for about 4 or 5 years. until she presented now with significant worsening of her functional class, this time due to severe mitral regurgitation. It's important in this particular anatomy to remember that the course of the catheter will depend a lot on the relationship between the inner atrial septum and also the atrioventricular valve. And in this particular patient, that was very challenging. You do need an anchor for the guide catheter when you're crossing the inner atrial septum. So you can't really utilize, most of the time, you can't utilize any pre-existing atrial septal defect. So this is her intra-procedural TEE. And again, you appreciate the crisscross relationship of the AV valves. This is the hypoplastic tricuspid valve. You're seeing it on FOS. And this is the mitral valve. So before, obviously, these patients go to the cath lab, we do a detailed TEE. And this particular patient didn't really have dysplasia of the mitral valve. It was of normal morphology. But what you see is that there's tethering of the posterior leaflet and there is some prolapse of the anterior leaflet, culminating in severe mitral regurgitation. In these complex patients, sometimes we do 3D modeling and even mock procedure. And for this patient, we concluded that the ASD was really in an unfavorable location. You have to cross the septum natively. So coming up from the IVC above the tricuspid valve and far away from the ASD was our point of entry to achieve sufficient height for the guide system to cross and also for the clip delivery system to straddle the valve. So this is the ASD here, and this is the guide crossing the inner atrial septum. And this is after 5 hours. And you see here the clip has basically caught on the anterior and the posterior leaflets in the, you can call it A2, P2 position, and creating a double orifice valve and reducing the regurgitation to a mild to moderate degree. So this patient improved her functional class and was able to regain her functional capacity. It is interesting sometimes in some of these patients, while there are many, many challenges, there are also opportunities. In a usual anatomy, sometimes it's a balance between how much regurgitation reduction you achieve versus stenosis of the valve that you cause. In patients who have 2 inlets of AV valves, you can actually be fairly aggressive in clipping the AV valve in those patients. The second case was a 15-year-old male, really sick, heterotaxy, unbalanced RV dominant AV canal, had repair palliated to an extracardiac Fontan-Kreutzer in childhood, and presented really late, unfortunately, with failing Fontan, cardiogenic shock on milrinone transfer to our center from out of state for consideration of transplantation. When he presented to the hospital, he was in dire straits and he was on multiple inotropes and barely able to breathe, even sitting up. And it was a decision between whether ECMO or try to achieve some type of a bridge by reducing the AV valve regurgitation until he is able to get transplanted. So this is his transthoracic echo. And as you can see, the systemic atrioventricular valve is just wide open. You might grade it as torrential. And in those patients, unless you have a hyperdynamic ventricle, this ventricle is really, really sick. So you have to kind of remember that. And you can see here, there's a very large coaptation gap between the leaflets, really across all commissures, traversing both sides of the ventricle. Okay, how do you get out of this? And now for this procedure, we were able to cross the extracardiac conduit somewhat in similar fashion to usual anatomy, and we're able to achieve enough height above the AV valve to straddle and then introduce the clip across the valve. And in earlier experience, even with the usual anatomy mitral clip system, there are some contraindications regarding how big of a coaptation gap you can tolerate. But with the second and even newer generation clip systems that are wider, that are less likely to cause tearing of the valve or injury to the valve itself, you really, if you're able to capture both leaflets adequately within the clip arms, you should be safe. And in this patient, we're able to reduce his torrential AV valve regurgitation to now severe. What's not shown here is that the left atrial pressure at the beginning of the case was about 30 with V waves up to 60. And once one clip was positioned, the V waves dropped to 30 and the mean pressure was around 15 to 20. And at that point, due to severe systemic ventricular dysfunction, we decided to stop and not proceed further. And basically, we've achieved our objective to bridge this patient who underwent successful transplantation. This is the last case. This patient was 23 years old, double outlet right ventricle, complete AV canal, mitral atresia, palliated to a lateral tunnel. Obviously, what Dr. Goldstein had discussed earlier, this patient developed very early Fontan pathway stenosis and underwent a stent that was later restented due to fracture of the Fontan stent. And he came to us with failing circulation due to severe TR, but also had moderate RV dysfunction. It was functional class 3, really limited, inching to 4. Unfortunately, not a candidate for transplantation due to overwhelming social challenges with his family. So the decision of the committee was to proceed with transcatheter edge-to-edge repair and see if we were able to reduce his regurgitation. The challenge was presence of 2 overlapping stents within the Fontan conduit. So really, it wasn't an option to go in the usual pathway across the Fontan. And what we ended up doing was going from the right-sided glen, and which happened to be in close proximity to the roof of the atrium in a straight shot. And we were able to land the clip immediately above the valve from the neck of the patient. And what you see here, this is the stent in the Fontan, which is left-sided. And also we used IVUS at the same time, or ICE, intracardiac echo, to be able to visualize tenting of this catheter across the atrium. And what you see here, you see the clip arms open as it's below the valve, attempting to capture the leaflets within the clip arms guided by TEE. And you see a similar picture here in TEE, traversing the roof of the atrium, straddling the valve, and finally we're able to capture the leaflets with one clip, and which was deployed. And here you see double orifice, really good tissue bridge, and that reduced the regurgitation, but he continued to have significant regurgitation. So we needed to deploy a second clip immediately lateral to that first clip, which was deployed successfully intraprocedurally here. And his regurgitation was reduced to mild to moderate. However, on next day follow-up, we noted that that second clip had detached from one of the leaflets, but remained fairly well anchored to the other leaflet. So that's what we call single leaflet detachment. And his TR was in the moderate range, but due to functional improvement for the patient, we just continued active surveillance and did not do any further interventions at this point in time. So our experience, we've done about 15 cases, adults with congenital heart disease, 4 with single ventricle, And for the large majority, we're able to reduce AV valve severity, regurgitation severity after the procedure. And there has been some significant improvement in New York Heart Association functional class. We are actually submitting our data and pooling it with another center. Together, we will have more than 30 cases. So it should be coming out soon. From our experience, also, we've learned that for a lot of these patients, the thinking of considering advanced therapies or similar interventions sometimes is late. And you just have to kind of raise awareness and availability of this technology for these patients. Valve anatomy is paramount. You can't just deploy a clip in any valve. You really have to study the valve carefully for adequacy. And if it's a candidate, then most likely you should be able to deploy the clip. Puncturing the baffle could be challenging, and you have to be creative in finding alternate access. At the end of the day, really, most of the work that we do before the cath and during the procedure has to do with positioning, where you exactly cross and introduce the delivery system. That is going to be probably the most important part of the procedure, not the deployment of the clip, because that positions you well in capturing the leaflets in their entirety and not have single leaflet detachment issues happen. And also, obviously, we have to be aware of the nuances of the anatomy. Some patients, the AV valve might be too close to the outflow tract, so you can't really deploy something underneath the valve. But also, there are some opportunities for single ventricle patients. And finally, what I've learned during this process is that partnering with our adult structural colleagues is paramount. And it is important because I spend a lot of my time with them doing structural imaging while they do clips for usual anatomy. And that's how I was able to bring this technology to our ACHD patients and for us to work comfortably together to be able to handle those kind of cases. Thank you.
Thank you. It's a pleasure to introduce our next speaker, Dr. Shahid Malik. Dr. Malik is an associate professor in the Department of Gastroenterology and a transplant hepatologist here in Pittsburgh. He's going to speak to us today about Fontan Kreutzer-associated liver disease.
Thank you. It's an absolute pleasure to be here. I see quite a few Fontan patients, so I'm here to share my thoughts and to learn. So the last time I was in a group with so many cardiologists was last week. I come from a family of cardiologists. My dad is a cardiologist. My two older brothers are cardiologists. The youngest is a pathologist, so half a doctor. So this was the proudest day of my life. Not necessarily that I had a daughter, but if you look at the bell of her stethoscope, it is instinctively placed in the right upper quadrant. So a future hepatologist. I think I took it too far when I brought her to the GI lab and I showed her where this thing is inserted. She doesn't want to be a doctor anymore. So this is my outline. I'm going to touch briefly on pathophysiology, talk about incidence, risk factors for progressive disease, clinical manifestations, liver cancer. How do we assess and predict a patient's course? And then the last half, I think I'm obliged to at least touch base on transplantation. I'm going to try to do this centered around a patient case. So a 42-year-old male referred to me from cardiology for abnormal imaging and abnormal liver test. He underwent a Fontan procedure at the age of 7. Per cardiology, the heart failure team, he had NYHA class 3 and met minimal listing criterion for heart transplant. His heart transplant was unlikely to be imminent, but they needed liver clearance. So these are his labs: a mild elevation in bili, which is predominantly unconjugated, a GGT about 3 times upper limits of normal, other pertinent labs, maybe some mild thrombocytopenia. Imaging shows a clearly cirrhotic liver with dilated hepatic veins. He has scant perihepatic ascites, mild splenomegaly, and some tiny collaterals in the upper abdominal wall. So liver fibrosis following Fontan was first recognized in 1981. Some degree of fibrosis is universal within the first few years. The Fontan circulation leads to elevated pressure within the hepatic veins and sinusoids, which leads to continuous and non-pulsatile passive congestion. In turn, this compromises portal venous inflow. The liver in Fontan physiology is therefore more reliant on hepatic arterial inflow and susceptible to changes in arterial circulation. So a combination of all of these factors, pressure, blood flow, congestion, oxygenation, complement and cytokine activation, neurohormonal regulation, and even the microbiome ultimately leads to hepatic fibrosis and portal hypertension. Abnormal liver tests are seen in 1/3 of Fontan patients. It's of course recommended that you rule out other forms of chronic liver disease, especially viral hepatitis, Hep B and Hep C. It's imperative that you counsel patients on avoiding secondary insults. You learn very quickly in liver disease, 1 + 1 does not equal 2. So anything you can do to avoid specifically fatty liver and alcohol is incredibly important. Our patient, his chronic liver workup was negative, viral serologies were negative. He had a moderate alcohol history. We counseled him to stop. His BMI was 31, but there was no obvious fat seen on imaging. The development of ascites almost always prompts a liver consult. You can usually determine if it is cardiac in nature by interpretation of the fluid analysis. Typically, cardiac ascites will give you what we call a high serum albumin to ascites or SAG gradient and a high total protein. BMP has also very good sensitivity and specificity. Our patient did undergo a one-time TAP greater than a year ago, and his analysis was very consistent with cardiac ascites with a total protein of 5.1. The incidence of varices also in about 1/3 of patients. Bleeding, however, is uncommon. All appropriate patients should undergo a surveillance EGD. Our patient underwent an EGD and there were trace to small esophageal varices. So if you take one home message from my talk, it's probably this one. The development of advanced fibrosis or cirrhosis occurs in up to 1/2 of Fontan patients by their mid-20s. That's a relatively high incidence when you look at the other most common causes of chronic liver disease in the United States. Hepatitis C, about 1/3 of patients will develop cirrhosis in a span of 30 years, alcohol about 20%, fatty liver disease about 5 to 8%. So how do we assess degree of hepatic fibrosis? There are some emerging blood tests that have not been yet validated in Fontan patients. I'm going to be focusing on elastography and liver biopsy. More and more, you will see that the use of elastography as a means of non-invasively determining hepatic fibrosis in all forms of liver disease, and there's increasing literature regarding its use in Fontan patients. So the top left is an image of a FibroScan, which we have available in our clinic. It can give you a read in about 5 minutes. The next two images are ultrasound with shear wave elastography. The nice thing about that is you also get a decent image of the liver. And then lastly is MRI. So the most accurate measure in 2023 is probably MR elastography. A measurement of 4 kilopascals is generally considered advanced fibrosis, and there is emerging data on its correlation with Fontan failure, portal hypertension, and longitudinal follow-up. Our patient had a pacemaker, so we couldn't get an MR. His ultrasound correlate was F3 fibrosis. These are MRI images with their corresponding stiffness maps below. So red indicates more fibrosis. Just as a reference, this was a patient I saw this Wednesday in clinic, a 32-year-old who likes her vodka. And you can see her KPA is an impressive 10. At the moment, however, liver biopsy remains the gold standard for the diagnosis of Fontan-associated liver disease and degree of fibrosis. But as much as we love biopsies, mainly because we're, I think, spoiled here in Pittsburgh to have some of the best liver pathologists in the country, it does have multiple issues. There's sampling error, risk of bleeding, patient comfort, and it's not suitable for longitudinal monitoring. The transjugular route especially can be challenging given the venous anatomy. So this study is the basis of what we quote when it comes to advanced disease in Fontan patients. 74 patients undergoing biopsies, median age was only 17. Over a third of patients had bridging fibrosis defined as F3 or full-blown cirrhosis. Most of us will default to a transjugular liver biopsy because it allows us to obtain pressures, which of course have huge prognostic information, but this too is problematic. A lot of the times the samples are fragmented and many times they underestimate the degree of fibrosis. And the pressure measurements may not always be accurate in Fontan patients because of the presence of veno-venous collaterals. So back to our patient, he did undergo a transjugular liver biopsy. His wedge was 15, his free was 13 for a gradient of 2. So remember, portal hypertension is defined as a gradient of greater than 5, clinically significant portal hypertension, a gradient greater than 10. His histology revealed portal to periportal fibrosis. Changes were consistent with advanced chronic congestion. There was architectural distortion. Overall, you would summarize these biopsy findings as early cirrhotic changes. Here's a representative image of his trichrome. Here I'm just highlighting the sinusoidal congestion and the hemorrhage, which is classically seen in outflow obstruction. And over here, I've highlighted an area of bridging fibrosis, and you can almost make out a nodule. Hepatocellular carcinoma deserves special mention and is an increasing recognized occurrence in Fontan patients. Most of the evidence for surveillance is based on this research letter published in 2018, quoting an incidence of 1.3%. The concerning thing is that many patients are being picked up with advanced and metastatic disease, and equally disturbing, half of the patients are reportedly do not have cirrhosis. Currently, if you look at surveillance for HCC in our general liver population, it is restricted to patients that have cirrhosis. The exception, of course, is Hep B. So I think this is something we need to have more data on. What modality to use is also hugely problematic, in my opinion. This study suggests that ultrasound is probably inadequate. But as we know, MRI is not feasible in many of our patients, and subjecting them to Q6-month contrast CTs is probably not the right thing. Our patient imaging showed cirrhosis, but no obvious lesions. His alpha fetoprotein was normal. So the evaluation and management of Fontan patients from a liver perspective is challenging and requires expertise, but is not the major issue I believe we are facing. The single biggest issue ultimately becomes the role of transplantation, namely combined heart transplant versus isolated heart transplant. This was my fortune the other day. An expert is someone that knows so much about so little. So how do we assess severity in liver disease in liver patients in general? Well, we have multiple scoring systems. The most widely used are the MELD and Childs. Of course, none of these were designed, nor have they been validated for Fontan patients. How do we predict outcomes or risk assess? The two most commonly employed risk calculators are the Mayo MELD risk assessment, which incorporates the MELD score, plus the patient's etiology, cirrhosis, ASA score, and age. And the relatively newer Penn vocal score. These scores definitely have their place, but as you can see, they don't allow an input for transplantation, and honestly are useless when it comes to predicting transplant outcomes. The biggest problem with these scores, in my opinion, is that they almost completely ignore portal hypertension. The other reason these scores won't bode well in cardiac and Fontan patients is because many of the parameters are just not reliable. In this particular patient population, LFTs can't be used because of congestion, albumin is depressed, and 50% of heart failure patients, INR is influenced by anticoagulation. Many patients are on diuretics, which influence the kidney function. When we touch base on imaging, elastography, liver biopsy, and HVPG, and their reliability. So when should you proceed with an isolated heart versus combined? Nobody knows. There is very limited data. In fact, most centers are now defaulting to combined, although this is a cautious and prudent and maybe easy thing to do. Is this always in the patient's best interest? Combined heart transplant is a rare phenomenon, and although recently there may be a slight uptick in cases, historically they make up a tiny sliver of transplantation. With regards to combined, these are case series from the large centers of patients undergoing combined, Stanford, Penn, and Mayo, with very good outcomes, limited data, obviously, with a total of only 25 patients. Combined liver organ transplant provides an immunological benefit, obviously, that cannot be under-recognized. Studies confirm a decreased incidence of rejection with the hypothesis that the liver confers immunotolerance and protection against rejection in the setting of multi-organ transplant. But I think the more important question is combined always necessary? Are we disadvantaging a group of patients by subjecting them to combined transplant? Unfortunately, the data on Fontan patients undergoing isolated heart transplant is also quite limited. A quick word about the pediatric population, a total of about 47 children. Outcomes are very good. So some evidence to suggest that if the patient is very young, isolated heart transplant may be okay. With regards to the adult side, there are two small single center studies. This one from Emory, which did include a few pediatric patients. This study wanted to highlight the short-term successful outcome, but also the radiographic improvement visualized in the liver before and after transplantation, which is impressive. This study is from the Toronto group, 14 adult patients undergoing isolated heart transplant with a follow-up of 5 years. 4 died within the first year, 8 were alive at 5-year follow-up. So I don't know if these two studies make you feel better. I think the bottom line is there probably is a subset of patients with advanced fibrosis who are okay to undergo isolated heart transplant, but we need to do a better job of teasing this group out. I personally think this is the most difficult question we were asked as liver specialists. Data is limited. There are 0 validated guidelines. There's differing opinions, and the stakes are obviously incredibly high. Nobody wants to be dealing with a failing liver following a heart transplant. This is the face I get every time I get asked by my cardiology or pulmonary folks to clear a patient for transplantation. Our patient was deemed too high risk for isolated heart. He's currently listed for combined. I'm not necessarily convinced he needs a liver, but again, these are difficult battles, I think, to fight. It is my opinion that one score or measurement is not enough. You need experience and must review everything: exam, labs, imaging, biopsy, endoscopy, pressure, and then you kind of get a gestalt on how the patient should proceed, but we must be more systematic about our approach. I've been helping the lung group come up with an algorithm for their patients with cirrhosis, and I labeled it the PENCEP score. We're hoping to get this published soon. So this is my proposal for Fontan patients. I'm unveiling it today. So it is called the PESFEC score, Pittsburgh Exclusionary Score for Fontan patients undergoing evaluation for cardiac transplantation. Trust me, the score is anything but perfect. But here it is. So what you do is you exclude isolated heart transplant if you have any of these 10 things. So a high SAG ascites with a total protein less than 2.5, SPP, HRS, portal pulmonary hypertension, HPS, medium to large esophageal varices or perivaricial bleed, history of encephalopathy, HCC. Now, this is not that complicated. This is basic stuff for a transplant hepatologist, but here's where it gets a little intriguing. I'm proposing the addition of shunt presence on imaging. I don't have a lot of time to delve deep into this, but there is very strong data on measuring shunts on cross-sectional imaging and the correlation to outcome in liver patients. The other thing I think we need to do specific to Fontan patients is revisit the HVPG. HVPG data and transplant is extrapolated from liver patients with Hep C undergoing kidney transplantation, and historically a cutoff of 10 has been used to determine the safety of isolated kidney versus simultaneous liver kidney. The problem is the presence of collaterals in the Fontan patient. So if you get a value of less than 10, are you going to feel comfortable saying that this patient does not have portal hypertension? I think we need to start incorporating direct portal vein measurements. So what I'm proposing is a transhepatic approach via IR. and a pressure greater than 10 directly in the portal vein would exclude a patient from an isolated transplant. This needs to be studied, obviously. I'm proposing we obtain HVPGs and direct portal vein measurements in about 10 Fontan patients and determine the correlation or disconcordance between these measurements. So this would be a transhepatic approach to portal vein. So that's my algorithm. You got to look at everything, review everything ad nauseum. I have some work to do. I'm not sure when this will fully come out, but I realize there will be some more talks on Fontan and liver transplant. I'm hoping, some of these ideas will be a springboard and perhaps some future collaborations. So my top 10 take-home points: Fontan-associated liver disease is universal. Advanced disease occurs in up to 50% of patients by the age of 30. You must rule out other forms of chronic liver disease. You must avoid secondary insults. The role of elastography is expanding, but biopsy remains the gold standard. Biopsy and HVPG have their issues. Surveillance portal hypertension, EGD, must be performed in patients with advanced fibrosis. Surveillance of HCC should probably be performed. When to proceed with isolated versus combined remains unknown. And 10, I'm proposing an exclusionary score with the addition of direct portal vein measurements. Thank you.
Well, wonderful. Those were incredible presentations. We are running a little bit late, but I think we can take a few minutes for some questions.
Just a quick announcement for the virtual audience. We will have the virtual poster session, which is virtual only, starting after the panel discussion. So we'll not start until after the panel discussion. This was a separate link that you received through email. Thank you.
We're going to take some of the questions from the audience. There's two questions. This looks like it's related to EP. How do you demonstrate bidirectional block after curval tricuspid isthmus ablation in a Fontan? Can you please describe the catheters used? And then if pulmonary vein isolation alone is good in a Fontan population or diseased atria, how good is it alone?
Yeah.
For Dr. Folansby.
Am I on? Can we hear me? All right. Yeah, this is an excellent question. This is again where the advancements in technology have really helped us out. So we are predominantly using EnSite X during our ablations and using the HD grid catheter, which essentially, to quickly describe it, looks like a fly swatter with a bunch of different electrical sensors on it. By using that, we are able to position that over top of our areas of block, and in live pacing, using usually a quad catheter position somewhere else in the atrium, we're able to demonstrate live flow of electricity across the myocardium and demonstrate the deviation of the electrical flow around our ablation area to prove the existence of a effective line of block. And then as far as the PVI goes, it's a very interesting question. The literature is not there yet for how good the PVI alone in this population is going to be. I think the very large adult studies looking at PVI in the traditional adult population has taught us that there are a lot of pitfalls and surprises awaiting us down the line as we learn how to apply this technique to the adult congenital population. But certainly our early experience has been encouraging in the short run as far as freedom from recurrence of atrial fibrillation goes. Though with the caveat being also that in the setting of the multiplicity of IART circuits, needs to be assured that revolving either figure 8 or multi-insert ART circuits are not confused for atrial fibrillation circuits.
Wonderful, thank you. There is a question about CAS. Do you always look for venous collaterals from the hepatic and renal veins in a Fontan CAS, or only when you suspect?
Great. Thank you for the question. I think this is a pretest probability driven experience for sure. So desaturated patients get more detailed investigations. than patients who are well saturated. I would say we typically include an angiogram in the IVC or azygos, depending upon the anatomy, and then typically another angiogram that is at the hepatic vein confluence adjacent to the entrance to the lateral tunnel or to the extracardiac conduit, but deeper investigation is warranted in patients who are more desaturated. Hope that helps. Thank you.
There is a specific question. There's a couple of questions actually addressing the clip interventional structural therapies in AV valve regurgitation. One is about what do you do with the hole in the extracardiac conduit if that's something that ever has to be closed. And the other one relates to timing as an intermediate step prior to transplant.
In our limited experience, we have not closed them. Eventually they do close, but obviously if there's cyanosis, you can always go back and close them. And then to answer the last question about transplant, I think what is my ideal patient? My ideal patient, when we're discussing them, is a patient with Fontan, good hemodynamics or good ventricular function, and has prolapse, definitely repairable valve. And that's the kind of patient you talk to the surgeon. Can we give it a try with a clip? And obviously you have to be the advocate for the patient in the procedure and make sure that patient doesn't leave unless they have an excellent result. Because if you deploy a clip and it's a suboptimal result, you may make it harder for the surgeon to repair the valve.
Makes sense. Wonderful. We may have to answer some of those questions electronically afterwards, but I wanted Tarek to ask you, with the MRI becoming such an amazing tool to assess patients with Fontan, and unfortunately we have so many patients who can't get MRIs because they have pacemakers or stents. How do you go about, still getting the best data from MRI on patients who have stents, for instance, or what alternatives do you see, in terms of advanced imaging so that we don't have to take all these kids to the cath lab?
Yep. Thank you, Jackie. That's an excellent question. I'm biased, but I think MRI is a great tool in this population as well. But I think about 15% or so will have a pacemaker, which will, currently we can't scan them in the MRI scanner because they have epicardial leads, and that's a contraindication for cardiac MRI. So in these patients, we end up doing a CT scan. And with the newer CT technologies, we can do like retrospective CT with relatively low radiation dose, which will allow us to assess ventricular function. So to do a lot of similar things to MRI, except for the flow data. For anatomy, that's also very good. So we can identify if there are any collateral vessels easily by CT as well. And then for the stents, most of the newer stents are, like generate just low artifacts, so we can still scan them by cardiac MRI.
That's wonderful. Thank you. And maybe for Dr. Malik and also for you, Tarek, about as well as Libby, what are the recommendations to screen the liver in Fontan patients? What kind of protocols do we use, both in children and adults?
So, go ahead, Doctor.
So it's a little bit controversial right now. The current guidelines just recommend surveying cirrhotics. And I think that's generally what we're doing based on either a biopsy measurement or an elastography. I'm not convinced about the data on HCC and non-cirrhotic Fontan patients. I think the data is a little bit sketchy. But generally, most of us are defaulting to some type of imaging study within 6 months to a year with an AFP.
Yep. And I can speak to the pediatric patients. We start some screening around the age of 12. And that's based on the youngest patient who was reported with hepatocellular carcinoma, which is the age of 13 or so. And we do that infrequently in childhood, and then we increase the frequency as we get to adulthood.
Wonderful. On that same line, there is a question from the online about any medical therapies to slow Fontan-associated liver disease, and whether aldactone has any role in that.
So there is data not in the Fontan patient, but in patients with other forms of fibrosis, coffee And so if you guys like coffee, there is very strong data on coffee and regression of fibrosis. I don't know how the cardiologist
So
may
that
not
the
like that.
coffee, a little bit of wine, you can counteract each other and not have any bad effect.
But the next big wave in liver disease, of course, are antifibrotics. So hopefully in the coming years, we'll see something like that.
Wonderful. Yeah, I think we may have to wrap up now. You want to wrap it up? Yes.
Thank you all the speakers for great talks, and we look forward to sessions in the afternoon.
Last,
Just a quick reminder for the virtual audience, they can log into the rapid fire presentations, which will take place shortly. Thank you.
Oh, I can help you now. Okay, so welcome to the next session. This will be managing heart failure and the Fontan-Kreutzer and timing for replacement therapy. So our first speaker is Dr. Anita Sarath, who's an MD, PhD, and one of our adult congenital colleagues.
Thank you, Kirsten. Welcome back, everyone. And thank you for being in attendance and for your enthusiasm for this conference. We really appreciate all of you and the support that you've provided us in many different ways. So I'm going to talk a little bit about medical therapy and our approach to a patient who is becoming more and more symptomatic over time. Sorry. So here I have an example of one of our a popular Fontan patient, somebody that everybody knows and has heard her speak quite a while in quite a few conferences, Megan Roswick. She has HLHS and she's determined to live her life to the fullest. She skydives, she skis, and she is very active on social media. And she is, one could say, a perfect example of a healthy Fontan or even a super Fontan. And then at the other end, you have patients who have Fontan circulation and are awaiting a heart transplant, have protein-losing enteropathy, have classic bronchitis, or have symptomatic heart failure, or sometimes we even lose a lot of our patients in this long journey of Fontan operation. And in many cases, in many circles, this is called Fontan failure. And going between Fontan failure and a healthy Fontan is a long process, and the one that we don't really understand too well. So developing this Fontan failure happens over the lifetime of the Fontan patient. And everybody likes to start thinking about the heart and the heart failure aspect of Fontan failure. But really, the heart is more susceptible to damage and further downstream consequences right from the embryonic development of this particular child. So when you think about a single ventricle, there are multiple different factors that can contribute to single ventricle anatomy. And this includes DNA mutations, epigenetic modifications, as well as the environment within the uterus for the embryo. And different factors work together to create the single ventricle physiology. Within the DNA mutations, there are different types of DNA mutations that have been implicated, including Notch and TBX and NKX 2.5. And all of these mutations are not really specific to cardiomyocyte development. They actually influence the development of a whole bunch of different organs, including endothelial cells and blood vessels, cardiomyocytes and other types of cells within the heart, the lymphatic system, the liver, and the brain. And after the child is born, they go through a series of operations, and then they have to go through an operation that changes the physiology and the way blood flows and circulates through the body. And this is the Fontan physiology. And you have heard about this many times through many different talks this morning, where the pressures within the circulatory system are very different in the Fontan physiology versus a normal biventricular physiology. As the blood exits the heart, it experiences very high pressures in the aorta, the descending aorta, and as the blood circulates to the periphery, these pressures fall. And as the venous return of the blood into the heart continues, these pressures fall further, but you don't see that in the Fontan circulation, where these pressures continue to be significantly high. And as a result of these high pressures, what the rest of the body sees is an increased pressure within the liver and within the portal circulation that has consequences down the line for a Fontan patient. So when you think about a symptomatic Fontan, it is easy to blame just the heart and to look for signs of heart failure. But if we've learned anything through this morning, it's that it's never just the heart. There are so many different organs that are involved in this Fontan failure physiology. So with the heart, of course, we see cardiomyopathy, we see heart failure, valve failure, as well as arrhythmias. But then there's the liver, and we had a great lecture on FALD. Ascites, liver cirrhosis are all implicated in some of our patients who are awaiting transplant. There's portal hypertension that presents itself as varices and thrombocytopenia, pulmonary hypertension, We had a great lecture on how our patients continue to struggle from a psychological perspective. And there's also huge evidence of how cognitive and executive function is also affected in our patients. Of course, kidneys are always in the picture whenever the heart is in the picture. So you have renal dysfunction as well. And of course, we had a wonderful series of talks that talked about various factors that change the way the Fontan conduit behaves over time, either because of the formation of thrombus within the Fontan conduit itself, or because of the formation of collaterals because of a difference in pressures. And last, but definitely not least, is the lymphatic circulation. And we're going to have a great talk about that later in this series as well. So when we think about all these different ways in which a symptomatic Fontan patient can present to us, what it makes it even more challenging is that they don't necessarily present the same way as children versus as adults. So as children with Fontan circulation, when they start having symptoms, what is more evident is they have plastic bronchitis, they may have some arrhythmias, but all of these incidents of arrhythmias and other types of PLE become more evident in the adult population. FALT, for example, Fontan-associated liver disease is definitely more ubiquitous in the adult population as compared to a pediatric population. And we are very aggressive at our center to monitor for Fontan-associated liver disease, as was indicated by Dr. Malik. So it's not surprising that given that this disease involves so many different organs, that traditional therapies that are used in heart failure in non-congenital heart disease patients don't necessarily work as well in our Fontan patients. So in this paper by Roche et al., they mentioned that there is really no great evidence that supports the use of beta blockers or ACE inhibitors in this population, and definitely not as robust as we see in some of our traditional patients, adult patients who have ischemic heart disease. There's another paper that came out that might explain why this is so. Could it be that the heart failure that we see in our Fontan patients is just completely different, or in many ways different, than the heart failure that we see in ischemic patients who have heart failure? So this is a paper and a study that was from Colorado by Shelly Miyamoto's group, where she looked at actual myocardial samples from 3 different types of patients. So this is a normal biventricular functioning patient and the explants of their hearts. And they compared them to non-failing single ventricle patients as well as failing single ventricle patients. And what they saw was that the non-failing biventricle patients and the non-failing single ventricle patients metabolize different factors within the mitochondria completely differently from each other. And over time, as the single ventricle patients start developing heart failure, these differences in metabolic outcomes become even more profound. There's mitochondrial dysfunction that is more profound in our single ventricle patients, not just when they have heart failure type symptoms, but much before that, in addition to the type of immunological responses that we get from these patients. So these authors concluded that heart failure in a single ventricle patient is affected significantly by the differences in the way energy is metabolized within the mitochondria of these single ventricle patients. And that could be a basis for sort of considering, or perhaps considering, that the therapies that we so commonly use in our chronic heart failure patients or adult patients may not necessarily work as well in our Fontan patients. However, this is all we have right now in terms of evidence, and all of our Fontan patients continue to benefit in some ways through the various therapies that we give them, including beta blockers and ACE inhibitors. Perhaps there isn't enough evidence to support this because most of the trials that were tried in these patient populations were really small, very small patient size in terms of patient population. The genetics and anatomy of these patients is also very diverse, and that adds a significant amount of confounding factors to these studies. Furthermore, I just mentioned also the fact that mitochondrial disease and cardiac dysfunction is a lifelong ailment that affects these patients. And we are only looking at the efficacy of these drugs over a few weeks or maybe perhaps a few months. And we are not giving them sufficient time to benefit from these therapies while we do randomized controlled trials. Furthermore, when we looked at retrospective studies or studies that are observational, multidisciplinary centers don't necessarily follow a uniform prescription methodology. There's variability in the rate at which these drugs are prescribed, ranging from 7% to 100% at these different centers, and therefore these outcomes might be different. So what really is the evidence of the guideline-directed medical therapy in Fontan failure as we understand it? So beta blockers, all of our ischemic heart disease patients get beta blockers even before they leave the hospital. It has great antiarrhythmic effects. However, in our Fontan patients, we need to be a little more careful in giving these patients these drugs when we know that they have sinus node dysfunction, or when we know that they can have reduced exercise capacity. Studies have shown that beta blockade decreases exercise hemodynamic response by lowering the blood pressure and decreasing chronotropic response in these patients. ACE inhibitors are great medications. They modulate the renin, angiotensin aldosterone pathway, regulate the blood volume and atrial pressures. However, short-term treatments of these medications in our Fontan patients has not necessarily shown that kind of benefit, and has not shown a difference in exercise capacity, ventricular function, or arterial stiffness. Furthermore, in our young Fontan patients who are at childbearing age, adding an ACE inhibitor or an ARB might be detrimental, as they have teratogenic effects on the fetus as well. And our patients may not necessarily know to stop these medications in time. Aldosterone receptor antagonists such as spironolactone also act together with diuretics in eliminating water and sodium from the body. And they have not really been shown to have any detrimental effects in our Fontan patients. And in fact, there have been few case studies where they have had some anti-inflammatory benefit with protein-losing enteropathy. And lastly, diuretics, which are commonly used in a lot of our Fontan patients and provide symptomatic relief to our Fontan patients with heart failure. 50% of adults with Fontan circulation are on diuretics, as was shown through a multi-center trial. However, independently, the use of diuretics was also associated with a 17-fold increase in transplant and death. So they need to be sparingly and wisely administered to our patients. So does treating a symptomatic Fontan patient then require for us to think a little bit outside the box? So what are some of the agents that have actually shown some benefit in our patients? So phosphodiesterase inhibitors and endothelin receptor blockers, pulmonary hypertension medications, have shown some benefit in our Fontan patients. This was a multi-center meta-analysis of 9 randomized controlled trials that was earlier published in 2019, where they looked at 381 patients who were on these pulmonary hypertension medications. And they concluded that there was a significant improvement in Fontan hemodynamics, reduction in NYHA class, increased 6-minute walking distance by 134 meters, and improved oxygen consumption during exercise. However, there was no significant benefit in mortality or in NT-proBNP levels. Additionally, more recently, we have seen the results of the FUEL study, where they administered sildenafil for about 26 weeks in about 400 Fontan patients. And this medication as well has shown some improvement in various exercise parameters, although not all parameters showed a significant benefit. So as per the AHA-ACC guidelines, administering these medications in our Fontan patients has a class 2A recommendation, whereas the European Society gives it a class 2B recommendation citing limited data. However, I would like to point out that there is increasing evidence that there is some influence of these medications on mitochondrial function, ROS production or reactive oxygen species productions, and could have overall pleiotropic effects in improving cardiac function by really targeting some of the cellular mechanisms by which Fontan failure takes place. What is also notable is that while these are recommended as class 2A guidelines, they're not very widely used. Only 5% of patients in a multi-cohort study from the UK showed that they were being used by patients with Fontan circulation. Next, I would just briefly like to talk about the non-pump failure of Fontan failure, which is the circulatory failure. Understanding portal hypertension and circulatory failure is just as important as understanding heart failure in these patients. In the study from Emory that came out in 2013, they looked at varices, ascites, splenomegaly, and thrombocytopenia, and created this VAST score and showed that a VAST score over 2 had significant correlation with hepatocellular carcinoma, transplantation, and death. And more recently, in 2021, they investigated the use of vasoconstrictor therapy in these patients by administering either oral midodrine or intravenous noradrenaline, and showed that the median interval of 1.7 months, various parameters did improve, and hospital admission did decrease from 4 to 1 at a 21-month follow-up. Unfortunately, these patients do have high mortality, and 60% of these patients did die at the end of the study. Lastly, I would like to talk about protein-losing enteropathy, which we see commonly in some of our adult Fontan patients. There has been a multi-drug approach to solving or addressing these issues that come up in our Fontan patients, and involve the use of reducing congestion by using furosemide and spironolactone, replacing lost protein, reducing inflammation by using budesonide, low molecular weight heparin, and to some extent spironolactone, reducing lymph reduction, and then modulating lymphatic and vascular tone by using midodrine and dopamine. However, I think we really do need to think outside the box when it comes to these patients, and think of next generation therapies. And some of the new ideas that have been used out there to address these patients include the use of oral positive pressure devices. This is a study that is being led by Dr. El Said at our center, where he's looking at these OPEP devices to see if he can improve overall outflow through the heart of patients with Fontan circulation by the use of these devices over a very short period of time, just a few weeks. And there are other devices as well, including the externally applied compression therapy, where they provide pulsatile compression pressures to the lower extremities to improve venous blood flow to the heart. And these studies are continuing and ongoing, and hopefully will yield some exciting results in our patients. So in summary, transition from healthy to a failing Fontan can be subtle and can be an extended process. Symptomatic Fontan patients have cardiac as well as extracardiac symptoms. Genetic, epigenetic, and environmental causes of single ventricle anatomy can also influence non-cardiac organs. Etiology of Fontan pump failure can be very different from traditional heart failure, and guideline-directed medical therapy may not necessarily work as well in these patients. Hence, we need to keep an open mind and think outside the box when it comes to using novel drugs as well as novel approaches to finding new cures for these patients. And thank you.
I'd like to introduce Dr. Matthew Zinn. Dr. Zinn is an assistant professor of pediatrics, as well as being a heart transplant physician. He's a medical director of both our ventricular assist device program, as well as Dr. Bill Natchez Heart Camp for Kids. The title of his talk is Entropy, Ventricular Assist Device, and Mechanical Circulatory Support.
All right, thank you, Sean. Thanks to the organizers for inviting me here today. There we go. Okay. So Dr. Saroff set this up very nicely. We have medical options that we have in place that can treat our forms of Fontan failure. Once those fail or no longer effective, then we've reached our end game, right? There are only a few things left that we have to do in order to get us to that ultimate goal of transplantation. But before we figure out what we are going to do, we have to figure out the exact type of Fontan failure. There are several types. The ones that we will focus on today, because they are directly applicable to our MCS conversation, would be type 1, so systolic dysfunction, and type 3, which is the failure of the Fontan circulation. And then there are, of course, there are types of failure that have all of that together. So that'll be the mixed type, to where the response will be a mixed response. So just to look at, we've talked about this and looked at this in various ways throughout all the other talks, but one large study out recently of 173 adult Fontans showed that 28% exhibited signs of Fontan failure, all different types of failure, at around a median of 20 years after their Fontan operation. And I think this graph nicely shows under A, you can see the green, which is all preserved ejection fraction, and then the pink and the blue are your types of dysfunction that are small But over time, going from that around 3-year follow-up to around 22-year follow-up, the degree, excuse me, of systolic dysfunction in the pink and diastolic in the blue significantly increases. So as we've seen in other talks over all of the hemodynamic changes that occur over the years, the systolic and diastolic dysfunction develops over time, as due to a smaller degree increases in PVR. That's important because the type of failure determines how we are going to respond from a mechanical support standpoint. If we look at our systolic dysfunction, right, those patients will have elevated end diastolic pressure and a low transpulmonary gradient. So this is the impaired cardiac output phase. And then the failure of Fontan circulation, higher than normal CVP. We know that's higher already in Fontan's, but at least here over 15, a normal end diastolic pressure. So filling pressures on the ventricle are okay. Elevated transpulmonary gradient. I've seen that number anywhere from over 7 to, for us in other areas of transplant, over 15. These patients have volume overload, pulmonary hypertension. All of this leads to that group of symptoms that we've been talking about that leads to decreased pulmonary blood flow. So our approach to these two types of failure guides our MCS strategy. But first, we need to know what is the goal. Right? We've heard a lot about all the different comorbidities that can come along with the Fontan patient over time. So not everybody is going to be a transplant candidate. There will be a complex evaluation that we go through from a VAD and a transplant standpoint that will either rule people in or rule them out. We can always do medical management on either side. We can also do destination therapy on the side where you're not a candidate. And then based on the age, size, multiple different factors of the patient, that guides our MCS decision. The listing will also be different. In pediatrics, we are still on the older system for listing in UNOS. So every VAD, no matter where you are or how sick you are, or if you're at school, will be a status 1A. Whereas in the adult world, now the Fontans with a VAD would be a status 2. And then the congenital heart disease alone, so the Fontan patients without support would be a 4. So the waiting time is drastically different amongst that, which is why we always try to get to people pre-18 so we can list them on the pediatric strategy if possible. Again, as Dr. Saroff talked about, we would still employ all of our goal-directed medical therapy in anticipation of the eventual need for MCS. And we like to be involved early. This has been brought up a couple times throughout the day so far, to where as a patient starts to show signs of failure, it's good to get us involved as early as possible so we can help guide and make these decisions as a team about ultimately getting someone to a VAD or a transplant candidacy. That initial study that I showed in the adults at that 20-year mark, those that have already started to develop or to show signs of failure, the freedom from death or transplant 5 years later is 70% and only 40% 10 years later. So we can see that once failure sets in, it moves. So we like to be involved as early as possible to help. Part 1 of my assignment for this was to talk about milrinone. We know the effects of milrinone. I've listed them on the screen. It can be, it's a very effective inotrope, one of our favorites in the pediatric ICU. Although it works differently, right? Milrinone doesn't respond the same way that it would in cardiomyopathy. We have seen in a study that looked specifically at the way the downstream molecular signaling of the phosphodiesterase inhibition works, it's different. So here, it's not so much that we are changing the calcium regulation. It's more so probably that lowering the SVR, decreasing afterload allows for improved function of the ventricle. But as we saw in the last talk, we can't expect that the drugs that we use in biventricular physiology will work the same in a failing Fontan. Dopamine, again, in our pediatric guidelines, would be there as well. It can be another first-line agent, but it doesn't have the same effects, clearly we all know from milrinone. And then epinephrine is more of the second stage, where specifically if we are hypotensive. From an ECMO standpoint, it is, of course, on the table when needed in an acute event. In talking with our surgeons, our cannulation strategy Typically in this size patient would be through the groin. And then we would add additional cannulae as needed to increase our venous flow. But of course, patients with all single ventricle physiology are ECMO candidates there, but they are of a varying degree of quality. We know that stage 3, so in this category, have the best outcomes, where the outcomes of ECMO at lower, at stage 1 or stage 2 are quite inferior. But they're still not good. They're not equal to our general congenital heart disease numbers. We can see here 230 Fontans, only 35% of them survived a discharge. And in another study, only single center, they had a very low incidence of ECMO after Fontan, but again, a low number of them survived to discharge. Compare that to our current numbers at the Children's Hospital of Pittsburgh in the extracorporeal life support network. We have our pediatric cardiac ECMO has a 61% survival to discharge. And of that's just the closest thing I could find. The hypoplastic left heart syndrome patients have a 57% survival, and that number is up into the 70s for our neonates. So it is improving, and as we get better and better at ECMO, these numbers will go up, but they will still be limited compared to our other means of support, and that's our ventricular assist devices. Again, devices that were not designed for use in single ventricles that we have come to use at increasing frequencies, but still things that are used in relative infrequency compared to the rest of the indications. Looking at our 2 big databases that we have now, PDMAX, which is our pediatric version of Intermax. Congenital heart disease actually it's increasing now. About 25% of the VAD patients that we have in the registry are due to congenital heart disease, not just we're moving away from that almost always just doing in the cardiomyopathies, normal biventricular anatomy. We do know compared to non-CHD patients, higher mortality, lower percent transplanted at 6 months, but interestingly, no difference between biventricular anatomy or single ventricular anatomy. So having a single ventricle is not a contraindication on its face to doing a ventricular assist device. That's a much bigger evaluation. But looking more specifically at the type of single ventricle support, the Fontans do the best. We have in that report, there was 95% survival at a year after implant. The next one is Action. For those who don't know, Action is our pediatric VAD learning network run out of Cincinnati Children's. We were a part of this report that talked about 45 patients with the Fontan, all under 18, average age of 10, mostly with RVs and moderate to severe AV valve regurg. They had roughly an 80% bridge to transplant or still on support rate, which is pretty similar to patients or all patients on a VAD. So when we look at just our Fontan patients alone, the outcome of VADs is actually pretty good. Compare that just in an incidence point to the adult with congenital heart disease. There wasn't much out there about using adult or this type of support strictly in an adult population. But one pediatric group looked at the UNOS database and simply showed that ACHD patients receive VADs at a pretty low rate, only 10% of them. But that actually seems up. I looked at some studies from around 2015 and the incidence was less than 1%. So that number seems to be rising just in general, like with us in peds, that as we get better at managing these devices, the numbers will increase. So what options do we have? Our options, again, are all designed for a biventricular anatomy. And now in pediatrics, because nothing is other than 1 or 2 pumps, nothing is specifically designed for our small patients. General rule, over 25 kilos, we can use our HeartMate 3, the standard intracorporeal device in adults. Under 25 kilos, we think about our Berlin X-Core, our Centramag, and then we've started to see a little more use, not much, of the Impella 5.5 as a temporary support when needed. If possible, from a device standpoint, we prefer to use continuous flow devices. We put a pulsatile device in in any patient, but in a Fontan, it will only decompress and drain the ventricle in diastole. If you have a intracorporeal, if you have a continuous flow device, it is continuously decompressing the ventricle. And we have seen that decreases that reversal of flow into the pulmonary veins, decreases your pulmonary edema. So when possible, just like we like to do in all cases, use continuous flow devices if possible. But the device, any of our devices have been shown successful as a bridge to transplant. From an implant strategy standpoint, won't spend a lot of time on the surgical aspect. There are centers that prefer atrial cannulation, ventricular cannulation. We've heard a lot from other talks about the other anatomical considerations. The thing specifically for us is if from a space standpoint or trabeculations, you can either remove those trabeculations that we saw in some of those echoes, or we can outright just remove the AV valve, whatever it takes to get the pump in there and to work as best as possible. And then other centers have described wrapping the device or essentially preparing the device or the patient at the VAD time for the ultimate transplant to expedite the transplant. We've heard a little bit as well about hypoxemia. So the fenestration and the veno-venous collaterals, there again are some people who recommend doing the fenestration all the time, others where it's questionable, or they do it case by case. Veno-venous collaterals on that pre-VAD cath. Look, do we close big ones, close them, or go back and close them after if there is ongoing hypoxemia? Now, the most interesting part here, AP collaterals. These are in our VAD flow, right? These are our enemy, right? They will take on an estimate 20 to 50% of that cardiac output right back to the ventricle and maintain an ongoing volume load. So we have to set our VAD settings, our RPMs or our rate at a much higher level than would be expected in order to account for this. So we ensure that we have adequate cardiac output. There's not much specifically in terms of difference really, or dedicated therapies right now in terms of supporting the failure of Fontan circulation. We can still use milrinone. This hopefully, right, decrease our PVR, increase our cardiac output, but short term. Milrinone is not something we're going to put someone on for months and months and months and send them home. If we have a short period of time per transplant, then we can consider doing that. ECMO, of course, can be used. And in this case, though, the systemic VADs, the things we just talked about, aren't really going to help. If we have someone who primarily has a failure of Fontan circulation, the systemic VAD is not the answer. Subpulmonary devices have been used and have shown success where we cannulate the cable pulmonary anastomosis and then cannulate back into the pulmonary artery, whether it be with a pulsatile device or with a continuous flow device. As Dr. Kreutzer alluded to in the morning, what I think is the most exciting part is that there is development of Fontan dedicated devices. This is difficult, as with all device development based on funding. These are all dedicated, or specific investigators are pushing these now. All are implanted directly into the Fontan circulation and have been shown to improve cardiac output, lower CVP, and can support the circulation directly. But these right now a couple of these are all over the world and they are still in development. One that has been actually used in people already is the Berlin X-Core venous cannula. This is very cool because the system to do this already exists. This is just a new cannula for our Berlin system. It basically takes the place, right? You connect the IVC and the SVC to it, comes out to the pump and goes back into the pulmonary artery. This has been shown successful in the Berlin group in a 12-year-old and a 17-year-old. I think it seems that this will be the thing that has the most immediate potential for us because it really is just a new cannula and a system that already exists. In a mixed etiology, we just combine the two things that we just talked about. We can do a VAD in the systemic position, milrinone on the left or on the right. We can do BiVADs, or total artificial hearts have also been shown to be effective at this stage as well. And we'll close just with our experience. In the past 10 years, we've had 4 patients at this stage who have been supported. Our smallest was a 3-year-old who was successfully transplanted after about 53 days off of Berlin. Then the next 2 were transplanted off an HVAD, which for us is very sad that that is no longer available because that was our perfect right around 20 kilo pump that worked really well for us. They were both successfully transplanted as well. And then finally, our most recent patient was an 18-year-old who was supported with an Impella 5.5 for almost 50 days. So this was one where we were on the bridge of the supporting from a ped side to the adult side, and talked with our adult colleagues, thought we would support this person for around 2 weeks. It ended up being around 7 weeks. And then in talking with the company, this is still the longest support of a single ventricle with an Impella 5.5. So in the end, there are medical options, there are mechanical support options, but each one needs to be tailored specifically to the patient, their exact type of failure and the goals of care. But it's not without risk. There are significant morbidity and mortality on the wait list. But they are superior to earlier stages. And ultimately, as we'll hear in the upcoming talks, transplant is the final end game for everybody. Thank you.
Thank you for that excellent talk. Our next talk will be by Dr. Brian Feingold, who's the director of our heart failure and transplant program at UPMC Children's and a professor of pediatrics in clinical and translational science. His talk will be entitled Post-Transplant Management and Planning in Fontan-Kreutzer ICU Management.
Thank you. I hope you can all hear me. And I'm going to try to show my slides. I apologize for not being able to be present with you today there. All right. Are you able to see those slides? Can somebody give me a thumbs up maybe on the presenter panel? Sorry, are you all seeing slides or no?
We're not.
Huh, you're not. Okay. It says I am screen sharing. Try that again.
That's great.
Okay, great. Thank you. I appreciate that. Yes, thank you again. And I apologize for not being able to be there in person. The hospital is fairly busy today. I'm going to speak a little bit about, I took a little liberty with the title, and I'm going to speak a little bit about transplant considerations in individuals with a Fontan-Kreutzer circulation. I have no relevant disclosures to this talk. So as a way of an overview, I will speak a little bit about outcomes after transplantation for individuals with a Fontan-Kreutzer circulation. I'll review some of the related morbidities that these individuals face with respect to transplantation and their influence on transplantation, and then try to sum it up at the end and put it all together and maybe give a little bit of a perspective of what a transplant cardiologist is thinking about as they approach an individual with Fontan-Kreutzer circulation. So what do we know about outcomes after heart transplantation in these individuals? There's a recent review article published last year by some of the folks in Melbourne, and it was actually a very nice article that looked at a lot of aspects of transplantation for individuals with Fontan circulation. And they have a nice table in there that summarized many, if not all, of the outcomes survival studies for individuals with Fontan circulation who undergo heart transplantation. And so I attempted to, from that, summarize it a little bit further. And as you can see, there's at least 19 peer-reviewed publications from 2004 to 2021 on the topic, covering patient years. So patient Fontan, at the time of Fontan, 1986 to 2018. Patient ages at the time of the Fontan range somewhere between a median of 6 years old to a median of 21.3 across these studies. And obviously there are ranges that exceed that. And early mortality is reported to be somewhere between 0 and 28% for these individuals after transplantation, with late mortality being also in some ranges here, but about 60 to 90% at 1 year, and about 60 to 80% at 5 years, and 45 to 70% at 10 years across these studies. So I think, one of the natural questions, this is a very heterogeneous group of studies that we, that they attempted to review. And it's a good question to ask is whether outcomes have improved over time in individuals with Fontan who undergo heart transplantation. And so this is a nice study out of the Pediatric Heart Transplant Society, which is a really major asset in the heart transplantation field that allows us to look at a lot of different questions about transplant candidates and recipients who are mostly children. And so they looked at this issue and found that indeed survival had improved. Looking on the graph on the left, I guess, is the early era from 1993 to 2006, transplants occurring in that range. And then the late era in panel B on the right, 2007 to 2014. And you can see that the survival curve is improved. And if you look at the point estimates at 1, 3, and 5 years, those numbers are generally better. And I believe this is a p-value of 0.02. And then moving on, though, I think it's also worth asking the question, are these groups the same? Is this apples to apples or apples to oranges? And there's some evidence, I think, when you look at, this is the table from that paper looking at the two different eras. You can see that in the later era, there seems to be there's some signal, I think, that maybe the group is actually a little bit sicker. It's hard to say for sure, but there's more individuals with PLE. There's a greater degree of them having failure to thrive. And more of them are listed, higher proportion are listed at status 1, which is the most urgent listing status. And so not entirely clear, but it's intriguing to see that both in potentially a sicker population or a more urgent population, that those outcomes have seemingly improved. Also in this paper, they looked at what were the top causes of death or the most common causes of death identified across these individuals and across the eras. And I highlighted here just the three the most prevalent or fairly prevalent causes. So we have infection, rejection, and then this other category of other, which is a little bit lacking in description. And I sort of took this to mean that it was related to the great list of Fontan associated morbidities. And I attempted to summarize the ones I could come up with and have read about and have learned about, but I put an asterisk here because certainly this is not a complete list, and we're learning more and more about the morbidities that these individuals face. But as you can see, this really spans the gamut of morbidities across the spectrum. And I think a number of the other speakers today will touch on some of these topics. And so I'll come back to this a little bit, but I won't go in depth. So if we come back to infection, though, for a moment and focus a little bit our thoughts on that. So why do individuals with Fontan have infection seemingly more commonly after transplantation? And I think the etiology for this is unclear, but probably is multifactorial as well, and probably includes a number of these factors I've listed here, including many of these individuals have a neonatal thymectomy at the time of their early congenital heart disease surgery. Many have lymphatic leak or develop lymphatic leak over time, PLE. And with that, you have lymphopenia and hypogammaglobulinemia. And so that would potentially predispose to infection. A number of our patients, unfortunately, when they come to transplant, are malnourished chronically. And so that would obviously impair wound healing. And then, of course, chronic steroid use for treatment of PLE can also potentially exacerbate the lymphopenia and perhaps make infection more common. There is at least one publication looking very recently, was published earlier this year by the group at Stanford, looking at risk of infections in individuals with a Fontan who undergo heart transplantation. And this is their baseline characteristics for this group. And you can see that they compared these 26 Fontan individuals to 33 individuals with dilated cardiomyopathy as their indication for transplantation. And so again, just even on this list, we see here that heterotaxy, history of protein-losing enteropathy occurred exclusively in the Fontan group, as well as at the time of transplantation, that their absolute lymphocyte count was significantly lower, as well as their serum IgG. So again, speaking to that lymphopenia and hypogammaglobulinemia that is unique or potentially exacerbated in this population. And they found that there's a higher infection rate at 180 days after transplant, with Fontan individuals having 54% of them having an infection versus 27% at 180 days in the dilated cardiomyopathy group. They were also more likely to have multiple infections by 30 days after transplant. There was a higher odds ratio for infection at 30 and 180 days in a multivariable model. And there was increased mortality from infection, it seemed, or at least a signal of this, where 4 of the 26 individuals versus none of the dilated cardiomyopathy individuals who underwent transplant died of infection or had a death where infection was related to it. So I want to diverge here a little bit and focus a little bit more on lymphatic leak. And again, I'm sure there are going to be have been and will be other great talks focusing on this, but I will sort of try to speak to the aspects that I think are pertinent to transplantation. Excuse me. And so this is a nice article also from PHTS centers that our center was a participant in. Dr. West, one of the panelists, is a co-author on this study. And it looked at Fontan-associated protein-losing enteropathy and outcomes related to transplantation. And this was a relatively small study where they looked at 52 individuals who had heart transplant and had previously had a Fontan with protein-losing enteropathy. The age of transplant is shown here at about 14, and the time from diagnosis of PLE to transplant was about 2.5 years median. And they did not find any associations of pre-transplant PLE duration or severity with mortality, which was 83% at 1 year post-transplant. And then found that resolution of PLE was near universal in this group, 98%, with a median time to resolution of about 1 month. Maximum time about 20 months, and 4 patients did have a relapse early post-transplant, but then resolved. And I would say this is parallels our experience here at Children's Hospital of Pittsburgh, and we have universally had resolution of PLE after transplantation. Moving on just to another lymphatic complication and its intersection with transplant is plastic bronchitis. And there's a very small set of patients who have been studied and published on this back in 2013. Again, a group of individuals out of the PHTS, their center data. And so there were 14 patients that were listed for transplant with plastic bronchitis, and 10 received a transplant in this group. 2 died waiting. The early post-transplant mortality seemed to be fairly high, with 3 of these 10 individuals who received transplantation dying. And they all seem to have pulmonary complications, or one was described as having, frankly, having casts. And so it suggests that, that this is, you're not necessarily out of the woods right after the transplant happens with respect to plastic bronchitis. But once you get through that first 30 days, there were no further deaths out to 5 years, and all the casts, all the plastic bronchitis events and casts resolved by 20 days with no recurrences out to a median of 5.5 years. So I'm going to move forward and talk a little bit about rejection now. And I think it's worth just pointing out, though, that, thinking about rejection and infection as top causes of death are actually a little bit sort of disparate or a bit of a paradox, right? Because when we think of the immune system and immunosuppression, somebody's immune system is functioning at a low level or is highly immunosuppressed is going to be more susceptible to infection, and somebody whose immune system is not adequately suppressed or is overactive, if you will, is going to be prone to rejection. So how can we have both of these in this same population be causes of top causes of death after transplantation? And I'm not sure, but I'm going to posit a hypothesis here, which is, again, many of these individuals, homograft use or allograft use, cryopreserved allograft use is very common in this population. Typically for arch augmentation for individuals with hypoplastic left heart syndrome, sometimes for PA patch augmentation. And this we've known for almost 30 years now is very highly sensitizing, causes marked degree of HLA antibodies to be present in that individual. And if they don't need a transplant, that's fine. But when many of these individuals come to transplant, that's a problem. And to explain why, well, these antibodies predispose to rejection. And this is historical data from the UNOS data set here in the United States. And that shows that in individuals who undergo a transplant, with the graph on the left, the survival curves on the left, with a positive cross-match, meaning they had antibodies already present, ready to recognize that graft as soon as it went in, survival was not as good. And that's the dashed line below on the left. Contemporary outcomes are a little bit better. The data on the right is from the CTOT-CO4 studies, which were done in part with our center and 7 other centers in the US. And it appears that transplantation across a positive cross-match, at least in the modern era, is no longer associated with an increased risk of mortality. And that may be because of changes and advancements in how we're able to treat it. But they still found that the presence of either early or late donor-specific antibodies, so antibodies that develop right after transplant or a little bit later in that first year, still were associated with added morbidity by way of rejection. One other aspect that's unique, I think, to patients with protein-losing enteropathy and Fontan prior to transplant is this phenomenon where they've received a homograft or an allograft distant in their history. They come to transplant a decade later, perhaps, or 15 years later. And we assess their blood for these antibodies and we don't see it. And they also happen to have PLE perhaps at the same time. And so they're hypogammaglobulinemic and are not maintaining steady state IgG levels. And so, this combination of maybe not having the production being ramped up because of the distant homograft exposure, the PLE causing this loss, allows us not to see those antibodies ahead of time, but we know to be worried about them. And so there's this phenomenon where they look like they're not sensitized, or they look like they don't have donor-specific antibodies to the organ that you accept for them, and then very quickly within days of transplant. So that's not a production of new antibodies because it takes 6 weeks to make IgG, 4 or 6 weeks. So this is within days of transplant, you see this marked blossoming of donor-specific antibody, unfortunately. And so this is really something that you need to be paying attention to and looking out for. And it's had a term either called an amnestic response or a memory response. And so it's important to be attuned for that in these individuals. Moving on. We'll talk a little bit about this other group again, which is to just say that there's a large list here. And so there's many more comorbidities that influence outcomes and survival and post-transplant morbidity after the surgery. And so it'd be great if somehow we could summarize this list into a risk prediction model or risk score. And I don't know that we're there yet, but also led by a number of PHTS centers and using that data. There was a recent publication last year in JTCVS looking at the liver and renal function. So basically using the MELD-XI score for individuals who have a Fontan and who are awaiting or undergoing transplant and looking at their outcomes. And so in this panel here on the right, you can see that regardless of how they're stratified, the green line being no VAD and no PLE at the time of transplant, and the blue line at the top being both VAD and PLE, so presumably a sicker population, that across the range of MELD-XI scores, a higher score is a worse is indicative of worse renal and hepatic function. You see that mortality on the y-axis here, 1-year mortality that's predicted is increased from anywhere from 9% up to about, I think this is about 25%, 23% for the most favorable group in terms of risk from a VAD and PLE perspective. And then this is actually outcomes data looking at individuals who were transplanted who had a high or a low MELD-XI score, and you can see that there indeed is a survival difference both early, and then it seems to continue on with further divergence of these curves late after transplant. So we're moving to conclusion here. I will just talk about one other area, which I think is a really important area and an area of emerging interest, and will be an area that we'll be focusing on more and more in pediatrics and borrowing from our adult colleagues, is the idea of or looking at frailty. This concept of frailty and trying to encapsulate that into our ability to understand the severity of somebody's debilitation, and perhaps as an area of focus to improvement. And so Kurt Schumacher, who's doing a lot of great work in the Fontan space and is really a thought leader here out at Ann Arbor, had this abstract as part of a group with this abstract presented at the AHA, I believe 2 years ago. A year before last, and they looked at frailty in pediatric patients and found that it was associated with impaired quality of life and increased hospitalizations. And so they looked at 54 individuals with a Fontan, median age 15 years, and they use a freed frailty assessment, but modified it, and it encompasses the 5 domains shown there. 33% of these individuals were identified as being frail, and another almost 50% were identified as being pre-frail. And interestingly, they did not look at frailty with respect to outcomes in this work, but they did find that there was a very poor correlation of that freed frailty score with the medical provider's estimate of frailty. So that's very interesting. So it suggests as providers, we look at a patient and we use the eyeball test, but it may not be telling us all that we need to be seeing about these patients and their degree of frailty. And then factors associated with frailty or near frailty included having PLE, having at least 1 hospitalization in the 12 months prior to the assessment for frailty, higher New York Heart Association classification, and more than 4 clinic visits in the prior 12 months. So these are factors you could start thinking about in your mind as you see your patients and decide whether they really are more frail than we're appreciating. So lastly, to wrap up here, I just want to speak a little bit about how, one approach or how I tend to think about risk in these patients and in all transplant patients, quite honestly. But, I think a transplant evaluation attempts to identify the risks that are present, unique to that individual, develop plans to correct or improve those modifiable risks where possible, and then determine whether in light of that remaining risk and what you can improve and what you can't, is it reasonable and feasible to proceed? And so I think of it as almost a risk budget. You think of like your budget and you decide where you're going to spend your risk and where you're not going to spend your risk, and you're just unwilling or can't spend your risk. And so, I think you can bolster your budget by the environment in which you practice and by your expertise and your surgical expertise and your ICU level support and your subspecialists when you have your gastroenterologists who are familiar with Fontan associated liver disease, and you have your nephrologists who are familiar with severe congenital heart disease and heart dysfunction. That all helps you bolster your budget, if you will, and I think allows you to have a little bit more risk to spend, if you will. And so with each transplant offer, I think you need to consider those risks that are presented at the time by that candidate and at the time by the donor, and see if it fits within your risk budget and it's a go to proceed. After transplantation, we need to anticipate and manage those budgeted risks. And we need to be vigilant for the known but non-budgeted risks that are still probably going to pop up, even though you've done your risk calculation. So, and with that, I will conclude, and I appreciate your time and interest. And again, thank you for allowing me to speak.
Thank you, Dr. Feingold, for your talk. I'd like to introduce Dr. Rod Gasimzadeh. Rod is an assistant professor of critical care medicine. In pediatrics, he's assistant program director for the pediatric critical care medicine and in attending in our cardiac critical care unit. He will be talking on the CSU management and tips post-heart and liver transplant.
Thank you to the organizing committee. It's an honor to speak amongst all these experts in the field. My job will be to discuss the CICU management, which in reality takes all the wonderful work that all the experts have already spoken on and organize them into a play that ultimately gets us to the goal line, which is getting these patients from a failing Fontan into a transplant, whether that be a liver, a heart transplant, or a combined heart liver transplant. What it really requires is organization of the entire team to really mobilize all of our advanced therapies to get them there. Strangely enough, when I looked up a picture of a playbook, it was the Pittsburgh Steelers running game against the Baltimore Ravens. It's an American football team here, so I hope I'm not divulging city secrets. So here's the team, the entire congenital heart team, including our interventional docs, adult congenital docs, electrophysiologist, interventional proceduralists, as well as our entire subspecialty team. As we know, these patients have a lifetime of success and complications, all of which is managed by a multidisciplinary team. So engaging them in the process from the beginning is vital to success. So again, we've spoken about this in a variety of different presentations about the level of dysfunction these patients have coming in, but specifically from a CICU standpoint, dealing with the Fontan pathway dysfunction, which leads to symptomatic chronic fluid overload, effusions, ascites, and very severe cyanosis. Ultimately, we manage that with a high degree of diuretics, and milrinone, as Dr. Zinn mentioned earlier, is our primary vasoactive to help treat Fontan pathway dysfunction. Although we are limited in this setting, too much diuresis, and we get rid of the passive movement of fluid and blood through the Fontan pathway. So we can't over diurese and we can't under diurese because we can't allow the fluid to cause significant multi-organ dysfunction. And then from a ventricular dysfunction standpoint, we usually use inotropes and other vasoactives that better tighten up the peripheral vasculature so that we can increase the SVR and get blood to the organs that it needs to go to. But again, in the setting of ventricular dysfunction, potential AV valve regurgitation, we may be hindered in that process. We are plagued by recurrent arrhythmias in these patients of all sorts of varieties, ranging from symptomatic bradycardia to malignant tachycardia. And unfortunately, at this stage of the game, any therapy to help treat that can potentially worsen ventricular dysfunction, worsen end organ dysfunction, such as amiodarone, procainamide, things like this that ultimately cause more problems than they help. So we oftentimes get stuck between a rock and a hard place. Lymphatic dysfunction plays a big part in, again, chronic fluid overload, plastic bronchitis. This is where our pulmonary team helps us out with novel therapies to help prevent respiratory failure related to that, as well as refractory PLE that affects our drug metabolism, our maintenance of albumin, our ability to maintain good nutrition in these patients, which we'll talk about soon is vital for them. And then extracardiac dysfunction, obviously the liver is affected. You may have varying degrees of cirrhosis, unclear how much is reversible, which affects synthetic liver function, drug metabolism, and excretory function. You have renal dysfunction or chronic renal failure, and oftentimes the interplay of the cardiac renal syndrome ultimately decreases the effectiveness of your diuretics and hinders your ability to maintain the patient forward towards transplant. In addition to the dysfunctions I've already mentioned, oftentimes these patients already come in with obstructive respiratory disease, endocrinopathies, adrenal insufficiency, thyroid disorders from prior medication exposures or genetic abnormalities. The neurocognitive changes are ongoing. Even just being in the ICU alone can cause long-term neurocognitive changes that may or may not be reversible. And thromboembolic complications and secondary erythrocytosis can be very troublesome, especially in the setting of needing to maintain vascular access, prevent strokes, and if a patient is on mechanical support, ensuring that it runs smoothly without any issues. And protein-losing enteropathy we already mentioned. Thankfully, in the cardiac ICU, pregnancy and sexual dysfunction don't come up very frequently. So this is a chest X-ray for one of the patients that we saw at our institution that came in for heart transplantation. Obviously, based on this X-ray, you can see a significant left pleural effusion, diaphragmatic dysfunction, and infiltrative disease, pulmonary parenchymal disease that's spread throughout the lungs. This is the starting point. So you can imagine the consultation and the anticipatory guidance given to the family is to expect that lung disease is going to be part of their long-term recovery and will certainly be a factor and a risk moving into surgery. Vascular access, the importance of which knowing and understanding what is open, what's available, and where you're going to access in order to provide advanced therapies if they need to. We are very blessed at Pittsburgh to have a very dedicated team to all aspects of advanced extracorporeal therapies, including obtaining vascular access, running ECMO or other mechanical support, our CRT team, as well as a plasmapheresis team, all of which we use very frequently and in interplay, oftentimes simultaneous, which helps us with limiting the amount of extra access we need, but sometimes we have no choice but to employ those strategies. As was previously mentioned, the vasoactives that we tend to use most frequently are milrinone, oftentimes upgrading to epinephrine and dobutamine. And oftentimes we may introduce vasopressin as well, given its effects to help reduce pulmonary pressures and renal pressures, counter to what it does to the rest of your SVR. And that helps us with maintaining blood pressure as well as ensuring that our pulmonary pressures are low and that we can maintain some diuresis. And we utilize all forms of diuretics, and you have to really use a multimodal approach given the lack of response, the usual response to diuretics. And oftentimes medical management is not sufficient, so upgrading to the mechanical support that Dr. Zinn had mentioned earlier is necessary. And creativity is the name of the game in this situation, understanding what the preoperative or pre-procedural pre-VAD anatomy is, how complicated is it going to be to go in, what's the patient's nutritional status, and how successful are you going to be to maintain the cannulas and the skin sites, as well as how will this mechanical implantation affect the future surgery of heart or combined heart liver transplant. This is an X-ray of a patient that we supported with Impella for several weeks as a bridge to transplant. And really, this patient was sort of at the edge prior to collapse. And Impella really helped us get through the last few weeks prior to transplant. Nutrition, 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 often forgotten, one of the most important aspects of taking care of these patients. Unfortunately, it's not uncommon to see cannula sites that are either infected or broken down because you dropped the ball on the nutrition. Overfeeding, CO2 burden, caloric deficits, immunosuppression, micronutrient imbalance, protein deficits, all affecting wound healing, development, infection, resource utilization, mortality, ICU stay, prolonged ventilation, and muscle strength and function, which ultimately, if you're successful in getting transplantation completed, this will be what will drive the patient out of the ICU. And if you can't get them there, then you'll be stuck. So the multimodal assessment is what, as ICU doctors, we ensure happens alongside the medical components. The clinical status, fluid status, anatomic lesions and considerations, hemodynamics, evaluation with the heart failure team, evaluating the modifiable risk factors such as collaterals, nutrition, physical conditioning, organ-specific comorbidities, and ensuring that we have the appropriate specialties have their eye on those organs, as well as the psychological and neurocognitive considerations. And as well as limiting sensitization, limiting blood products, and having protocols that dictate how you can limit blood products as much as possible, because sensitization can even happen in the brief period of time that you're waiting, hopefully in the CICU for transplant. Having some kind of protocol for understanding which patients will go for combined heart liver or just heart is vital. I think nowadays, especially that heart liver is becoming more common, it's clear that some patients do fine just with a heart transplant, and adding the extra wait time, given the lack of resources, the lack of availability of multiple organs, we want to make sure that we utilize them appropriately. So understanding which patients should go for just heart, which patients should go for heart liver, and choosing the right one ensures success. This was a study done, I believe, by the group in Columbia in New York that looked at pre and post-operative factors and outcomes for patients who receive heart transplant versus combined heart liver transplant. And oftentimes, maybe not unexpectedly, the heart transplant only recipients had a shorter time from Fontan completion, higher hemoglobin level, less diuretics at presentation, less likely to be transplanted in the recent decade. Combined heart liver transplant recipients, longer time from the Fontan, lower hemoglobin, more diuretics at presentation, more likely to be transplanted in the recent decade. And at transplant, the heart transplant recipients, not unsurprisingly, have a shorter cardiopulmonary bypass time, whereas the combined heart liver transplants have a longer cardiopulmonary bypass time. There are other mentions in this study about shorter ICU stay, hospital stay versus longer, but there's a recent study at Stanford that may conflict with that, so I'll discuss that as well. And ultimately, what the two studies do share is that the outcomes are about the same, especially improved in the combined heart liver if you have cirrhosis, especially in their FALD scoring greater than 2. Understanding preoperative risk factors listed here. I think all of these were mentioned in prior conversations. Third tip I have is protocolization, ensuring that you know how to balance between fluid management and blood pressure management, both organs which require totally different things post-transplant. For heart transplantation, we usually limit fluid, limit the afterload and blood pressure, whereas in the liver transplant, you want to maximize fluid and maximize mean arterial pressure in order to ensure that the liver gets adequate blood flow. So it's the interplay between these two where you have to know where to find the balance, and having both teams at bedside during rounds is vital in that process. The intra-op strategy for how each organ is supported certainly is not something that we control in the ICU, but may affect the post-operative management. It was interesting how every different center has a different strategy for supporting each organ, and some doing on block, some doing sequential. Some choosing to do veno-venous bypass of the liver, some choosing to do total cardiopulmonary bypass for both, and some choosing to support via ECMO throughout post-bypass period. Post-operative bleeding is inevitable and annoying. So ensuring that you have covered treating coagulopathy, ensuring that you do not have hypothermia, treating with bicarbonate for metabolic acidosis, and optimizing your organ function to ensure that you can stop the bleeding, because unfortunately, especially in the setting of mechanical support, bleeding will be there. And ensuring that you have liaised with your blood bank to have a protocol in place so that when there is bleeding, especially when it gets more into massive bleeding stage, you have a protocol in place. We have found whole blood and medical management, advanced medical management of bleeding post bypass to be extremely helpful. It was incredible. One of our patients just bleeding, and then after 1 or 2 units of whole blood, bleeding stopped quite a bit. But engaging with your surgical colleagues to make sure all bleeders and leftover lesions are addressed, because no amount of medical management will fix that. And using diagnostics such as TAG and ROTAM, which we use at our institution, to identify the problem so that you're not providing unnecessary blood products. Managing fluid overload is really what's going to keep them in the acute range post-operatively. It will affect lung function, kidney function, abdominal function. So we at Pittsburgh use an aggressive strategy of getting fluid off as soon as possible, whether they're on mechanical support and we can utilize the CRT through the mechanical support system, or ensuring that our surgeons or interventional team can give us long-term dialysis catheters so that we can just keep the train rolling on fluid removal and ensure that their lungs don't receive any extraneous damage from lack of fluid removal. Nutrition rehabilitation, I already mentioned the importance of that. That continues post-operatively, being mindful that these patients likely had significant chylous drainage and protein loss beforehand, so they're at risk for infection, at risk for chronic chylous drainage, protein loss. So ensuring that when you do start feeds, you start with low fat or no fat formulas. Consultation with the rehab team early, and considering early trach and G-tube to help with mobilization, limiting sedation, and getting them out of the ICU as soon as possible. Outcomes, this has been reviewed, so I'll just quickly breeze through that, at least in the most recent data from Stanford, in a retrospective study, so not totally similar groups, but the outcomes for heart transplant and heart liver transplant were very similar with similar complications. The only post-operative item that was different between the two groups was the ischemic time, which was obviously longer in the heart liver transplant patients. There was freedom for rejection in the heart liver transplant patients longer than the heart transplant patients, but given the grouping and number of patients in each group, that data has to be taken for what it is. And it's thought that the immunological benefit from a new liver helps with that decrease in rejection in that group. And given that my other hat in the ICU is quality improvement, I want to highlight the fact that having mechanisms in place to ensure that there's good team communication, resuscitation action plans in place, and making sure that every team understands what your targets are, what your expectations are, given a patient's preoperative risk factors and post-operative risk factors, is vital to ensure your team moves forward and a patient doesn't get stuck in the ICU cycle where they receive more and more therapies and have a tough time leaving. I couldn't think of 10 tips, so the 10th tip is to thank the organizing committee and my ICU and Heart Institute colleagues for allowing me to share our institution's experience. Thank you.
Thank you, Rod. Our next talk will be by Dr. Edward Hickey, who's the Surgical Director of the Adult Congenital Heart Program at Baylor College of Medicine and Texas Children's in Houston, Texas, where he'll be joining us virtually. And his talk is entitled How to Refer to Transplant at the Right Time.
Good morning, everybody. And I sincerely regret not being able to be there in person to discuss advanced therapies in Fontan failure, especially with regard to timing, which I'm actually going to leave till right at the end. But I do think there's a theme throughout the message that I'm discussing. So this summarizes, I think, a large bulk of the problem. We all know that congenital heart disease surgical risk is highest in the neonatal period, and thereafter reduces. But what is often underappreciated is this. It then rises exponentially in early adulthood because of interventions, fibrosis, residual lesions, infection, etc. And this is, of course, typified by Fontan failure, such that for complex ACHD categories like Fontan disease, the median age of death is in your 30s from heart failure rather than in your 70s from things like malignancy. And in contrast to general heart failure, which has decades or centuries, in fact, of research and understanding and recognition, such that transplant and VADs are now ubiquitous part of their treatment, that the opposite is true for adult congenital heart disease failure, which is a very new concept. And especially, it's very, very different. Fontan failure presents in your 30s already as established multi-organ disease. Patients have had many interventions that are often sensitized. There's no proven role of goal-directed medical therapy, etc. And advanced therapies, we simply don't know where the role is yet. It is a myth, though, that you can't live a long functional life as a single ventricle. Sharks typify that. But all these large animals that have a single ventricle circulation, the gas exchange membrane is actually downstream of the heart, and therefore the blood pressure is very low. In fact, only crustaceans are the only animal I can find that have something similar to a Fontan, where the gas exchange membrane is upstream of the heart. And that's a problem because your central venous pressures must necessarily be slightly higher than normal. And it's these higher pressures that lead to virtually all of the late issues that complicate Fontan circulations. And then any inefficiency, whether it's valve regurgitation, stenosis, ventricular dysfunction, any inefficiency greatly exacerbates the problem. And this is what you see, CT contrast with a flat fluid line because the circulation is just so inefficient. And of course, the end stage, the end organ manifestations that greatly increase risk of any intervention. Eventually, during one of these exacerbations of heart failure, decisions will need to be made about what the next steps are. And I would suggest that the three main buckets that teams have to decide is, do we undertake some form of high revision surgery to optimize what we already have? do we consider some novel option, such as VAD support, or do we need to move down the road of transplantation? And just for a minute, I'm going to settle on discuss revision surgery, because I don't think it should be overlooked and should always be considered in this decision making. For us, we go through almost sequentially a range of various strategies we can use to try to optimize the circulation. But I think mechanical residual lesions are the most important to my mind, and they're generally either inflow problems, AV valve regurgitation, or outflow problems such as DKS, aneurysms, and aortic regurgitation. And for the AV valve, this patient I'm going to present really typifies the message I want to get across. This is a 19-year-old with heterotaxy and a morphologic right ventricle, typical Fontan liver disease and ascites, moderate, close to severe regurgitation of his tricuspid valve, mild to moderate RV dysfunction, and on cath, a low cardiac index and Fontan pressures in the low 20s. Now he was actually, this is a typical echo that we all see pretty regularly in an ACHT clinic. Now he was actually followed at an outside hospital and was just being admitted repeatedly with ascites and scrotal edema, and in fact underwent a hydrocele repair, which predictably does not deal with the problem. It'll just come back. When it did, he was then referred to us for the next step. And really our options were medical therapy, transplant, of some sort of VAD option. Well, what about a high-risk AV valve repair? It is high risk, but that's actually what we undertook with VAD backup. And in the operating room, we replaced his AV valve with a mechanical prosthesis, and we had a good day. We came off pump really on very reasonable inotropes. He was very stable to the extent we extubated him in the operating room. And the initial days, he did okay with a gradual slow wean of inotropes and introduction of afterload reduction, but we were caught off guard. And he suddenly had a VT arrest about a week later and had to resuscitate him. And at that time point, you can either go down the traditional route of high dose inotropes and try to limp through on intensive care, or do something different. And we decided to do something different. He had very poor function at that time point with this new afterload of the mechanical valve. But instead of cranking up the inotropes, we instead inserted an Impeller 5.5 via an axillary graft. Difficult to get good placement because of his dextrocardic morphologic RV, but nevertheless got a good placement. And it was a very effective strategy because you're able to wake him up, extubate, get him out of bed, rehabilitate, shut off all the inotropes, get the heart rate down, introduce oral heart failure medication. He had a Fitbit and was walking many kilometers each day around the hospital, and then did a slow wean from the impeller after 5 weeks and removed the impeller and discharged him. And now 2 years on, he's had no further readmissions or recurrences of his ascites, and he feels better than he's ever felt in recent years, and he's engaged to be married. We had an almost identical patient to this in Toronto who 6 weeks after a high-risk AV valve replacement was asking to go skydiving. I guess the point is, if in patients who you're considering transplant because of how sick they are with bad AV valve, it's worth always thinking, if we can get through the perioperative period, is this patient going to be offsetting the need for transplantation by a number of years? And sometimes that is the case. Finally, I'll just say that the impeller strategy is very effective, and I think it's a really useful tool in the perioperative period for these high-risk cases because you can extubate them, rehabilitate, and get off the inotropes. Regarding outflow tract, all I'm going to say is that we seem to be seeing an epidemic of these DKS aneurysms and bad AI, which lead to terrible decompensated Fontan failure. And in this situation, I would always be considering major revision surgery to try to offset the need for transplantation. They're big cases, high-risk cases. We had to reconstruct, all of this DKS with bental grafts, but I think you probably do offset the need for advanced therapies if you can get the patient through. Now, I'm going to switch gears to VAD therapies just briefly because I think that they are having very much a growing role in this patient population and should do. And we're considering them in a situation where transplant isn't a viable option either because of urgency, risk tolerance, patient-specific factors like sensitization or obesity, or other social factors. But you may ask, perhaps the outcomes are actually favorable enough to be considered as a strategy simply to delay the need for transplantation. So the HeartMate 3 is the durable device on the market at the moment, and compared to the HVAD, it really does have very stable long-term outcomes if you can get through the perioperative period. But to apply them to single ventricle patients, I think you need to have the political capital in order to do that. And we're lucky that at Texas Children's we have a very extensive congenital VAD experience. And so we have applied it. And this case I did actually yesterday typifies that. This is a 28-year-old heterotaxy, single ventricle with situs inversus and left-sided veins. It's got a right SVC, but it feeds this terrible plexus of venous collaterals here. And renal disease, liver disease, very cyanotic, inotrope dependent after multiple in and out of hospital. And on echo, very poor ventricular function and severe AV valve regurgitation with a Fontan pressure of 33, even after optimization. And so for a whole bunch of reasons, we did not think he was going to be a viable transplant candidate, and especially in the time frame that would be required. And so instead placed a HeartMate 3 yesterday. And the placement, I won't go through re-entry and bypass and all that sort of thing are absolutely critical, but one thing that can be tricky is the placement of these VADs in complex congenital disease. And so we use epicardial echo an awful lot, and the finger by TEE looking for the exact location that's not affected by papillary muscles and things. And yesterday, for example, I replaced his AV valve with a tissue bioprosthesis, and the inflow cannula is coming in here, and it was an odd location on the midline on the diaphragmatic surface of the heart, but it just seemed to be the right location when we were assessing by TEE, and it's not obstructed, and he's been very stable. In other settings, I mean, I've put the VAD on the direct anterior surface of the heart sometimes in the subaortic right ventricles. The point is, it may need to be in a bizarre location, but so long as it's unobstructed, I think that's okay. For Fontans, we've actually now done 17 durable VADs for Fontan physiology. And here I summarize the rough outcomes for this patient population. And I don't think they're too bad. 77% remain alive. Median duration, a median survival is 3.5 years after a VAD. Maximum is over 8 years. And in terms of the major complications at the bottom right, I think they're pretty reasonable. And these are certainly in line with the registry data on the same topic, about 3/4 alive or transplanted. So I think VAD options are definitely something to consider for this patient population. And the longest surviving Fontan, who is still on their durable VAD with us, is a now 24-year-old who has been on his VAD for now 8 years and has got married and had a child while supported with his VAD. But transplantation, well, transplantation for ACHD in general, to be honest, has a poor reputation, partly because historically outcomes were terrible, sort of 30 or 40% early mortality. And that was true too in Toronto until about 2013. I think perhaps more than any other area of congenital heart surgery, this is where you need the right people operating at the right time, in the right place, on the right patients. And for ACHD transplantation, that's very, that introduces some problems. Which teams are best to manage them? Which location is best to manage them? But certainly one thing is absolutely central, and that is a dedicated ACHD heart failure team and service. And if I have one message from this talk, it is that this service is central to getting patients recognized early, the minute they start to decompensate, and then following them longitudinally. And they are the best resource to identify the precise timing for major revision surgery, VAD options, and transplantation. And that would be my take-home message. These patients need to be led through their inevitable decline rather than followed. When you're following patients, you're always on the back foot or somewhat complacent because they're sort of how they've always been, but maybe just a little bit worse. I think if you're seeing them from a heart failure vantage point with all of these advanced therapies in your mind because they're so familiar to you, I think you're better placed to getting the timing right. Certainly for transplantation, the heart failure service, the ACHD heart failure service, and me as the ACHD heart failure surgeon needs to be centrally involved in the decision making as well as the timing. And for me, when we're seeing these patients, these are the questions going through my mind. Are they sick enough? Are they in fact too sick? And of those two, it's almost always the latter. We're seeing patients who are too sick rather than seeing patients who are much earlier in the disease natural history. And it tells us we're always referring too late. I'm then looking for red flags, patient-specific ones, frailty, sensitization, end organs, etc. Is the transplant technically feasible? And we're talking about re-entry, topology, venous structure side, these sorts of things. And of course, can the patient actually be compliant and get with the change in lifestyle that's required? Just because I'm a surgeon, I am going to mention some sort of technical things to do with these big transplants. The re-entry is critical and is a talk in and of itself, and I won't dwell on it anymore, other than it is essential to have a clean re-entry, which may often need peripheral cannulation strategies, which we use an awful lot, femoral, axillary artery, and even jugular vessels. But even in the worst and most unfavorable transplant after many previous revision surgery, you only need 3 structures to do the transplant. And that is control of the SVC, control of the IVC, and control of the aorta. You don't need to dissect anything else out. Those 3 things are what's needed for you to be able to explant the heart. And so those are the 3 things that I'm always going for straight away. Because once you have those control, you can then explant the heart. And this is what you want to achieve. A situation where you have the left atrial cuff, the aorta, SVC and IVC, and the pulmonary artery cuffs ready for an implant. And it doesn't matter if it's the most complicated Fontan transplant. This is what I'm trying to get to before the heart arrives in the room. And it's at this time point that you undertake the additional reconstructions if they're necessary. If you need to augment the arch, this is going to be the easiest arch you've done because the heart is not in the way. If you need to augment the branch pulmonary arteries, this is the time to do it. And of course, for Fontans, we always need to. We need to take down the glen, divide the SVC and oversew the stump, divide the Fontan conduit and oversew it. I always patch hilum to hilum and then augment that with a long oval graft of Gore-Tex, and then make an opening in it, which is going to be for your main pulmonary artery. And this is all done before the heart arrives. So we can then focus on what we call the warm ischemic time, which is the time from when the heart comes off ice until it's being perfused with blood again. That's the critical time. And if you have everything set up for when the new organ arrives in the room, you can keep the warm ischemic time to a minimum, even in the most complex transplant. Typically, it's 15 to 30 minutes. For a Fontan, often we do the left atrium, main pulmonary artery, and the aorta, and then reperfuse, get the clamp off and reperfuse the heart, and that's about 45 minutes. And almost any heart will work if the ischemic time's just been 45 minutes, unless there's been some catastrophic protection problem. So this is my general approach for a Fontan transplant. And throughout the intraoperative period, there are many hurdles that obstacles that make these transplants high risk. But I think each of them has an area that you can mitigate to reduce the risk. But when you arrive on intensive care, I definitely think that the post-op journey is extremely predictable. Patients are very vasoplegic on high pressors, the cardiac output's low, the filling pressures are high. That leads to renal and liver dysfunction, can't extubate the patient. So they're on more sedatives and they're delirious and TPN, etc. And the problem is everything feeds off everything else. And then you only need something like sepsis and all bets are off. The one thing that breaks this entire cycle is get the patient extubated. It breaks so many of these problems. The SVR comes back really rapidly and you can come down on the vasoactives and you can mitigate delirium and sedation and things like that. And for us, if the patient isn't extubated by day 2, we do a therapeutic tracheostomy, which is an extremely progressive and helpful thing actually to break this cycle. And by controlling these various risks, we've really changed outcomes, I think. Certainly in Toronto, we did almost overnight in 2013. And at Texas Children's too, our Fontan transplant history is actually really very good. Everyone survived. Although I will say that these are a slightly younger patient population in Toronto. These are often older teenagers and young adults. But nevertheless, I think it proves that you can mitigate the risk. And for the patients, it's really, the rewards are absolutely huge. So how do we get the timing right? Well, throughout what I'm saying, throughout what I've been saying here, is about this decision-making between revision, VADs, and transplants. You need to be able to consider all the options throughout a patient's gradual decline. And I think the only way we can do it is by having very comprehensive Fontan follow-up programs. At Texas Children's, we call it Fontan Go, but Cincinnati have one, many other institutions have them. I think you need to have these longitudinal Fontan programs. They don't need to take over your patient. They can be parallel to, but they are, I think, best placed to identify when patients are sliding and then get them immediately plugged into the second key thing, which is the dedicated ACHD heart failure service. I think it is absolutely integral to recognizing when patients are at the right time for any of these 3 options. And they're also the best placed to then decide which of the 3 options. So I think that's a roundabout way of showing this story of getting back to the fact that you need to be seeing these patients in comprehensive 360-degree forums parallel to their own cardiologists they've seen for 20 years. Thank you very much.
Thank you, Dr. Hickey, for that talk. So for the last, at the least, talk of the afternoon for this session, I'd like to introduce Daniel Wierzinski, who's speaking with us from a unique perspective regarding living with a Fontan-Kreutzer operation, patient perspective.
Good afternoon, everyone. My name is Dan Wierzinski. I'm 44 years old from Pittsburgh. I'm married and have a 16-year-old daughter. I appreciate you having me speak today. Unfortunately, I couldn't make it in person, but I appreciate your time. Obviously, with the Fontan conference going on, me being a Fontan patient, I appreciate Dr. Saraf asking me to speak. I was little history, little medical history with myself. I was born with a single ventricle heart, had some procedures, 2 months at 5 years old. And then my Fontan was done at age 10 in 1989. And really before the Fontan, I would have trouble keeping up. After school, running around with friends, I could probably go 10, 15 minutes and then, really become shortness of breath, headaches, things of that nature. And then at age 10, when I had my Fontan, that really set me up for a very normal life. I was kind of, when I thought about this conference and speaking, I was kind of laughing to myself because, I think I had 10 or 15 minutes kind of allotted to speak, and there's not a whole lot to speak on the Fontan. I mean, I had it at age 10 and it really set me up for a very normal life. School full-time, work full-time, for the last 25 years. When I got into my late teens, I didn't even, this is probably a fault of my own, but I didn't even see a cardiologist from my late teens up until, 40 years old. I mean, that's how normal of a life that I had. And then, age 40, 41, a few years ago, started to slow down a little bit. That's when, kind of Dr. Saroff came into my life, which was perfect timing, her to come on board and with Children's Hospital, with having, such a deep background with Fontan patients. The start of COVID, I was walking, I was in great shape. I mean, I was walking, anywhere between 5 and 10 miles a day because everything was closed down. There was nothing to do. And I was in great shape walking, my daughter and I, and then, kind of as summer progressed and into the fall, I started slowing down quite a bit. Like I could only go probably a half mile without having to sit down, which obviously is a pretty dramatic drop off. So met with Dr. Saroff and we did a pacemaker kind of as a bridge to kind of the ultimate goal of having a heart liver transplant, which I had last October 4th. So it's been 8 months now. And it worked out really well. I felt pretty good going into it as far as health wise. I was pretty strong. I felt confidence in all the doctors and the surgeons, Dr. Krasarowski doing the heart and Dr. Hughes doing the liver, meeting with them, not only with them, but the heart failure team and the liver team, nutrition, going through the whole valuation process, week-long process, meeting with all the heart team and the liver team. I really felt comfortable after meeting them that this was going to be a success. I tell people all the time that, kind of I had the easy job in this of, kind of exercising and eating right and taking my meds, daily and at the right time. And, I don't think that's too much to ask, but, going back to Fontan, because it is a Fontan conference, just an amazing procedure for me. Like I said, there's not a whole lot to talk about as far as the Fontan from my perspective and that's a great thing because it really set me up from age 10 for 30 years of living a very, very normal life of work, of family, of traveling. So, it was really a kind of a game changer for me. And then leading into the transplant, it was a couple stressful years, obviously, and kind of a stressful last, 8-9 months, but, and I've had a few bumps in the road, but overall, I've felt really good. And it's given me a second chance. Dr. Saroff, like I said, she came into my life at kind of the perfect time. The timing was kind of crazy how it worked out, but even meet with Dr. Feingold and Dr. Goldstein, who I believe are speaking today, and Dr. Malik, who I believe speaking also. On the liver side, just amazing people. Dr. Krasarowski and Dr. Hughes, I mean, I owe so much to them. The surgeons are amazing. I have people, I had a nurse say to me one time how it's a miracle. And like, I don't look at it like that at all. Like it's, you get to spend time with all these people and you realize how highly trained and highly skilled and passionate they are for people and their well-being. It's just, it's not a miracle. It's just, it's them knowing what they're doing and executing properly. And that's, kind of how this has worked out for me. And that's how I look at it. And, I couldn't be more thankful. I have an amazing support system with my wife. My parents are, I'm lucky enough they're still around. They're amazing, and 2 older brothers that are still local. That I have such an amazing support system that I look back and I don't know how people make it through stuff like this without an incredible support system. So thank you to the doctors in attendance and that are not in attendance. And I'm doing great. The Fontan for me was amazing. Hopefully these conferences keep going on and they're an annual event, and hopefully I can, next year be in person and get to meet everyone. So appreciate your time. Thank you very much, and hopefully see you soon. Thanks.
Thank you so much. We'll take questions from the audience. Yeah, I see it. I can see it here.
Can you see the Zoom question?
Yeah, so we have a couple of questions coming from Zoom. The first is coming from Mohammed Abdael, and the question is, in Fontan with depressed function, do you use sildenafil routinely with any other medications? I think that would be a good question for you, Dr. Saraf.
Yeah, so we sort of evaluate, we have a multi-step evaluation process. Our CATS team does very detailed hemodynamic evaluation, and we try to see if any of the pulmonary vasodilator therapies are working or beneficial to the patient, even if they don't have significantly elevated PVRs. If we do see an increase in cardiac output without an increase in EDP in these patients, with these agents, we do tend to add the PD5 inhibitors in them, and have tried to titrate them slowly over a longer period of time so that they can tolerate them better.
Okay, the second question from the chat is, have you had cases of need for decompression or venting of the atrium in a post-Fontan patient with ECMO? And with that, what approach do you suggest?
I don't know
Matt.
if Dr. Hickey is still on the line, or Dr. Zen.
At least for us, and I talked to our team there. Oh, did the question go away?
No.
We've only had one patient in the past, or in many years, who had, at least from the topic where I gave it, that at a later time had was on ECMO after Fontan. I don't remember specifically if they needed decompression. Our primary approach would be to go to the cath lab and do a balloon atrial septostomy for decompression on ECMO. Another thing we talked about recently, another indication, but haven't done it specifically, you could do an impella at that stage. But this physiology here would do septostomy.
I think like,
Oh, or D.
I have 2 questions regarding aortopulmonary collaterals to the panel. One has to do with intra-op. Do you routinely close or coil these collaterals before transplant to minimize bleeding issues? And 2, what is your strategy post-transplant? Do you revisit those if there are any residual collaterals?
I think with our limited experience, haven't had a structured approach in each individual patient. I looked at those patients that we had. They did not require significant coiling of collaterals after and did well, or before and did well after. So unfortunately, I don't have a good or a set answer for us programmatically. I just haven't had that experience yet.
I think it also depends on the stability of the patient and how they're presenting. Oftentimes we have to, even if AP collaterals are addressed in the preoperative period, typically on the first trip to the cath lab for a biopsy after a transplant, we have to address additional collaterals.
and we have had at least 2 patients where we had to go to the cath lab the next day because there was significant bleeding in the operating room, and to coil to get rid of collaterals. But I think over time, as transplanted heart recovers and filling pressures go down, those AP collaterals often improve and get smaller over time, but they don't need to be addressed.
Yeah, we've had some patients, especially those who wait for a long time on the list, have reemergence of collaterals. So we're wondering if you guys have any approach regarding recathing them routinely every 3 to 6 months while on the transplant list, or no?
No, and I think from a support standpoint too, it's all been relatively short to the point where we haven't had just the need yet or the indication to recath.
Being a cath doc, we tend to usually always pre-cath those patients and close all the collaterals. In the pre-Fontan cath early, we know that they come back very quickly and try to do the pre-Fontan cath 2 weeks before the Fontan. But in these failing Fontan patients who are going for transplant, I don't know whether it's because they're usually not so blue or what, but it seems like the work we do in terms of coiling collaterals tend to stay longer. So that if you do a very aggressive collateral closure in the pre-transplant cath, you do decrease the risk of bleeding in general. But sometimes we've had to come back, as you say, and go on close, especially if you suspect they had a lot of bleeding in the OR or they're high filling pressures.
I think we might have time for one more question that I can take from the virtual chat. When PLE turns into when does PLE turn into a heart transplant contraindication? And how do you manage systemic AP collaterals in the heart transplant? So I think we answered the second part of that question. I don't know if Dr. Saraf and Dr. Zinn, if you want to address PLE and heart transplant.
We've had some difficult patients that have had PLE, and if we could maintain some degree of control before, we have not had it as a contraindication prior to transplant in the right patient. Otherwise, the patient is a good candidate. We would have a belief that it would be successful in reducing PLE or recovering afterwards.
I think frailty is an important concept here too, seeing how much you can get the patient back to a stable state where, they can tolerate the rigors of transplant. And that becomes sort of a subjective decision, objective from a physician standpoint, because we see these patients, but it's a little bit of a gestalt on, how stable the patient is and what their frailty index would be.
I think Dr. Feingold nicely showed data that PLE resolves after transplant. I think one of the biggest considerations we take into account is how it could affect preformed antibodies going into transplant, and think about monitoring closely afterwards. Any other questions from the audience? All right, thank you to all of our speakers for an excellent session. Thank you. Have a break.
Hey, everybody, we're going to get started with our final session of the afternoon. Give people a minute to come in from the outside.
Our first presenter this afternoon is, for the session, is Dr. Natasha Roche. Oh, excuse me. Dr. Natasha Wolf, excuse me. She's an assistant professor of internal medicine and pediatrics at UPMC Children's Hospital in Pittsburgh.
Great. Thank you so much for having me. So I'm just going to give a fairly quick patient case presentation to kind of set off the topic of conversation for this session. So this patient is a 43-year-old male with complex single ventricle anatomy who had a Fontan at age 10 with progressive activity and tolerance over 2 years and worsening hypoxemia to the 70s. He previously was very active, walked a lot, but is now unable to do so without fatigue and dyspnea. He was at one point early in his evaluation found to have second-degree heart block, and a dual chamber pacemaker was placed. And he did have some subjective improvement in his symptoms for a period of time, but then they kind of returned. He also was started on sildenafil without much symptomatic improvement in his dyspnea and fatigue. So diving more into his medical and surgical history, he's a double outlet right ventricle with mitral atresia and a hypoplastic left ventricle. He had a balloon atrial septostomy at 2 months, an open atrial septectomy and PA banding at 7 months of age, then a right classic BTT shunt when he was 6 years old. And then it's a little unclear reading through his notes, but looking at kind of his cath images, he probably had a modified AP Fontan at around 10 years old. He had the pacemaker, as we spoke about, which was fairly recent. He did have a Fontan conduit thrombosis at one point as well. Was anticoagulated with resolution of clot. And then he has extensive VV collaterals, has had multiple coiling procedures. He also has Fontan-associated liver disease with known grade 1 varices and anemia and thrombocytopenia. So at the time of his evaluation, he was on pretty good medical regimen already, including carvedilol, daily Lasix, spironolactone, sildenafil, Eliquis, aspirin, and then also an iron supplement and allopurinol due to his chronic significant cyanosis. His social history was pretty unremarkable and very responsible patient overall. So his physical exam was notable for oxygen saturations at 78% in exam. He has well-healed sternotomy and thoracotomy scars and a right upper quadrant pacer, clear lungs. He has some systolic ejection murmur at the left upper sternal border and also a blowing systolic murmur at the apex. He does have a weak radial pulse consistent with his classic BTT shunt. His has some hepatomegaly and then positive clubbing and cyanosis and very prominent lower extremity varicose veins. So honestly, somewhat expected given his age and his known history. His labs were notable for mildly elevated INR, normal kidney function. He had kind of it was felt to be a relative anemia due to his cyanosis with a hemoglobin of 17. And then otherwise his liver markers, his GGT was mildly elevated. He had a normal AFP. And then when they calculate out his MELD score, it was 13. And then his VAS score, which is the varices, ascites, splenomegaly, thrombocytopenia score that we look at for Fontans was all of them was 4. So very high, consistent with significant Fontan-associated liver disease. His echocardiogram, these are pictures, just giving some shots showing you that he had normal systolic function. He had patent Fontan and low velocity flow and mild to moderate TR. He did have full body CTA with really remarkable prominent VV collaterals throughout. He also had some small AP collaterals. He had liver cirrhosis with evidence of portal hypertension with splenomegaly and varices. And then he did undergo an EGD with our hepatologist who also found varices. This is his cardiac cath data. And I think comparing 2 years prior to kind of presentation now, you see a remarkable change in terms of the Fontan pressure has gone from 13 to 21. And then he's also significantly desaturated. Remarkably, his cardiac output was not terribly depressed, but it was kind of just rising venous pressures and hypoxia due to the collaterals that was causing his limitations. So this patient ultimately, after extensive evaluation, was listed as a status 4 for combined heart liver. Liver hepatology did not end up wanting a liver biopsy. They felt like it was pretty clear that he was going to need a liver transplant regardless of what that would show, related to his portal hypertension. And also he had extensive collaterals down throughout the portal systemic system as well. On 6 months later, he did have kind of repeat imaging and a cath, and it demonstrated increased collateral burden as well as rising Fontan pressure. And so at this time, they chose to admit him and start on IV dopamine in order to kind of raise his transplant status. And so he was upgraded to a 2 exempt, and then ultimately received a heart liver transplant after waiting 2 months in the hospital. He actually did quite well post-operatively and was discharged home 2 weeks after transplant. That's it. Now we'll start the conversation. Okay.
Okay, to continue on that topic, now we'll have Dr. Lucy Roche come up. She's an associate professor of medicine at the Toronto ACHD program at University Health Network in Toronto, Canada. And she'll also be talking on heart as a single organ transplant versus heart liver combined transplant.
Thank you. Thank you so much for the invitation to speak today. It's really nice to join you and be part of this conversation. I have no disclosures. When I got given the topic of this, I felt this sounds like more of a debate. And which I'm supposed to give both halves. So that's how I'm going to approach it today. I'm going to debate the whole of the first half and then try and use similar data, because there's only so much data we can use here, and it's the same whichever half of this you're debating, and debate the other half. So I'm going to start with assuming that combined heart liver transplant is the ultimate therapy, as the paper says, for Fontan circulatory failure. And I'm going to give you 3 arguments why I'm definitely correct about that. And I'm sure you're all going to agree. And as we've already heard today several times, the first of these arguments is that by the time Fontan circulatory failure warrants heart transplant or heart liver transplant, Fontan-associated liver disease is ubiquitous. And then the second argument is that Fontan-associated liver disease causes perioperative catastrophe after heart transplant alone, and several people have alluded to that. So I feel I'm on kind of solid ground with these arguments. And thirdly, I'm going to show you some data hot off the press that combined heart and liver results as superior, and therefore I think this will be conclusive for you all. So let's talk about the first of these. So this is a mixed audience of pediatric and adult congenital cardiologists, and I'm actually a pediatric cardiologist by training who now only does adult congenital heart disease. But really in childhood, severe Fontan circulatory failure has become unusual. This is data from the Hospital for Sick Children in Toronto, which looked at all of their Fontans after 1985 in patients who'd had either an extracardiac or a lateral tunnel Fontans. There's 500 patients. And they divided it into 2 eras, and you can clearly see there was such an improvement in outcomes, and that since 2000, there's been no deaths. There may have been after this, I don't know, but between 2000 and 2012, there were no deaths before hospital discharge after Fontan completion. And since 2000, the late deaths were only 14 and 4.6%. So even if we were to think about transplanting these patients, there's very few in childhood that would need this, and mostly because we've discussed several times all the comorbidities of Fontan patients and the pathophysiology that continues after Fontan completion. This is something that adult patients will inevitably face, and the decisions will really become the realm of the adult congenital cardiologist. This paper looked at Fontan-associated liver disease surveillance in childhood, looking at repeated liver ultrasounds and laboratory data, and found that the prevalence of Fontan-associated liver disease and severity increased. And other people have shown similar data, but by the time these patients are 10 years after Fontan completion, 2/3 of them have moderate to severe, and they scored it in a way with points for each of these things, Fontan-associated liver disease. So you can see that by the time these patients reach adulthood, when we're talking about transplanting them, they're all going to have at least moderate, and a big chunk of them, probably more than a third, severe Fontan-associated liver disease. So it makes sense that we consider transplanting that liver in these patients when we come to talk about transplant. The reason it's important that they have Fontan-associated liver disease for us when we're thinking about transplanting them is that it really causes and drives these horrible early postoperative outcomes that people talk about after heart transplant alone. Dr. Hickey talked about some of this. These are intensely challenging transplants. You have to think about how you're going to get into the heart. These are some of the patients we've considered for transplant. You can see that this massive RA is right behind the sternum. You have to do PA reconstruction, aortic root reconstruction. You all know that these patients have collaterals. They've been mentioned several times today. Patients are sensitized. Sometimes you're taking hearts from a long time away and you can't control the ischemic time, and there are problems with vasoplegia and all the other organ dysfunction. So when you've got this intensely challenging transplant, why do you want to add to it this liver that may not function very well afterwards when you know the liver is impaired? And the reasons, the ways in which the liver contributes to postoperative mortality is in part because of bleeding. And I've borrowed these slides from a colleague who I heard present this half of this argument a while ago. And we know that Fontan-associated liver disease through many mechanisms increases bleeding post-transplant, decreases the ability for the blood to clot. And the bleeding causes RV dysfunction and multi-organ failure, and eventually results in death in the perioperative period. This is the role of bleeding in this has been confirmed by this paper, which is probably from, I'm going to refer to this paper a few times because it's probably the largest single center adult heart transplant only data. And they looked at patients between 2007 and 2019. And they found in various ways of looking at it that the biggest predictor of poor outcome in the perioperative period post-transplant were patients who had major bleeding during the operation, during the heart transplant operation. And the moral of this story is that if you could find a way to stop them having major bleeding, then you would put them on this curve, which would give you a very much better post-transplant survival. And I would posit that one way to stop the post-operative bleeding problems is to transplant the liver, because that's where the bleeding is often coming from. And then the third argument that I'm going to talk about is that combined heart and liver results are superior, not just for that early post-operative period, but also for late outcomes. We've heard today, and I'm not a hepatologist, so I can't explain this in depth. And again, I borrowed the slide from Justina, that the liver plays an important role in immunological function. And if your liver is functioning well, it probably decreases the risk of sepsis and rejection. And these are both things which we heard in an earlier speaker today drive post-transplant outcomes in Fontan patients. The highest risks of death are from, the biggest causes of death are from sepsis and rejection. So in some way, if you have a liver that's able to do these things and able to control this, you might produce better long-term outcomes. This has not clearly been studied in long-term follow-up, but it makes a lot of sense. And there is also potentially a role for improving late outcomes, is particularly in sensitized patients, if you have an immune function that's working quite well. All of this is summarized in this slide, which is the AHA White paper on Fontan-associated liver disease, and summarized very well here. You've seen the picture before, but it really is just arguing the difference between, if you're going to do a heart transplant alone, you have to consider what are the potential outcomes. So this fibrosis could regress, it could progress to cirrhosis. We've mentioned before that some of these patients are at risk of hepatitis C. If you leave the liver in place, presumably these patients remain at risk of hepatitis C in the long term, and that there is the risk of postoperative hepatic decompensation. So if you consider a combined heart and liver transplant, you get rid of some of these risks. Obviously, you don't have to worry about the development of progression and the development of hepatocellular carcinoma. And you also get these extra added benefits of the immunological benefit. So even without this new data that I'm going to show you, which is hot off the press, published this week, I think I'd have a pretty strong case for saying that heart-liver transplant is the best option for patients with a failing Fontan circulation. But just to add to that, lucky for me, presenting this side of the debate, this was published this week. And this is data from 15 US and Canadian centers looking at patients who'd undergone heart or heart liver transplantation and comparing the outcomes. There was 131 patients, which was 91 heart transplants and 40 combined heart liver transplants. All of the patients were over 16 years of age. The team gave a score, 1 point for any of these things. We've talked about it's difficult to know how bad is Fontan-associated liver disease. And lots of people today have tried to put up scores and shown other papers. But in this one, they gave a point for having had more than 2 paracenteses, imaging or pathology-based cirrhosis, splenomegaly, or varices. And that to me sounds a reasonable way of scoring it. I'll show you some other data from this paper later. The overall results were kind of similar, but if you look at the patients who have a high liver score, and you look at the patients who were transplanted after 2000, which is the more recent kind of era when more heart liver transplants were done, you can see a clear preferential outcome for patients who had combined heart liver transplant. So I really think that this is the nail in the coffin for the other argument. And I can't see how that anybody would disagree with the proposition that combined heart liver transplant really is the ultimate treatment for Fontan circulatory failure. And if I was doing a debate, this is where I would rest my case. However, I'm going to take my cardigan off and present the other side. So here we go. Pretend I'm somebody else now. And I'm going to present that I think combined heart liver transplant is rarely required for Fontan circulatory failure. And in fact, heart transplant is the preferred option. And I'm going to obviously, the person presenting before me had 3 great arguments, but I'm going to take those apart and I'm going to replace them with arguments that show that this is the definitely correct statement. And this time I know I'm going to win and you're all going to agree with me. We'll have a vote at the end, not really. Okay, so before I start my talk, I'm thinking about who might disagree with me, because when I'm trying to give a talk, I'm trying to win those people over. And unfortunately for me in this audience, there's quite a lot of US centers. And the first time I ever put this, I had some, and now I've put many. US centers probably disagree with me. Originally, it was just a couple of places. And you can see that these people's websites and papers say things like Fontan patients deemed eligible for single heart transplant will all undergo a dual organ transplant. And other people think it's the ultimate treatment option, like the person who argued before me. And even here, Sasha, who is in the audience, his website says now that these patients whose best chance at long-term survival is with combined heart liver transplant. And this is the kind of thing our patients can read when they're trying to find out about this. Unfortunately for me, well, not unfortunately, this message has come along and people are really taking to it. And there has been increased use of combined heart liver transplant in the US in recent years. And you can see this paper here showing a much bigger number of patients. So this is 50 per year in patients from 2011 up to 2020. And you can see that the era-related changes relate to the diagnosis. So in the more recent era, the primary diagnosis now for combined heart liver transplant in the US is congenital heart disease. And then this hot off the press thing makes it even more clear. This is a United States paper, obviously, and shows that survival rates are better. So I really think that you are a tough crowd for me making the opposite argument of this, but I'm going to do my very best to take down these 3 arguments, which I think are completely incorrect. I'm going to start with this one. Well, actually, it's not incorrect. It is ubiquitous, but I don't think that that's the point. So yes, I agree that Fontan-associated liver disease is ubiquitous in adult life, but that's not the point at all. More importantly, how many people are living with this Fontan circulation? And this is a paper which is quite interesting. It starts out with a real number. They actually counted in, I think it was the UK, Australia and New Zealand and the US, how many patients are alive with a Fontan circulation at the moment. And it's 66 per million in 2020, 55% are adults. And then they did a prediction of how many there will be. And you can see it is mostly adults now that are living with this circulation, and there's 77 people per million. So yes, all of these people have Fontan-associated liver disease, and at some point, many of them are going to need a heart transplant. They may not all be eligible for a heart transplant, but they're going to need one. Just looking at Canadian data, I can't find this data for the US, but if we think that we're going to give them all a heart liver transplant, what will that actually mean? Well, looking at the waiting list in Canada, you can see that people waiting for a liver transplant last year, of the people on the waiting list, 95 died without a liver transplant. So if we're going to start adding to this 77,000. It won't be all of them at once, obviously, but a large number of Fontan patients who we're going to try and take the livers from these patients. This number is going to be much higher. So we're really talking about something that I think is the most important thing when we think about who needs a transplant. It's not that you have Fontan-associated liver disease that means you need a transplant. We have to go back to our medical ethics training 101 and think about how do we make a decision about the best action to take. And we have to think about doing good and not doing harm and what the patient might want in this situation and ensuring fairness. And then this is something that we can think about. You maybe did this experiment at university where you have a trolley car and you get to make these thought decisions about, are you going to pull the lever and let the trolley car go this way or that way? And they make it harder and harder to, are we going to do the greatest good for the, what is it called? The utilitarianism, the best increase in utility, the best for the most number, or are we going to try and help one or two people? And this definitely plays a role in this, because some of these patients, if we take these livers for our Fontan patients, there will be other patients who die from liver failure who do not have an organ replacement therapy. We've heard here that VADs potentially can be used for Fontan patients. There isn't a VAD, I don't think, for a liver that's failing or something like it. And I don't think so. So I'm going to replace this argument. I think that this is, it's true, but it's not actually an argument. And I'm going to replace this with utility. And this, I found that you actually used to have trolley cars here in Pittsburgh. We still have them in Toronto. So just to remind you of what I mean. So I think in terms of utility, my argument that heart-only transplant is better is the right one. So I'm going to come to the next one. So Fontan-associated liver disease is a pathway to perioperative catastrophe, and doing the same thing over and again and expecting different results is insanity. Okay, so it's true that bleeding is an important cause of postoperative mortality. I 100% agree with that post-transplant, but I think the situation of what kills patients in the first phase of transplant is very much more complex, especially if you think about the patients we're talking about. So there are so many different types of Fontan circulation. All these different versions of it. We've heard about the history of the surgery today, and it's a wonderful story of innovation and impressive survival improvements. But it means that there are lots of different sorts of patients out there, and there are different patients even from the original anatomy with which ventricle is first and last. So these patients they probably all respond slightly differently to the surgery that we put them through. There's also differences in the liver. We heard that there can be other like fatty livers and patients who have exposure to toxins and alcohols and with hepatocellular carcinoma and without, and where the liver is. And these things make a difference, I think, in how patients do post-transplant. None of this, I think, probably is as big as this in terms of my argument really would be that this is a huge part of how we manage transplants and how we get good outcomes. Every place that does transplants does them differently, does them with different teams, different people, and who runs the show is different in different places and who's at the center of the decision making. And your transplant can be done by an adult cardiac surgeon, a congenital cardiac surgeon, a pediatric person who primarily does pediatric procedures. And the anesthetists are all different, and who manages your ICU are different. And then who puts the patient on the waiting list and who picks the donors. All of these things are different. I think by no way is the case clear that the postoperative bleeding problem, which kills patients perioperatively post-heart transplant, is caused by the liver. I think some of these things might play a role, which are difficult to factor into it. So I would say that this argument is important, but you haven't proven that it's the heart transplant alone that causes this. I think there's lots of other things, and I think there's a question about causality. And I'll just come back to that in a second, because I'm going to talk to this difficult argument here now. I'm going to use the rest of my time to just talk about this. It's a hard case to argue with this data, you would think, except it's not really. So this, you'll see here, I've changed the graph. This is the actual survival, not for just the ones with Fontan-associated liver disease. This is for the whole group of patients who were propensity matched. So they had 30. When the big numbers of patients that they had, 191, if you work that out, it's a 26-year study with 131 131 patients in 15 centers. That means that if every center were doing them, both types of transplants, there would be, each center would do one every 3 years. So the real problem with this data is that there's hardly any patients getting transplanted. No matter what way you look at it, it's back to that utility question. It's difficult to get these patients transplanted. And the real numbers here at risk in this propensity match thing are about 30. So there's not very many patients in this. And I think that they're missing a lot of heart transplant only patients by getting a multi-center data from different centers in the US that do very few heart transplants. And I'll explain why in a second. We had Ed Hickey showed some of the data from Toronto, which I'm not going to show, but that to show that we had a problem in Toronto with outcomes from heart transplant before 2012. And that was for all congenital patients, but it was definitely worse for Fontan patients. And we had 4 deaths in Fontan heart transplants alone. And we really made a big effort in 2012, 2013 to change things. We actually went to this center, which is the largest center, 31 Fontan heart only transplants who are not in that data, but it's the same as all the heart only transplants, to see how they did it and see how they were trying to get these patients with the excellent mortality. So our whole team, a large team from Toronto, visited the Freeman in 2014, but we'd already made some changes. We made the changes in 2013, and I've just listed them here, but we did lots and lots of different things. We started an ACHD heart failure clinic. We put the ACHD cardiologist kind of quarterback in the whole thing, the transplant assessment, the timing of listing, whether there were alternative strategies that could be pursued. We had a preoperative anesthesia clinic, monthly surgical performance rounds, congenital heart disease surgeon performing all the transplants, lots of different things. And we also put a VAS cath in every patient. I forgot to put this on this list, but so that we can do early postoperative dialysis, which somebody else mentioned just before. So we did lots of things and we really changed our outcomes. So this is our data now in the current era for heart-only transplant. Since 2013, we've done 21 adult heart transplants. 20 were in patients who were on Mironone at the time of heart transplant, and the survival to discharge was 19 out of 21. These are all in Fontan patients and only heart-only. And our 1-year survival is 85%, and we have one person who's yet to reach the year, but she is still alive, and that would be 86%. I have to thank Chris Broder, who's currently in Houston, for collecting this data for us. So we think that we can get excellent results with heart-only transplant in these patients, many of whom have ascites and hepatic, all the features of Fontan-associated liver disease, and we're in the process of writing this up. And we did already write up what happens to the liver later on to answer that question about, do these patients go on to get cirrhosis? Do they go on to get other complications of hepatic failure later on? And we wanted to see what happened. This was a while ago. We've obviously done more since then, to the patients who had already survived 1 year. And these were the questions that we were asking. We looked at the pre-transplant clinical characteristics, and you can see that we didn't really do that many biopsies. That's not part of our routine practice anymore, but the ones who had a biopsy mostly had cirrhosis. 80% of them had cirrhosis on liver ultrasound. Many of them had ascites pre-transplant. So they have Fontan-associated liver disease, as we would expect for the ages of the patients. You can see the age at transplant here is quite old, quite a lot older than other people's patients sometimes are in these studies. A follow-up of 4.7 years, 9 of 10 of these patients had ongoing freedom from ascites. The CVP decreased at transplant and remained normal thereafter, although the liver and spleen dimensions did not change, and you can still see the liver's abnormal. However, with this relatively short follow-up, none had developed hepatocellular carcinoma, and the thrombocytopenia had improved. So I would say it's not that hard to argue with this data. Our data's in this data, but it isn't separated out between 2013 and 2000 and before 2013. And although they looked after 2000, I think there's quite reasonable data to say that it really outcomes from heart-only transplant improved in the mid-2000s. I think that there's not a lot of patients in this. It's very interesting data. It's very important data, but it's not a definitive argument, I would say, in terms of saying that combined heart-liver transplant is always better. So I would question the efficacy. So to summarize my arguments at the end of this, I would say that heart-alone transplant is clearly the best option for Fontan-associated Fontan circulatory failure. And I would say it's a deliverable and sensible use of organs. The liver can go to someone who actually needs it. You can get excellent outcomes in specialized centers. And I think it's a lot to do with the team and how the team work together to produce an excellent outcome for these patients. It's not easy. I think that there is potential, if you just do the hearts, to scale that for the size of the Fontan population, particularly if you can use VADs to support people till they get transplant. And I'm going to give a 2-minute rebuttal. Hold on. So you said it's rarely needed. What did you mean by that? sorry, it's the end of the day. I thought I would try to entertain everybody a little bit. When would Toronto opt for a combined heart liver? Well, this is when we would. So we would transplant somebody's heart and liver, and we've done it once if somebody who had hepatocellular carcinoma, or if in this picture here you can see the ascites in this liver, but the liver's very small and shrunken, and we haven't determined exactly what small is, or if there were many other risk factors that we felt that the liver being very borderline would be too much, so we would add up all the risk factors. So this would be a case like that. I'm just going to show you in the last minute. Recently, we had a 23-year-old about 14 months ago, this was, with severe Fontan circulatory failure. She had dextrocardia, as you can see, left atrial isomerism, bilateral SVCs, and she'd had a Kawashima type Fontan with a right-sided Glen. And she had a Gore-Tex, a 20 millimeter Gore-Tex conduit incorporating hepatic veins. It was interesting. She had these two very large hepatic veins, and she had a lot of vena-venous collaterals, and her saturations were 86%. This is just some pictures to show you, and the risk of sternal reentry, which we take a lot of consideration about. So she had ultrasound and CT features of cirrhosis with portal hypertension, splenomegaly. She'd had ascites for 2 years with paracentesis every 4 to 6 months. We don't generally do paracentesis, which is why I wonder about that as an inclusion criteria. We just don't do it very much, even with big ascites. But she was getting 2 to 3 liters drained out. She'd had prior varices, banded, thrombocytopenia, a transhepatic gradient. So we thought this was a high-risk sternal reentry, something unusual there about those hepatic veins that might be difficult to plumb back into a new heart. Clearly a massive liver, ascites, and yes, you would think we would do a heart liver. But we didn't. She had just a heart as well, and she was completely fine. And the reason we didn't was we had a meeting with various people, including those people in Newcastle with the 31, looking at all the anatomy, discussing it with the liver surgeons. And we thought of a very thought through strategy of how we would manage her anatomy, the donor, her risks preoperatively, and she has been fine. She's about 14, 15 months post-transplant now. So really my sort of coffee shop consensus is that there are advanced therapies, and you can't adapt a one-size-fits-all approach. And it's not really one type of patient that you have to do this. And each institution is going to get best results doing it in slightly different ways. And for some places, combined heart liver might be the best answer, because at least these patients then get a transplant and they might not otherwise. And different countries might have different approaches depending on organ availability and that kind of thing. But what everywhere needs is this kind of highly committed, mutually trusting team who can, and you need to be in an institution that can tolerate the learning curve. Even after we revised our approach, the first patient died, and it would have been very stressful if we'd have then had to stop, but we obviously didn't. And I would say that we will always offer heart liver for hepatocellular carcinoma. And these things would definitely raise red flags in us to make us think about it, particularly if there were other anatomical or non-cardiac risk factors that might make us think about it. So I'd like to thank everyone for bearing with me with my cardigan off, cardigan on approach. Thank you for listening. Thank you for the invitation. And I'm really sorry, but I have to run to get a plane. So I'm not going to be able to sit on the panel. But if anybody wants to email me or talk to me afterwards, you're welcome. Thank you very much.
I'd like to introduce our next speaker, speaking on surgical considerations to transplant, Dr. David Kazarowski. He is an associate professor of cardiothoracic surgery and the surgical director of the Advanced Heart Failure Center at the UPMC Heart and Vascular Institute here in Pittsburgh. And he will be speaking to us virtually here today.
My name is David Kazarowski, and I'm the surgical director of the Advanced Heart Failure Center at Hello, my name is David Kazarowski, and I'm the surgical director of the Advanced Heart Failure Center at the University of Pittsburgh Medical Center. I'm an associate professor of cardiothoracic surgery in the Department of Cardiothoracic Surgery, and I work closely with our congenital heart surgeons to do the adult congenital heart transplants at the University of Pittsburgh. And I greatly appreciate their collaboration on that. And with that, I believe we've been able to achieve some very good outcomes. I've been asked to discuss surgical considerations to transplant in the Fontan-Kreutzer patient, and that's the focus of my talk today. So it's clear that long-term survival in patients with single ventral congenital heart disease can be commonly achieved with staged Fontan palliation. However, it's also clear that late morbidity and mortality can occur through a number of different mechanisms. These can include Fontan pathway dysfunction, systemic ventricular dysfunction, extracardiac dysfunction, including liver dysfunction and renal dysfunction. It can also include lymphatic dysfunction resulting in protein-losing enteropathy or plastic bronchitis. And some have suggested that advanced heart failure consultation should be considered when these things occur. And it's clear looking at ISHLT data why in adult patients, transplantation might be an attractive option for patients that have late complications. Specifically, we know from ISHLT data that although there is a fairly high perioperative mortality in patients with congenital heart disease, there's really excellent long-term survival. This is even more clear when we look at survival conditional on 1 year survival. And specifically in this case, patients with congenital heart disease, denoted here by the yellow line, actually have the very best survival compared to other groups. Now, it's also clear that stage palliation for single ventricle hearts can cause a number of issues for transplantation down the road. Specifically, in order to perform this sequence of operation, multiple sternotomies is required. There may be construction of a neo-aorta, and there's surgical manipulation of the pulmonary arteries. This may include a BT shunt, a Sano shunt, and of course, Glenn and Fontan anastomosis. So this sequence of operations can result in a number of challenges. And one of these challenges is sternal reentry. When we look at patients that have had single ventricle palliation and specifically those with neo-aorta reconstruction, we can often see aortic dilatation. This aorta may be just underneath the sternum, and the heart and other structures may be densely adherent to the sternum underneath. This can create a dangerous situation when we attempt to re-enter the mediastinum. Some have advocated the use of cannulation of peripheral vessels and early institution of cardiopulmonary bypass to help mitigate these risks. Other challenges include the presence of collaterals. We know that one of the things that's difficult about these operations is that intraoperative and perioperative bleeding may occur, and this is really a major source of morbidity. There may be veno-venous and or aortopulmonary collaterals, which may be present, and these can result in bleeding during the mediastinal dissection. So it's clear that meticulous attention to hemostasis is crucial, and awareness of the presence of these vessels is important. As I mentioned, there may be aortic dilatation. There may be also calcification of the neo-aorta. And aortic dilatation, again, can be a problem as it may necessitate replacement of some of the ascending aorta or aortic arch. Again, it may create a dangerous situation for sternal reentry. In addition, aortic calcification may create a difficult situation when attempting to anastomose the donor aorta to the recipient aorta. And in each of these situations, it may be necessary to perform an ascending aortic replacement and or hemi-arch. As I mentioned, the pulmonary arteries may be manipulated. There may be an atriopulmonary connection. There may be a lateral tunnel, total cavopulmonary connection. There may be an extracardiac conduit. In each case, there is manipulation of the pulmonary arteries, and this may result in stenosis, and the pulmonary arteries may or may not have been stented. In any case, the pulmonary arteries may be patched or entirely reconstructed. There may also be anatomic variation, including variation in the position of the great vessels, as shown here with the PA stump to the right of the aorta. There may also be dextrocardia or situs inversus. There may be venous anomalies or other anatomic variations. All of these challenges represent challenges to the mediastinal portion of the operation. But in addition, these patients may have cirrhosis, which can result in coagulopathy due to impaired synthesis of coagulation factors and thrombocytopenia. There may be also venous collaterals or varices that can be prominent. These can result in bleeding as well. In some cases, a combined heart-liver transplant may be necessary, and this can be either performed sequentially or en bloc. These issues were summarized nicely by Konstantinov and colleagues in this figure that was published in JTCVS Techniques in 2022. The authors illustrate here that, again, there can be manipulation of the pulmonary arteries with the Glenn and Fontan itself. There may be neo-aortic dilatation. The PAs may be stented. I didn't discuss this, but a left ventricular assist device may or may not be present. There may be anomalous venous anatomy, including the presence of a left-sided SVC. So again, this may necessitate a variety of things that complicate the operation. There may need to be ascending aortic or hemiarch replacement, or as illustrated here, total arch replacement. The PAs may need to be patched, as I said, or also simply replaced with a tube graft. And there may need to be venous reconstruction as well. Then the heart can ultimately be transplanted in really a normal fashion. But this does involve a significant amount of operation, which then necessitates longer cardiopulmonary bypass times and may result in longer ischemic times as well, which may not be good for the graft. There can also be a number of other challenges. These include things like protein-losing enteropathy, renal dysfunction, an elevated pulmonary vascular resistance, and there may be challenges diagnosing that. Patients may have muscle wasting, and they may also have preformed antibodies. Top of that, the adult heart transplant allocation system was revised in 2018, and it was revised from the old system, which was essentially a three-tiered system, status 1A, 1B, and status 2, to a six-tiered system, status 1 being the highest and 6 being the lowest. And patients that were most acutely ill were essentially allocated to the first status. Many of those patients may require VA ECMO, but they must meet hemodynamic criteria. Patients with congenital heart disease, including patients with Fontan circulation, are status 4 in this allocation system. And it can be challenging to obtain high quality hearts for patients that are status 4 in the system. So it's clear that staged surgical intervention for single ventricle hearts can result in a number of challenges to subsequent heart transplantation. So what are the outcomes after cardiac transplantation in Fontan patients? Simpson and colleagues looked at outcomes after pediatric heart transplant in the pediatric heart transplant study database. This database is housed at the University of Alabama, but includes data from 38 centers, at least at the time of this publication, and these are located across the United States, Canada, and the UK. Previous work had demonstrated a relatively high post-transplant mortality in Fontan patients undergoing heart transplant, most of which was in the early perioperative period. And so Simpson and her co-investigators divided these patients into early and late cohorts. The early cohort was between 1993 and 2006, and the late cohort was between 2007 and 2014. The patients in the late cohort had a slightly higher incidence of renal insufficiency, although this did not reach statistical significance. They did have a higher incidence of protein-losing enteropathy, which did reach statistical significance. There was also a significantly higher proportion of patients with failure to thrive in the late cohort, and the patients in the late cohort were more frequently supported with inotropes, whereas the patients in the early era were more commonly on a ventilator at the time of transplant. They also compared patients with other forms of congenital heart disease to those with Fontan circulation. And when they looked at these groups, they found that there was a slightly higher incidence of renal insufficiency in the Fontan patients, although again, that did not reach statistical significance. There was certainly a higher incidence of protein-losing enteropathy, also a higher incidence of failure to thrive, again, not reaching significance here. There was a significantly higher incidence of inotrope use in the Fontan group, and the non-Fontan patients had a higher incidence of ventilatory support. I'll also point out that as we discussed, and as you might expect, the ischemic time was longer in the Fontan patients, although not significantly longer from a clinical standpoint, although it did reach statistical significance. There was a higher percentage of patients that had an ischemic time longer than 4 hours as well. So when they looked at the outcomes in each of these eras, the early era and the late era, what they found is that there was a high hazard or mortality in the early perioperative period, and this leveled out. This is what has been seen previously. The 1-year survival in the early era was 77% compared to 89% in the more recent era. And now, when they compared the patients that had Fontan circulation performed in the early era, it was seen that these had the worst overall survival with a high perioperative mortality. This certainly improved in the more recent era and was much closer to what was observed with other patients with congenital heart disease in both eras. In terms of causes of death, infection was a major cause of death in both eras. Around 20% of patients died from infection. Acute rejection was actually a significant cause of death as well, causing death in 14% of patients and just over 11% in the late era. And then sudden cardiac death was high in the early era, 14% versus only 3% in the late era. Other causes of death accounted for 30%, or roughly 30%, both groups. And some of these were likely due to multi-organ failure in the perioperative period. Mertuzza and colleagues also looked at outcomes in patients with Fontan, but they looked at survival of adult patients undergoing cardiac transplantation at a single center. And what they found is that the mortality of patients with Fontan circulation was very high and was over 30% in the early perioperative period, although they did have a fairly high mortality of non-Fontan patients as well. What they found also was that the incidence of heterotaxy was much higher in non-survivors, and the MELD score was also much higher in non-survivors in their series. In an overlapping cohort of patients, Cordoso and colleagues looked at outcomes in patients undergoing transplantation. These are adult patients with failing Fontans, and asked what we could potentially do better. And so when they looked at these patients, again, they observed a fairly high perioperative mortality, again, in the neighborhood of 30%. And then they stratified by the presence or absence of major intraoperative bleeding, and they found that there was an extremely high mortality in patients with major intraoperative bleeding and a much lower mortality in patients that did not suffer from major intraoperative bleeding. They identified this as a major target for improvement in these patients. Now, this was a slightly flawed definition. They used the number of packed red cells as one criterion for the diagnosis of major intraoperative bleeding, but also the need to go back to the operating room. And importantly, the presence of an open chest was used as a defining criterion for major intraoperative bleeding. So you could imagine that patients with significant right heart dysfunction may also fall into this group. But I think the data does demonstrate that major intraoperative bleeding is certainly a problem, and if we can avoid that, we can potentially do better with outcomes in these operations. Jonathan Menachem and his group looked at outcomes in adult heart transplant patients, this time using the nationwide inpatient sample database. And so they looked at inpatients between 2004 and 2014 who underwent transplantation with the diagnosis of single ventricle. And what they found is that overall, the mortality was 5.4% in the cohort of patients they looked at. Of those that had a Fontan, as compared to other adult congenital patients, the mortality was 26.3%. So there was a odds ratio of 18, and this did reach statistical significance for the presence of a Fontan. The rate of major bleeding was also much higher in patients with a Fontan, and the use of ECMO was also substantially higher in patients with Fontan. And again, both of these reached statistical significance. So what can we do to optimize these outcomes as outcomes for heart transplantation in adults with Fontan clearly not optimal. There are a number of things that can be done. Some of them I've listed here, but clearly from a pre-transplant standpoint, we definitely want to perform imaging to define the anatomy, including the great vessel arrangement and venous anatomy. It's important, I think, to document the vascular access, as well as get the best assessment of the PVR that's possible. I think it's important to assess hepatic function in the presence of cirrhosis. And it's also important to assess whether the patient is sensitized or not and have a strategy to deal with that, and as much as possible to optimize the nutritional status. For our donor selection, we avoid undersized donors, and I think that is largely agreed upon. Marginal donors with marginal LV or RV function should probably be avoided, and extra length on donor vessels can be useful as well. From an intraoperative standpoint, we've already touched on some things, but I think coordination is of the utmost importance. I think it's important to allow extra time for insertion of lines, anesthesia, and the initial dissection. Because the sternal reentry can be problematic, it's probably advisable to have peripheral access available. If the initial sternotomy and dissection can be performed off of bypass without the administration of heparin, that may be beneficial since the patient won't be anticoagulated, but if it's necessary, it is. The pulmonary venous return from these collaterals may also be unusually high, and cooling can be very useful, as well as additional venting. And then, as we discussed, deep hypothermic circulatory arrest may be necessary for aortic reconstruction or if there's significant injury on reentry. Certainly, there are many others, but some of these things may help us optimize outcomes as we approach these patients. There are a number of alternatives to transplant. Konstantinov in his JT-CBS techniques outlined a number of potential ways that ventricular assist devices can be utilized, and some of this has been discussed already today. And Dr. Morell will be also discussing some other alternatives to transplantation in his talk. So in summary, I think we can say that the long-term survival in patients with single ventricle congenital heart disease is commonly achieved with stage Fontan palliation, but there is late morbidity and mortality that can occur through several mechanisms, and heart transplant is one treatment option when this does occur. Stage palliation for single ventricle hearts requires multiple sternotomies, surgical manipulation of the pulmonary arteries, and may involve neo-aorta reconstruction. This process results in a number of challenges to transplant, including mediastinal adhesions, aortic dilatation, calcification, collaterals, and the potential need to reconstruct the pulmonary arteries and others as well. Outcomes for pediatric patients undergoing heart transplant are comparable to those with other types of congenital heart disease and have improved over time. However, mortality after heart transplantation in adults remains high, but this can be in part mitigated by careful pre-transplant preparation, donor selection, and intraoperative management, including the avoidance of major bleeding. Thank you for your attention, and this is my email address. I'd be happy to discuss this further or take any questions. Thank you.
All right, our next speaker will be Dr. Victor Morell. He's the Eugene Weiner Endowed Professor and Chair of Pediatric Cardiothoracic Surgery, Surgeon in Chief here at UPMC, the Executive Director of our UPMC Heart and Vascular Institute, and the Co-Director of the HVI at Children's. Dr. Monroe, he'll be talking about the novel alternatives to transplant biventricular and 1.5 conversion.
Thank you. Thank you, Matt. Thanks everybody for hanging around. I know it's been a long day and hopefully I won't make it any longer than it has to be. I have no disclosures. You know, I thought that this was somewhat of a very difficult topic because I'm not sure that we have really novel techniques to transplantation in single ventricles, but I think we have some ideas. We have to assume, as it's been described by many different people in this panel, that every single patient who has a single ventricle physiology will likely or has a real chance of ending up in a transplant center for transplantation, cardiac liver. I mean, so I think when I think about this specific talk, that when we look at viable alternatives for transplantation, I'm really looking for viable alternatives to single ventricle physiology, because that's really the question. And that's what I think my talk will be about. And also in those few alternatives, are the outcomes any better than transplantation? So this is a meta-analysis on which I kind of like the title of it. Said meta-analysis of the effectiveness of heart transplantation in patients with a failing Fontan. So the effectiveness is kind of, you know, how effective is transplant on these patients? And this is meta-analysis of many different, and you can see mortality, it varies throughout. Obviously, different centers have different expertise. And I think, unfortunately, for transplantation, we see that outcomes can be affected by that. But let's assume that the 1-year survival for a transplant on a failing Fontan is about 80%. And we'll go with that number. So when should we consider alternatives for the Fontan-Kreutzer palliation? You know, and really the answer is always. Unfortunately, most of the time we have no other option, but we always think about the possibilities of doing something different. And it's always difficult to consider another option as surgeons, I have to tell you, because the Fontan-Kreutzer procedures become such a standard, simple, straightforward, extremely low mortality procedure that at times myself, I say, why would I expose this beautiful child to this complex of an operation, maybe get to a biventricular repair, maybe at a maybe, I don't know what kind of cost, you know, with a higher mortality, maybe more reoperations, when I can certainly guarantee a family that comes for a Fontan that the patient's going to be fine. I mean, the mortality for the Fontan-Kreutzer nowadays is almost 0%, honestly. So it's somewhat of even a moral discussion as a surgeon, as a team, say, what are we going to do with this patient, you know? So anyway, the group from Boston truly have pioneered the concept of, can we grow a ventricle, you know, which it's been around not for a little while. First paper here by Imani in 2012, looking at the recruitment, what they call stage left ventricular recruitment after single ventricle palliation. And it's truly an interesting study. They looked at 34 patients in which they're taking through the single ventricle stages, Norwood, Glenn, and Fontan, but they're also doing other surgeries to different structures that we'll discuss, and compare them to patients who are going through the same process, but they're just going through the standard, you know, Norwood, Glenn, Fontan. And you can see in the left heart rehabilitation group, they're doing, you know, stage 1, but at that time they might be doing EFE resection, they might be doing a mitral or aortic valvuloplasty, ASD restriction. You can see in stage 2, they're readdressing some of those issues. Stage 3, they're readdressing some of those issues. And they're comparing this group to patients who just had a Norwood, Glenn, Fontan with nothing else, okay? And then we look at what happens to those ventricles. And they show that the left ventricular and diastolic volume grows, so that ventricle seems to be bigger. the length of the ventricle is bigger. Compare, this is the patients who didn't have the valvuloplasty or anything else, they just had Norwood, Fontan, and these are the patients that had the LV rehabilitation, the mitral grew. So you can argue that this is an interesting concept that maybe we can grow a left ventricle on the mitral valve and the aortic valve, but only 13 patients out of the 34 that was in the rehabilitation group ended up getting a biventricular repair, and the outcomes are somewhat unclear yet. So we don't know what truly happened. This was followed by a more recent paper in 2021 from the same group that are looking at biventricular conversion after Fontan, and this is a preliminary experience. And again, they agree that even patients with well-functioning Fontan circulation, long-term failure is inevitable. So again, we have to look for other options. So they had a total of 23 patients, 17 that had a primary biventricular conversion, and 6 patients that had a stage biventricular conversion. So they had a Fontan, some of them went from Fontan, 17 of them Fontan to a biventricular conversion, and 6 that they had stage conversion, just like the previous ones I just showed. When you look at the diagnosis, clearly, it makes sense that patients with hypoplastic left heart syndrome who were Fontans at that time, they needed a stage conversion as opposed to a primary conversion. And, a lot of the patients with the primary biventricular conversion were patients that had some type of heterotaxy, TGA, DORV, and other diagnosis, only one was under the diagnosis of hypoplastic left heart syndrome. When you compare the pre-op hemodynamics of these patients, essentially was very similar. When you look at the end-diastolic volume and systolic volume, the patients with the primary biventricular conversions tended to have slightly bigger, and I would argue almost normal size ventricles compared to the patients with who had stage palliation. The staging and recruitment of those 6 patients as in that first study, included fenestration of the ASD, atrial and mitral valvuloplasty, resection of EFE. So again, very similar. When we look at the overall survival, of the whole 23 patients here, you can see that the early mortality and the mean follow-up on these patients is only 1 year. Okay, so we don't really have any long follow-up on these patients. It's just 1 year, but at 1 year, you can see the overall mortality or the overall survival, I think it's just south of 80%. Reintervention-free survival, as you can see, is quite poor. When you look at reoperations and caths, in these patients, they're significant. A lot of patients need reoperations. A lot of patients need cardiac catheterizations. Interesting, when you look at the survival of patients that came in for just elective, so they were not considered to be failing Fontans, the survival is quite good. So you have a patient who's otherwise doing fine, who has a Fontan that comes over and you say, well, can I turn this patient to a bi-V repair? Those patients in which you can do it apparently do well. But if you try to convert somebody who's coming with a failing Fontan, the outcomes are not as good. From the Boston group, there's a significant learning curve to this biventricular conversion. And obviously, as we can imagine, I mean, these are complex operations, and I think we can argue all day about growing hypoplastic left ventricle. If it's, can you really make it a real ventricle? Is it, even though it's bigger, is it really normal? And certainly, but there's a learning curve to doing these operations. They concluded, at the present, it is unclear whether this treatment strategy is superior to conventional single ventricle palliation or preferable to transplantations in patients with a failing Fontan. Okay, so even though it's an option, is really unclear that it's any better than just going ahead and doing a transplant on those patients who have a failing Fontan. This, I think, is a very interesting paper, and some that specifically I haven't really thought much of. And now every time I see a patient that could be a candidate for this, I consider it, which is a concept of ventricular switch. Basically, in patients that have 2 ventricles or maybe have 1.5 ventricles, instead of just saying, well, the LV has to be the systemic ventricle, maybe we just keep the RV as a systemic ventricle and do arterial switch. And that is a great concept, and maybe not applicable to 1,000 patients, but it might be applicable for a few patients that we see every day in our clinic. And for this specific, they had 3-dimensional models they thought that were critical. And I have to say, the more we use 3-dimensional models for complex patients, complex transpose, for example, it is very useful. It's a tremendous complement to what we do every day. They only presented 5 patients. There's only 5 patients here from different centers. They all had basically heterotaxy, as you would imagine. And 4 of the 5 were basically done as a salvage. These patients were failing in some single ventricle stage, so. And if you look at the operations they ended up doing on the patients, included, septation of AV valves, repair of partial anomalous pulmonary venous return, atrial conversion. So you have to do atrial switches because you're going to put you have to redo the way the venous system works inside the heart. And you have to put an LV to PA conduit because the LV is becoming now the subpulmonic ventricle. Okay, interesting concept. I think that this is something that we might see more in the future. I also wanted to just point out that I know Mark Rutherford in Indianapolis and his colleagues he's been working now for quite a few years on developing a Fontan pump, which theoretically could become a ventricle. And this is basically, you have this pump here somewhat spins in the middle of the intersection between the IVC, SVC, RPA, LPA. And the concept is that it augments the flow through the SVC, IVC, and through the RPA and LPA. And at least in the lab, you can see in a mock loop, this the baseline pressures in the cava was 17, on the PAs was 14. So you have a higher pressure in the cava than you have in the PA. But when you use this pump and start, getting at higher reps, you drop the pressure in the cava and you increase the pressure in the PAs, which is really what happens in our hearts. Our ventricle increases our pressure in the PAs. So this is, an interesting concept, still a lab experiment. We haven't, it's never tried in humans, but maybe one of these days it will. And I just want to just describe a recent patient we had, came as a consult from another center, 10-year-old boy with heterotaxy, dextrocardia, VORV with pulmonary atresia, had severe AV valve regurgitation, right-sided, had bilateral Glenn's and a Fontan-Kreutzer procedure. Had plastic bronchitis for 2 years and failed lymphatic intervention. And on presentation was coughing, casts daily. Had a MR, showed dextrocardia, patent bilateral bidirectional glands, unobstructed Fontan. Left ventricle was anterior and inferior, and left where the right was, the ventricle was, right ventricle was posterior and superior and more to the right. And the aorta arises from the right ventricle. The right ventricle was mildly hypoplastic, with good function, and the left ventricle had good function too. It was basically from the MR. You can see the RV here, slightly hypoplastic, the LV here, aorta was sitting right there. Had a right-sided IVC to PA, had bilateral bidirectional glands. You really can't see the left, but it was there. So we presented in conference and thought that this was maybe a candidate that we can, we agreed that we'll take to the OR and try to convert into a biventricular repair. So We did a 1.25 ventricle repair, and we repaired the first thing. We repaired the tricuspid valve. We patch closed the VSD. It was more of a Rastelli type funneling of the LV into the aorta. We had an RV to PA conduit, Fontan and left glen takedown. And I left the right glen simply because anatomically I couldn't figure out a way to reconnect it. The aorta was in the middle, the RV to PA conduit was in the middle, and there was really no other way I can get that right glen into the heart, into the atrium. The post-op TE show normal ventricular function, trivial tricuspid regurgitation, and no stenosis anywhere. This is a post-op from an MRI reconstruction. You can see here the aorta connected to the LV. You can see the RV here. The conduit kind of sat to the right and looped around. So when I did the operation, I initially had to transect the aorta in order to take down the glen. The left glen is here, reconnected to the top of the right atrium. You can see the right glen here who stayed connected to the RPA. We were able to disconnect the Fontan conduit and connected it to the right atrium. And the patient did quite well. Had post-op cath that showed great hemodynamics. So just some final thoughts. We have a limited number of options to transplantation in patients with failing single ventricle physiology. Biventricular conversion is really rare and often plagued with complications. We still have no proof that it provides better outcomes. Stage recruitment of the LV is an interesting concept. We still have minimal data. Ventricular switch concept needs to be considered in some of the patients that we see, and I do think that certainly it should be in an armamentarium. And there are certainly patients with complex anatomy, probably a lot of patients with heterotaxy that are reasonable candidates for biventricular conversion. Thank you so much.
Okay, our final speaker for this session will be Dr. Christian Kreutzer. He's the Chief of Congenital Heart Surgery, Hospital Universitario Austral in Buenos Aires, Argentina, and he'll be speaking about lymphatics and Fontan Kreutzer, commandeering the other vasculature.
So, thank you very much. It's really a pleasure for me to be here today, especially after the quality of the lectures. It's going to be hard for me to keep up with those fantastic lectures that we have today. So I have no disclosures. Okay, here, yeah. I have no disclosures, except that probably the title of the talk, Commandeering, is kind of difficult. I don't feel that I'm a commander of the lymphatics yet. Probably I will get there, but certainly not yet. And actually, I will present to you a lot of failures today. So if you embark in this task, I hope you don't repeat it. So I have to disclose something too, that I'm a part of this fantastic group of people. There is Victor Hraska, Vivek Yortel, Yoav Dori from TOP, and myself, that we call ourselves the Lymphomaniacs. And we have had several meetings through the last 6 or 7 years, and many of the concepts that I'm going to present to you today were developed by the four of us. So single ventricle lesions in 2023 have now, with the modern forms of the Fontan-Kreutzer circulation, the lateral tunnel, the extracardiac conduit, have more than a 25-year follow-up. And it's representing a great triumph of congenital heart surgery because it is allowing survival of 90% of 30 years for the most complex forms of congenital heart defect. So this is really something. The quality of life is reasonable, and we obviously are very concerned at the rate of 10 to 20% Fontan-Kreutzer failure at 25 years. But of course, when we talk about Fontan-Kreutzer failure, please exclude residual lesions. Those are our failure. Those are failure in management. A pulmonary branch stenosis is a failure in management. A subaortic stenosis in a Fontan patient in a late follow-up, it's our failure. So that is not Fontan's failure or Fontan-Kreutzer failure. So there are always two forms in which percentage we can have three forms that we can have the Fontan-Kreutzer system failure or the ventricular failure, but sometimes you have a combination of those. So preventing lead failure is the new challenge. A lymphatic system and circulation are key players in failure. So, and why the lymphatics are key players in failure? Because the Fontan circulation operates up at or above the functional limits of the lymphatic circulations. We have increased lymphatic production by increased central venous pressure, and lymph drainage is also compromised. There's no diastole to produce a sac of lymph into the systemic vein that has the normal biventricular circulation. The central venous pressure, as I said, is high. And we know by experiments done in the 90s that there is complete cessation of thoracic duct flow at the pressure of 20 to 25 millimeters of mercury. So we have a stasis in the thoracic duct that produces thoracic duct dilatation, tortuosity, valve incompetence. There are valves in every 3 millimeters in the thoracic duct. And of course, these central lymphatics start to have a failure of pumping. But lymph is still finding the way. So early after the Fontan, we have the early lymph complications. There are pleural effusion, chylothorax, pulmonary lymphatic edema, and ascites. Those are the typical ones. And the late complications, there are effusion, ascites, PLE, bronchitis. These are the tip of the iceberg. But the problem is that we have chronic tissue lymphedema. Because while we tend to notice that patients are having PLE or PB, below that, lymphedema is producing a cascade of unfortunate events that eventually will end up in every organ fibrosis. And this is not only happening in the liver, it's also happening in the heart. As Tarek showed us, myocardial fibrosis, diastolic dysfunction, elevated stiffness are present in the Fontan circulation, and there is this pro-fibrotic milieu of augmented MMP and TIMMP. So this is happening in every single part of the human body. And there's a huge improvement in the way that we can evaluate lymphatics with the development of T2 MRI central lymphatics lymphography. This is a non-contrast sequence of magnetic resonance imaging that has a high affinity for aqueous fluids. So we can see central lymphatics, and we can actually classify in single ventricle lesions in 4 types according to the progressive of abnormalities. Type 1 with clearly or no abnormalities, type 2 abnormalities in the supraclavicular region, type 3 abnormalities extending to the mediastinum, and type 4 abnormalities extending in the whole thing. And actually we can see here a very important element that is the thoracic duct. The tortuosity and the diameter in the thoracic duct are also key indicators of how the lymphatic system is functioning. And where does lymphatic complications start? Well, this paper from our friends in CHOP, in which they perform T2 MRI pre-Fontan in every single Fontan completion, and they noticed that patients with high-grade lymphatic abnormalities had 6 times greater odds of developing early complications. So there was, in this patient population, there was increased length of stays and chest tube drainage in type 3, and there was increased mortality and takedown in type 4, suggesting that the patients that have an abnormal or exhausted lymphatic circulation are going to do poorly after the Fontan-Kreutzer. So why not restore normal lymphatic drainage? Well, that actually means decompress the lymphatic system for patients that are going to be subjected to the high central venous pressure that produces a Fontan-Kreutzer. And actually that is trying to put all the lymphatic drainage into the low pressure left atrium that has the low diastolic pressure, the low end diastolic pressure, and has inspiration to enhance the lymphatic drainage. And this is how it looks from the venous side, from the venous catheterization. This is an injection on the left arm. You see a wide patent anastomosis. This is the innominate vein. and you see some flow going up, that is a good sign. That means that you're not getting the compressing from the right side. You can have a lot of shunting from the right jugular vein up to the transverse sinus, going to the left, and then you will have cyanosis. So this is a good result. And if you see here on the left, this is a lymphography doing by gastric puncture of the cisterna chyli, and you see contrast going all the way up into the thoracic duct. And you will see here, you see this smoke here, that is the thoracic duct draining into the innominate vein, and you see contrast getting in here in the left atrium. So there was really this was really amazing in one of the patients that we treated, that there is a lot of flow here, as you can see. So the indications now for this Hraska procedure, Victor Hraska, working in Germany, was the first who applied the concept of thoracic duct decompression to the single ventricle palliation. You can use it concomitant to the Fontan Kreutzer for high-risk patients that are showing an exhausted lymphatic system by T2 MRI lymphangiectasias type 3 and type 4. For early failure, for patients that have an intractable ascites pneumothorax early after Fontan, and the technique for, and also obviously for failing Fontan with PV, plastic bronchitis, PLE, and effusions. The technique for the Hraska procedure is the direct innominate vein with thoracic, with the thoracic duct here, turned down to the left atrial appendage. And there are very important things if you're going to do this procedure. It's going to be very important to analyze the anatomy of the left atrial appendage. The CT angio is performed when if left atrial appendage is not clearly seen in the MRI. You need a big left atrial appendage to do a wide anastomosis. Because what you will need is a wide patent anastomosis with a low risk of thrombosis. If there is a long distance between the innominate vein and the left atrium, well, you can use a ring PTFE graft dunked in the LA cavity, or if there's the diminutive left atrial appendage, then you have to go to the right and ring the PTFE, and the ringed PTFE graft should be dunked in the right atrium. So, but I'm going to tell you later that is probably not a good idea. So, since 2017, all Fontan Kreutzers that are performing in my institution are subjected to a pre-Fontan MRI lymphatic screening by T2 imaging. So 38 patients were included in cohort. The diagnosis included the typical forms of hypoplastic left heart syndrome. We had performed the MRI analysis. We classified it according to the CHOP classification, and we defined 2 pathways of treatment. Group A, that encompasses 26 patients underwent a classic extracardiac fenestrated Fontan Kreutzer, and group B, types 3 and 4, those with the higher abnormalities, underwent the extracardiac conduit with the innominate vein turn down or Hraska. The innominate vein turn down procedures were performed by direct anastomosis or by conduit interposition. There was one early mortality in group A, and there was 1 innominate vein turn down thrombosis and occlusion in group B. There was, interestingly, less volume of effusions in the patient that had a lymphatic decompression. So that actually was one of the most important optimistic factors that we had. The ICU guys were absolutely amazed that we were able to take the tubes out much faster in the group B. So the follow-up now has a median of 30 months. The patency of the innominate vein turn down was assessed by echo, CT, or angio in 12 survivors, but we have 4 complete occlusions, all of them with PTFE conduits. So I don't think with those results that using PTFE conduits for these small, low flow systems or anastomosis, it's going to work. There were no PLE of plastic bronchitis. There was 1 late death in the lymphatic decompression group from progressive right pulmonary vein stenosis. There were no difference between groups in survival, oxygen saturation that was almost exactly the same, and functional status. But I gotta show you a failure. Now it's a patient that is 4 years old and is doing well. He's a hypoplast, atrial atresia, aortic atresia, mitral atresia, status post in our hospital, the Norwood, attenuated at the bidirectional gland at 5 months, complicated by hylothorax. And we know that hylothorax is a risk factor for failure, for late failure. 3 years of age, pre-Fontan cath, normal PA pressure and end diastolic pressure, good PA anatomy, multiple collaterals were embolized. A pre-Fontan T2 MRI showed type 4 abnormalities. So he underwent a Fontan completion with denominator event turned down, an event for procedure, extubated in the OR, chest tube removed, then the third postoperative days, SATs in the low 80s. So everything was happiness until in the sixth postoperative day, prior to discharge, suns went suddenly up and the patient started with shortness of breath. And we have to put the chest tubes back on and start leaking like crazy. 180, the second day, 450, 780. It was easily to notice this left cervical venous ingurgitation. So we took the patient to the OR, see normal Fontan pathway and pressure, but if I can have the video on. Oh, wait. No, I can't be on. Oh, sorry for that. Oh, there it is. I got you. You see, this is complete occlusion by thrombus. So in this case, the remedy was obviously worse than the disease. So we obviously did this procedure. And what we noticed in the revision that we noticed as the left atrial appendage had a neck. So the left atrial appendage was big enough to allow us to do the anastomosis, but it had an stenosis in the middle of the body of the left atrial appendage. So pay attention to the anatomy, another very important thing. So the patient was discharged and he's doing very well 1 year after that. In CT angio, there's complete occlusion of the PTFE conduit. And obviously the patient was in oral anticoagulation. So what is the criteria for failing Fontan with PLE and effusions? Well, at least the patient must have preserved or mildly depressed single ventricle function and normal end diastolic pressure. The thoracic duct has to be patent, of course, the cervical veins as well. Ideally, it should be to the left. The right thoracic duct with the right gland requires conduit interposition. The rationale of this procedure is restore normal lymphatic drainage, but once the leak is present, once we have PLE or plastic bronchitis, probably it won't stop after decompression. And the reason is because duodenal pressure is around 8 millimeters of mercury and can be negative at some times. And for plastic bronchitis, airway pressure is negative. So I cannot compete with negative airway pressure with a pressure in the left or right atrium of around 8 millimeters of mercury. And we reserve the lymphatic intervention, in the contrary as our friends in top. We always perform the lymphatic intervention secondary to the thoracic decompression. That is embolization of lymphatic collaterals for plastic bronchitis or embolization of lymphatic collaterals for PLE. And we have experience in 4 patients with PLE. First patient was a 5-year-old that had 2 years after the Fontan presented with a massive ascites and PLE and massive effusions. So the patient had bilateral SVC. We performed the right gland takedown and AV valve replacement. The albumin levels went up, improved. Unfortunately, these patients suffer from late death for acute pulmonary hemorrhage at 6 months of follow-up. Another patient with heterotaxis syndrome that had all of these patients have CHOP type 3 abnormalities. 9 years after the Fontan presented with ascites, presented with effusions, and the one Nebraska with extra conduit change. He's alive, working normally at 5 years of follow-up with normal albumin. This is really a success. A patient with 53 years old with transcapital atresia performed by Billy. That is a real Kreutzer procedure. 36 years after a Fontan presented with massive ascites, PLE, no effusions. She underwent the Fontan conversion and Nebraska, had normal albumin. Unfortunately, this patient died 2 years after the procedure for pulmonary hepatitis. And the last patient is one of the patients that I want to present you as a case report. Is mitral atresia, double right ventricle, 15 years after Fontan, presented with ascites, effusions, PLE obviously, and underwent the Nebraska and an extracardiac conduit change. So she is status post atrial septectomy and abandoning as a neonate, bidirectional glen at 8 months, extracardiac conduit Fontan Kreutzer at 3 years of age with a 16mm conduit. He had normal RV function and mild TR, restricted atrial septum. So by 11 years of age, presented this restricted atrial septum. So underwent 4 surgery, atrial septectomy at another institution, no conduit change, good recovery, normal albumin. 17 years, when she was 17 years old, 2 years ago, ascites and PLE relapse, chronic diarrhea, very low albumin catheterization. We found small extracardiac conduit with a discrepancy of IVC 26mm conduits 14, normal Fontan pressures 13, normal end-diastolic pressure 7, normal PNE anatomy, INT2 MRI, she was a type 3 with a thoracic duct of 6 millimeters in diameter, that's very dilated with severe tortuosity. So 5th sternotomy, extracardiac conduit to 22, innominate vein turn down, an eventful recovery, discharge home on 7th postoperative day, oral anticoagulations. 3 months later, albumin levels were improved. We were very happy. But this patient presented episodes of anxiety. She was mentally unstable. And we had questions about the adherence to the oral medications intake. So 6 months later, severe diarrhea leaking 1.5 liters a day. She was readmitted and cath. And as you can hear, the anastomosis is wide, but it's full of thrombus. So we take, obviously, she was treated by a stent, but in tandem stents, as you can see here, and we were able to regain. And look how this vein is decompressing, and that vein completely disappears after the anastomosis is patent again. So again, after cath, an eventful recovery, discharge, huge improvement of symptoms, albumin levels were improving. Again, same thing, severe diarrhea, and now the patient is having Fontan pathway thrombosis and innominate vein thrombosis. So 6th sternotomy, redo innominate vein turn down, Fontan pathway thrombectomy, now PLE relapsed, embolization percutaneous 2 times, and now she's listed for heart transplantation. This is our experience with plastic bronchitis that is quite positive. It's only 2 cases that both of them are alive, and one needed, a cath intervention to embolization of lymphatic collaterals, and the other patients did not, and he's alive and well 2 years after the decompression. For intractable effusions, we have experience of 3 patients. One patient that was 14 years after Fontan had ascites, and it was very, and even though his catheterization in the measurements were okay, he continued to have ascites all the time. He was very distressful for the patient, so he underwent the Nebraska and extracardiac conduit change. He had a conduit of 18, but of course, since we opened the chest, we decided just to change the conduit. So this patient is alive and is completely asymptomatic, and he does much improvement of ascites. The second patient is a patient that presented initially we did a T2 MRI pre-Fontan, and he had type 2. But soon after the Fontan, he was presenting with intractable effusions. And we took him to the cath lab. Everything was quite well, but we did a new MRI, and now he was type 4. So his lymphatic system was reacting very badly to the new circulation. So he underwent a Nebraska, and he obviously the ventricle in a condition after 14 days of ECMO, he was presented ventricular dysfunction, and this patient ended up dying in the hospital. And the third patient is a patient that was done at another institution. 4 months he was on a ventilator, 4 months after the Fontan, never got out of the ventilator after the procedure. He had massive ascites, he got pleural effusion, he was leaking between the ascites and the pleural effusions around 800 milliliters per day. So he only underwent HRASCA, and this patient, this is a chest rate pre and post HRASCA. This looks like magic, but it worked perfectly in this patient. The patient was discharged on a tracheostomy and unfortunately died of viral pneumonia 2 years later. So prophylactic lymphatic decompression is possible at Fontan completion. The results are promising for patients that are presenting and already exhausted of abnormal lymphatic system. We don't know if we're going to ameliorate fibrosis or reduce the lymphatic complication with this approach. For late lymphatic failure, our motto is first restore normal drainage, then intervention, then percutaneous intervention. For early Fontan-Kreutzer lymphatic failure, effusions or ascites, it might have a role, I'm sorry. Thrombosis and occlusion is the villain here. The nominate vein turn down must be perfect. This anastomosis must be perfect. So much here we have to pay attention a lot more to anatomy, especially the anatomy of the left atrial appendage. The anticoagulation must be stricter than expected, and probably PTFA conduits are a bad idea in this situation. And of course, you need a multidisciplinary team for diagnosis by MRI, understanding by cardiac catheterization, the unique physiology by lymphatic catheterization, I'm sorry, of the lymphatic circulation. Thank you very much.
Okay, while we're waiting to see if there are any questions on the chat, any questions from the audience?
I was wondering, there are many patients that we take care of that have a left SVC to a coronary sinus, and if the thoracic duct may be draining there, we tend to go and coil it and close it in the cath lab. Maybe we should start thinking for the future and leave that connection to the LA as a potential lymphatic decompression. Yeah, comments.
Yes, but the problem is that most of those patients have heterodoxy. And in heterodoxy syndrome, you can have the thoracic duct to the right. So you have to be sure which way goes the thoracic duct. That is an idea that Mark Gevelig is having, to doing one gland instead of two, and trying to band to have more flow to the side in which you have the gland, trying to band the left or right internal jugular vein at the time of the gland. Never done that, but I think it's good thought.
Yeah, thanks for a great session. Last two were awesome. A question for anyone, because there's really no right answer. Just like to hear people's opinions. The idea of biventricular conversion or VAD for delaying transplant obviously come with the risk of increased sensitization in patients who are already sensitized, and then they just wait longer for transplant and may not have options. So how do you guys feel about that conundrum and balance those risks and benefits?
So, yeah, I think the issue of, I mean, most transplant centers, I think throughout the country, you have a sick Fontan, Fontan-Kreutzer. I think 99% of those patients will end up in the OR table getting a transplant or getting a VAD. They need it. Obviously, we only put VADs in patients who need a VAD, or they're going to die. So we have very little option there. You know, we need to, in some of these patients, they need to be somewhat, the VAD for them might be a way to improve their overall state, you know, before transplantation. So the sensitization piece is real, but, you know, I think we're always in a very tough position when we have to put a VAD on a single ventricle. Okay, but we do it because, you know, we're forced to. You know, the biventricular conversion, I think that there are a lot of patients out there who have a Fontan-Kreutzer circulation because their anatomy where they were seeing was too complex for the team. And you know, I think a lot of these surgeries require a pretty senior person who's been around the block, who is willing to tackle some of these issues that early in your career you're just not ready for them. You know, and I think, I mean, at times I remember going to conference and, you know, national conference and seeing patients presented who are single ventricles that I would say that patient could have had a different operation and be biventricular. But I know that in that center, they wouldn't do that operation, and the patient ended up with a single ventricle. So some of those patients might get into trouble and come to institutions like this kid that I presented, and we say, okay, I think we can do this. I didn't present the other patient who soon after this one, I took to the OR to do the same thing. And unfortunately, I did all the steps, but I just couldn't put an RV to be a conduit on that patient. It just anatomically was impossible. And I didn't truly appreciate that pre-op. But so I took everything down, fixed everything, and then I had to undo everything. And thank God the patient did okay. And you know, but it's now back on the transplant list. Okay, so at times you have to go and fail. You know, you have to give it a try. At times it's an issue of giving it a try. But you know, these are very difficult patients, and there's no right answer. You do the best you can, and I think every center tries to do the best they can.
Can I say something?
Yeah.
The only thing for me that it's not advisable to do is to jeopardize the way of the transplant. Because if you try to recruit a left ventricle and you end up with pulmonary hypertension, then it's not a good idea. So the decision should be made earlier, because I've heard that there are some surgeons around the world that they are doing this they're reversing the ventricle. So they are doing a double switch, and they will end up with a patient that has a small left ventricle. So probably the compliance for exercise would be bad. And if you had a small left ventricle in the pulmonary position, and they will have a right ventricle in the systemic position with a sending and an arterial switch. And probably a sending is one of the procedures that we abandoned because it was full of arrhythmias. So you have a systemic ventricle with a sending, with systemic right ventricle with a sending, and you end up with that because the patient is not even a candidate for a transplant. So I think that the decisions of going to recruit a left ventricle, especially for borderline left ventricle, should be done really early in life. And if you fail, go back and open the ASD and decompress the left atrium. So because this patient probably is going to go to a Fontan pathway, and eventually we will need a transplant.
And you know, the other thing that goes unsaid is that not every country has transplantation as an option. So, I mean, we're sitting here thinking like, well, you put them on the transplant list, but you can't do that.
I can't.
You can't do that. So you have to do all these other surgeries that you know, people might be sitting here and say, well, why did he do that 5 times? So because there's really no other option. You know, if you don't try, but those are our realities, and we all have to accept our realities and do the best we can with our reality, you know?
And some patient realities, some patients, and Matt may comment, they're terrible transplant candidates, right? Whether because they're social issues or whether because they have huge antibodies and they're just not transplant. The wait time would be forever, right?
Yeah, this patient.
I was wondering about for those complex biventricular repairs, Victor, what do you think, does it help you to have a 3D model to look at the anatomy before to figure things out? And is that something that you think should be done?
Without a doubt. I mean, we've been doing that probably for the last few years, certainly for the complex transpose with that get repair, we certainly do the 3D reconstruction. And I think for this really complex biventricular repairs, for sure you need it.
Thank you. First of all, I'd appreciate if I don't have to accept my reality, but we can move on. I remember seeing a video from one of your lymphomaniac friends showing decreased peristalsis, I think it was, of lymphatics in the context of a calcium channel blocker. Has there been any exploration of medications to improve lymphatic function?
Well, that is a question that we have to ask Vivek Yortal, that has these huge lymphatic laboratory now in Copenhagen. She had a laboratory in Denmark. There are few medications. Unfortunately, the medications that we commonly use, for example, Lasix, decrease the lymphatic function. And the other thing that Vivek is thinking, and probably I will take the responsibility of speaking in her name, is that every single human being has a different circulatory system. The lymphatic system of every single one of us is different. And some lymphatic systems are able to tolerate much better the high central venous pressure than others. So probably through genomics, we will learn which patients are in danger of a lymphatic complication in the future. And we see, for example, patients that have a Fontan circulation in place for 20, 25 years. We do a T2 MRI and it looks normal. And we say, but come on, it should be type 4 and it's normal. And we don't know why, because the central venous pressure is high. Another patient with a central venous pressure of 12 has a complete disaster with a very, the thoracic duct very dilated and very tortured. That is an indicator of failure, for example.
But, we were discussing earlier, I think, we do cath in all these patients, but we really don't study their lymphatics pre-op. And one thing is, they get into trouble, it's okay, you're looking for what's wrong, but it'll be more interesting to look at patients, before the Glenn, you do a study, you look at their lymphatics, and maybe for the Fontan, so that we get data about these patients, because we keep dealing with the same, we keep talking about this, which I think is a tremendous concept, and lymphatics clearly are important. And we better put some, studying into them, because, they cause a lot of issues for us. So it's something that, we certainly need to consider here.
And for example, we know that transposition of the great arteries, we used to see a lot of chylothorax and in pleural spaces that we do not open. We see that in Down syndrome patients after complete AV canal, we see chylothorax. And probably that is obviously a genetic disorder. Well, that genetic disorder was described. I'm sorry, I forgot the abnormality. But so those patients are keen to lymphatic complications. And probably we are not knowing who are the ones that are going to develop these complications. So I think that can be a game changer for the future.
All right, everybody, thank you for an excellent discussion. That'll be the end of this session. Next is the research highlights.
All right. So before we close out, we will present our winning poster and research abstract. In the interest of time, we have Chow Jaraswarapam from University of Indiana, who is an assistant professor in gastroenterology, hepatology, and nutrition. And he's from the Riley Hospital for Children's at IU Health. Talk to about his research in biomarkers of fibrosis and portal hypertension of Fontan-associated liver disease in children and adults. And after we close out, we will all be heading to the 4th floor terrace for drinks and hors d'oeuvres. So please keep that in mind. I'd like to present to you as our certificate and appreciation for your work. And we will also have a cash prize that we will send to you later.
Oh, thank you so much. All right.
Hi, everybody. My name is Chow. Again, I'm a pediatric hepatologist from Riley Hospital, Indiana University. So today it's my pleasure to present my research on the cardiologist today. So I have nothing to disclose. So first, so you know already that a post-Fontan patient always have a hepatic fibrosis, even though cirrhosis over time that we call it the Fontan-associated liver disease. And only liver biopsy is only gold standard to assess liver fibrosis, and they have no standard non-invasive biomarkers to assess liver fibrosis so far. So our research is investigating non-invasive biomarkers of fibrosis and portal hypertension in children and adults with Fontan liver disease. So this study is a retrospective chart review Fontan patient more than 10 years old who underwent liver biopsy. Liver biopsy scale, we use congestive hepatic fibrosis score. 0 is mean no fibrosis, 4 is mean cirrhosis. Advanced liver disease defined as score 3 or 4. We also measure non-invasive fibrosis score, we call AST to platelet ratio index, APRI, or fibrosis 4, we call FIB4. This non-invasive score in the adult hepatologists, they used to assess liver fibrosis and cirrhosis. In other liver disease like Hep B, Hep C, or fatty liver. For April calculation, we use AST and platelet for calculation. For FIB4, we use AST, age, platelet, and ALT for calculation. We also measure the feature of portal hypertension, varices, ascites, splenomegaly, and thrombocytopenia that we call VAS score. And VAS score more than equal to is means significant portal hypertension. We also measure cardiac cath parameters like Fontan pressure, hepatic venous pressure gradients, calculation, which is the difference between weight and free hepatic venous pressure. We also measure liver stiffness from the FibroScan as well. The first data we show you is in the middle column is non-advanced liver disease. We have 27 patients, and advanced liver disease, we have 39 patients. You can see the age or the time of the Fontan. They look similar in both groups. One thing that you can see is lower platelet is shown significantly in the advanced liver disease. We also found FIB4 APRI also higher in the advanced liver disease, significantly compared to non-advanced liver disease, as well as Fontan pressure, weight, and free hepatic venous pressure. Interestingly, you can see hepatic venous pressure gradients is we always use in the hepatology world that if more than 5, it means significant portal hypertension. And you can see both groups, they are very low, only 1.1 or 1.14. For FibroScan, we measure liver stiffness. Normally it's 5 to 7, and you can see both group is really high. Again, we don't see any difference significantly between the two groups. We also separate between adults and children, non-advanced and advanced liver disease. You can see similar to previous table that age and Fontan pressure, they look similar. Again, lower platelet, FIB4 APRI, Fontan pressure, weight, and free hepatic venous pressure also higher in advanced liver disease. For children, you can see the result is contrast, but we have only 6 in non-advanced liver disease and 13 in advanced liver disease. One thing that we found is age at the Fontan procedure is older in the patient who have advanced liver disease. Otherwise, there are no difference between these two groups. We compare between like VAS score that I mentioned before, less than 2 or more than equal to is means significant portal hypertension. You can see that lower albumin is significantly lower in the whoever have high VAS score, as well as higher fibrosis score, FIB4 APRI, Fontan pressure, weight, and free hepatic venous pressure. And you can see gradients also higher significantly in whoever have a high VAS score. Again, for the fibrosis from liver stiffness, they look similar in both groups. Conclusion. So APRI or FIB4 is maybe non-invasive biomarkers for Fontan liver disease progression, and lower platelet or higher Fontan pressure is observed in adult with Fontan advanced liver disease, but not in children. Liver stiffness from FibroScan is very high due to hepatic congestion and possible liver fibrosis. Portal hypertension in 4 you can see is caused by both elevated venous pressure and liver fibrosis. So I would like to thank my mentor, Dr. Jean Moloston, and adult hepatologist, Dr. Masuoka, and our cardiology team from Riley Dr. Mark Cam, Dr. Mark Payne, Andrew, Jessica to help me for this project. And right now we have ongoing multi-center for registries. If anyone interested, please let me know. Thank you.
Well, everybody can smile. We came to an end. Okay, so everybody survived, and hopefully our lymphatics are still working well. Okay. With that said, it's a fascinating topic. Clearly, we went from the heart to the liver to the lymphatics. It's a complex problem that doesn't have a simple solution, which is fascinating because it means we'll be having meetings like this recurrently for the next 100 years, discussing this topic and many others that might arise as we hopefully solve some of these issues. We want to thank everybody online. We want to thank Billy Kurtzer for taking his time and spending a whole day with us here. It's been a real pleasure, like always. And want to thank everybody out there in the audience, online.
Yeah, especially wanted to thank in the audiovisual, James Ferris with Massive Media, the Congenital Heart Academy for transmitting to people all over the world and improving access to great conference and all the amazing work they've done over the last few years. Also, our course coordinators, Katie Scollon, Andre Kinnunen, and Andrew Beckhout, because they really did an amazing job supporting this. And the three physicians who truly developed the program, Anita Saraf, Tarek Al-Said, and Arvin Hoskopal for putting this together. This was terrific when they came to me with that idea to us, and we supported it. So thank you for doing that. And especially amazing presentations from people who came from other locations to visit here in person, and those who presented remotely, really outstanding presentations. Thank you so much for all of that. It truly, I also learned a lot. So thank you.
Thank you. Thanks.
Hello. Reminder that cocktails are on 4th floor.